Good morning, everyone. Thank you so much for being here. We're very happy that you're joining us for our third and last day of MPHC 2021. And as usual, before we get started, we will go ahead and read the disclaimer. So the information provided by the National Pre-Health Conference through the following webinar is for general informational purposes only. All information in the webinar is provided in good faith. However, students should seek competent advice for issues related to their specific circumstances. We will make no warranty, express or implied, regarding the accuracy, reliability, or completeness of any information. And this is just to let you guys know that we do work really hard to put this information together, but as always, reach out to your mentors and people who are closer to you to be able to get advice that is the most helpful to you. And now I will go ahead and, sorry, one second. Yes. So as I mentioned, thank you so much for all of you for being here. Welcome to the last day of the second annual National Pre-Health Conference. Our theme for today is special topics. So for today, here's a glimpse into what we will have in store for you. First, we will have racism in healthcare and health equity with Dr. Lauren Powell. After that, we will have making an impact with ovarian cancer survivor stories with the Minnesota Ovarian Cancer Alliance. After that, we have scientific communication in research and medicine with Dr. Vincent Rasaniello. After that, we will have emergency medicine in rural hospitals with Dr. Fernando Cortez. After this session, we will have how Instagram can help you build your dental practice with Dr. Bill Dorfman. We're very excited to have Dr. Bill Dorfman and all of our other speakers. After that, and it's kind of included in the same session, but we will have Garrett Howley talking about channeling passions and health advocacy through social media. And he's a famous TikTok star. So for all of you who use TikTok, feel free to check him out. Later, we'll have mindful wellness using mindful practice for stress management with Dr. Alexis Arsinski. And finally, for our last session, we will have volunteering abroad with the Africa Mercy with Ruth Welm from Mercy Ships. And at 2:30 p.m. Eastern Standard Time, we will have MPHC Kahoot with our MPHC team members, Ruhi and Jacinta. So please join for this session. And this is a little bit of a more informal session where we will be able to play together and get to know all of you a little bit more. So we really encourage you to check it out if you wanna get to know other MPHC members and students. So now we will go through some logistics, and my co-president and co-founder, Alexia, will go over some logistics. Oh, so sorry about that. Some logistics of the Zoom webinar. I'm just gonna screen share. Oh my God, I'm so sorry. I don't know what's going on today, but every time I screen share, it goes to the wrong place. But here it is.
No worries, Alejandra. Thank you for the introduction. To go over just some quick logistics for the day, if you look at that black bar at the bottom of your screen, you should see a few features. The most important feature for today is the Q&A feature. So at any point during the session or after the session that you would like to ask a question to the guest speaker, go ahead and click on that button and type in your question. And either the speaker will type their answer after the session is over, or the host for that session will ask your question live during the Q&A session. Next, we have the polling feature. At the end of every session, Alejandra will release a poll to ask you and gain your feedback on that session. Raise hand. If you'd like to ask a question verbally and live to our guest speakers, please raise your hand and we will call on you to ask your question. And then of course, using chat. For general respect, please just use the chat respectfully. We have people of all backgrounds from all over the country joining us today. But feel free to use the chat at any point to express how you're feeling during the session. And if you have more questions to the National Pre-Health Conference team, you can also use that as well.
Awesome. Thank you, Lexi. So now I want to thank again all of our wonderful media sponsors who were able to help us promote the event and also are providing some resources for you guys that we'll talk about more later. But these people basically are the ones who made MPHC possible. So we really thank all of them, and we hope that some of you got to know more about them through the tabling sessions that we've been having. So we really appreciate our sponsors. And if you have any questions about our sponsors, we encourage you to go to the MPHC website and you'll see the same image here, and you'll be able to click on each of the logos to get more information and learn more about each of the sponsors.
All right, so these are some exciting surveys that we have for you today in the last 2 days. First is the feedback survey. If you would like to receive a certificate of participation for joining the conference these last 3 days, please fill out the feedback survey, which will be provided to you after the conference. Once you leave that webinar, it'll redirect you to that survey. If you don't receive the survey, send us an email. We will also send out an email over the next few days to remind you to take this feedback survey if you'd like a certificate. Also, we have had one pre-conference survey. So I'm doing my thesis on the National Growth Conference at Arizona State University, and I sent out a pre-conference survey to all of our attendees about a month ago. And so if you can receive that email and you completed that survey, you will receive a post-conference survey from me over the next few days. And if you have completed both of those surveys, you are eligible to win a free t-shirt, sticker, and or Amazon gift card.
Awesome. And now we're very excited to announce our MPHC t-shirts that we will be selling through our website. Feel free to check that out and buy shirts for you. So sorry about that. I think there were some technical difficulties. Can everyone hear me again?
Yes.
Okay, perfect. some small technical difficulties, but anyway, I was saying we have MPHC merch for all of you. So please check it out on our website and let us know if you have any questions.
We have some exciting free resources for you just for joining the National Pre-Health Conference today and the last 2 days. We will send a link in the chat with these free resources and also a viewer slides link, so you can click on these resources. But Kaplan, one of our sponsors, and their guest speaker also joined us yesterday. They are giving out a scholarship for one of their MCAT courses valued at $2,499. And the deadline to sign up is August 7th at 6:45 p.m. Eastern Time. So don't wait to get on that and fill out that form once we send you the link.
Awesome. And similarly, we also have one of our other sponsors provide free resources for all of you. So this one, as long as you sign up through the link that we will send, you will be able to access all of these things. So you will have access to this ultimate guide to the MCAT cars, more on-demand webinars that you can check out, blogs and resources, and an initial consultation if you're interested in checking out the services that BMO provides. So we'll be sending that on the chat shortly, and we'll also add it to our website under pre-health resources tab. You will have access to these links, and also any other free resources that our media sponsors provide for us.
We have 5 platforms that we are present on: Instagram, Twitter, Facebook, LinkedIn, and Discord. Check out all of those and make sure to join us, especially Discord. I will be sending out free resources after the conference throughout until the next year. And you also have the opportunity to meet other members in the MPHC community. So I highly recommend joining Discord and following us on all of our platforms.
Awesome, very exciting. And now we want to say that today we will present the winners of the Research Expo Certificates of Achievement. We will have our 3 main categories: Best Presentation and Most Innovative. These two, the MPHC team will decide. And then the middle one, Audience's Favorite. This one was voted by the attendees of the Research Expo. So we will announce who was the winner of the Audience's Favorite Award. So stay tuned at the end of today.
We are also having a virtual gallery, which includes all of our presenters and some other MPHC researchers, and their research will be posted on our website. So make sure to check that out after today.
Perfect. And lastly, we want to encourage all of you to check out our program guide. This will give you more information about the MPHC team, all of our speakers, or most of our speakers, sponsors, and overall all the sessions that we will have, and more information about everything you need to know about MPHC. So feel free to check it out. And now I will go ahead and start the Pear Deck again. So just a reminder to everyone, Pear Deck is a tool that we use to be able to gather more information about you in a way that helps us get to know you better. So please, I will show some instructions and you will be able to join Pear Deck. Oh, so sorry about this. This always happens. Give me 1 second. I will be joining through my account and it's ready to go. So I will screen share again. So please go to the website, joinpd.com, and very shortly we will have our own code so that you can join our session. Okay, there it is. So go to joinpd.com, and then click the code section and type RGAFSC. So I will give everyone a few seconds to join. So I see we have 10 students right now, and there's more in the participants. So please join whenever you get a chance, because we want to get to know you better and interact a bit more. So awesome. I will give it a few seconds because I see students still joining. All right, so I will go ahead and start the class, but please remember that the code is up here, and also our co-founder Lexi has added it to the chat, so check it out. And I'm gonna go ahead and skip to our questions. Perfect. So at this point, you should see a question asking to place a dot where you're from. So please put a dot in the map wherever you're either located right now or where you are originally from. So we want to see where everyone is watching from. So we have some responses. I'm going to go ahead and show them and overlay. Nice. So we see people all over the world, some in India, some over here, almost all continents. So that's very exciting. We're very happy that you're here today. I see some from Mexico. That's awesome. That's where I'm from. So welcome everyone. And from all over the US, very exciting. And I'll go ahead and move to the next question. So where are you in your education? I know that MPHC encourages students from all walks in life to come and join our conference. So right now, we'll get a glimpse of everyone's education that are watching the event. And we welcome all of you, regardless of whether you're in high school or undergrad or after college, whether you took some gap years, everyone is welcome here. So let's see. So we have some high school students. That's awesome that you're here, getting an early start. Undergraduate, first year, awesome. Second year, third year, postgraduate student, parent or guardian. That's really awesome that you're here and hopefully can share some useful information to your kids, faculty, or healthcare professional. That's really awesome. And I really like seeing all the diversity of our participants. Yesterday during the case study session, I met with some postgraduate students. Some of them were doing their masters, and it's just really cool seeing everyone here from all walks of life. So next question is, what are your interests? And if I remember correctly, this was in terms of your career. So MD, public health, all of that. So let me start showing responses. So medicine, we have a lot today and a lot in general. I do know that about 70% of MPHC participants overall who signed up are interested in medicine. So that's really cool. No physician assistant or nursing today. And I guess, psychiatry. That's awesome. We hope you enjoyed Dr. Crystal's presentation. And also public health. We had a session yesterday at 7 that we had to move from day 1 to day 2. So we hope that you were able to watch it. But if not, we encourage you to check it out on the YouTube channel. And this one is the wrong day. So now, which sessions are you looking forward to most on day 3? So we have racism in healthcare, making an impact, science, communication, and research, emergency medicine, building your social media platform, challenging passions and health advocacy, mindfulness, and wellness. And I'm gonna go ahead and take a picture because once we get to the numbers, I'm gonna forget most of these. So I'll give everyone a few seconds to put it in the chat. And yeah, just to give a little bit of context, day 3, we have special topics that hope will make you a more well-rounded and just an overall better healthcare professional in the future. And we'll discuss some very important topics such as health equity and all of these here. And it's different to the other sessions that we had on day 1 or 2 in a way that it's a little bit less structured. As you see, we have a lot of variety of topics, but we hope that all of you are enjoying and will enjoy today. So I'm gonna go ahead and share. So 1, 2, 3, 4, 6, 7. It's a lot. 1, 2, 3. Awesome. Number 3, science communication. That one we're very excited about. Awesome. Mindful wellness, science communication and research. Yes, Dr. Asuniello is he has a very famous podcast on virology. So we hope that some of you have had a chance to check it out. And if not, we encourage you to join and learn more about him. And mindful wellness, yes, 1 through 7, awesome. Social media, yes, Dr. Dorfman also is very famous in social media and just the Hollywood world in general. So we encourage all of you to check it out. Awesome. So we have a lot of different interests today. So I know we're getting close to our next session. So I think this is it for today. And again, welcome to everyone. Welcome, regardless of your background, regardless of what your interests are. We hope that you can learn a lot today. And just as a reminder, please fill out the feedback survey and keep anything in mind that you think we could do better, anything that you enjoyed, or anything that you would want to see in future years. We really want to hear your feedback. That's why we've been sending a lot of polls this year. And we really encourage you to tell us what you think you like so that we can make this better in the years to come, because MPHC will be back from now on. So we really want to try to make it a better experience for everyone. So now I will go ahead and leave this page and introduce our first session of today, our first guest speaker session. So we will have a 4-minute break. So we will start at exactly 10 a.m. Eastern Standard Time, but please join us in about 4 minutes for Dr. Lauren Powell's presentation, A Legacy of Racism in Healthcare. So we're very excited to learn about this. And I will send out a poll to just get your feedback from the intro session, but please come back in a few minutes and we'll go ahead and get started. Thank you so much.
Hello, everyone. My name is Ruhi Sahu, and I'm a student at The Ohio State University. Today, I'm excited to welcome Dr. Lauren Powell to lead a session discussing racism in healthcare and health equity. Recently named among Fortune's 40 Under 40 in healthcare, Dr. Lauren Powell is the president and CEO of The Equitist. As a founding leader of The Equitist, she helps systems and leaders move from embracing health equity in theory to action by noticing and intervening in oppressive forces that operate within people and systems. Her professional and personal experiences spearheading equity efforts in healthcare make her a nationally sought leader on all things health equity. Attendees, feel free to put your questions in the in the Q&A section throughout the presentation, and please welcome Dr. Lauren Powell.
Well, thank you, Ruhi, for that lovely introduction. And good morning or good afternoon, depending on where you are in the world. Hello to you, and thanks for the opportunity to participate in today's really great conference lineup. I'm going to share my screen so we can get to my presentation. Gosh, Google Slides always messes me up. Okay, so this morning we're going to talk about the legacy of racism, race-based treatment in healthcare. My name is Dr. Lauren Powell. I invite you to follow me on Twitter or on LinkedIn if you are on either of those platforms. And today we're going to talk about really the history that has really led to what we see today is racial health inequities and the history behind that. So I first want to start with, to start with understanding the history here, we really have to go all the way back to the bottom of the map. We have to go all the way back to the beginning of Africans in this country. That was 1619 when the first enslaved Africans arrived in America in what would come to be known as Virginia. So slavery was an openly accepted commodification of bodies from 1619 until technically until 1864-ish, 1863. But in 1807, something really important and interesting happened. There was an act that was passed that specifically prohibited the importation of slaves. Now, prior to this, African bodies and African people were moved from across the continent and were part of the transatlantic slave trade, which I'm sure you all have heard about, which was transporting slaves from Africa and other West Indian countries to other European countries, right? So this act in 1807, though, said that technically you could no longer import slaves. First, let me just ground you in the fact that we're talking about people. So we're talking about humans that were essentially trafficked and moved around as commodities. So that's the first thing to think about. But the second is that the importance of this act meant that slave owners had to actually take really good care of the people that were within their jurisdiction. So they could no longer say if a slave got injured or grew older or was just not malnourished or not taken care of, they couldn't just trade it out for another body. So this was a very important act that led to an invested interest in slave owners making sure that they took care of their slaves. And that is actually the foundation of what would become our healthcare system. So I'm going to fast forward just a little bit, because in that moment, then there was an invested interest, as I said, in slave owners recognizing the importance of taking care of their slaves. That meant that women became extremely important in making sure that they could actually procreate, which is where we get several of the procedures we still use in obstetrics and gynecology, which I'm going to talk about in just a few minutes. But it also, all of that in the commodification of Black bodies, right, really created the foundation of what we would come to know as eugenics and scientific racism. That was the idea that there was an inferiority in certain races based against the superiority of the white race. and that the goal was to ensure that that those races would not necessarily procreate, and that there were specific standards that would show you the difference between the value in those different races. And so, sorry, wrong way. And so some examples of that, eugenics really projected the idea that some people were born to be a burden on the rest, and that there were certain groups of people in society that were less important and less able-bodied than others. Oh gosh, why does that keep happening? And so what we see here is an example of eugenics. So taking, for example, the shape of someone's nose, the size of someone's nose, the size of someone's head, or cranial size was used to determine superiority and inferiority. Really important foundational notions of what would become scientific racism, but that would also bleed over into the ways that we treat different people when they seek healthcare today. We can fast forward. I'm taking you through some vignettes, so we can also fast forward into modern medicine and the history of experimenting on Black bodies, and how that has continued to have an impact even in the more modern centuries. I hope that you all know who this woman is. This is Henrietta Lacks. Henrietta Lacks is an African-American woman who's really credited as being the modern matriarch of medicine. She her cells were actually taken from her when she was seeking healthcare several years ago. She was seeking care for cancer. She had cervical cancer, and her cells were actually extracted, which was a common practice during that period of time. But her cells were extracted for the use of science, right? But what people didn't realize is that her cells would go on to become the first line of immortal human cells. And they are actually still alive today. October will mark the 70th anniversary of the discovery of the HeLa cells, which you may have used in laboratories or in lab experiments if you have been a bench scientist. If you've used HeLa cells, they are credited to a Black woman, Henrietta Lacks. Her cells are still alive today, but the resurfacing of this story, which happened maybe about 10 or 12 years ago, the resurfacing of this story and really attributing HeLa cells to Henrietta Lacks has very much sparked a remembrance in the Black community of the many ways that Black bodies have been exploited for experimentation purposes, and to build the foundation of our healthcare system. So a couple of these instances and a couple of these illustrations here I've already mentioned. We're going to start in the top, my left corner, so maybe your right corner, but here where we see the woman who's sitting on the table. This is a illustration, if you will, of the ways that Black women became such an important foundation of the healthcare system, mostly against their will. This is an illustration that really speaks to J. Marion Sims, who some of you may be familiar with. He is heralded as the modern father of gynecology, but it is said that he created many of the procedures that we still use today in obstetrics and gynecology, but he created those on using Black women. So remember when I said the Importation Act, the act that prohibited importation of slaves in like 1807, that gave slave owners an important incentive and reason to maintain the population of people that they already had, and to make sure that women in particular were able to bear more children and were kept healthy and well in order to do so. This is a direct example of how that built our healthcare system. So J. Marion Sims is heralded as the father of gynecology. He is accredited with so many different procedures that are still used today in modern obstetrics and gynecology. But it is said that he discovered those procedures, if you will, by experimenting on several Black women, several African women who were slaves. And it said that he did his procedures on them without the use of anesthesia. So one example in one prolific woman that it is said he experimented on over 40 times without the use of anesthesia. So I want you to think about what that means for the foundation of how healthcare came to be in the United States in particular, but also with global implications. That one, several of the procedures and some of the advances that we have today, many of the advances that we have today were built on Black bodies. Second, that understand that these experiments were done with no anesthesia. So there was already an ingrained thought that somehow Black people, that somehow slaves and people of African ancestry did not feel pain or could tolerate pain in a very different way. Remember that, because we're going to come back to that. And I'm going to show you some modern day examples of how that still remains a problem in healthcare. The next picture we see is just examples, a couple of them actually, of the ways that Black bodies were actually experimented on in the use of anatomy and physiology in medical schools, right? So you're all probably very familiar, as you're pre-health students, with some of the requirements for medical school and for other professional healthcare professional training is anatomy and physiology. And so now there are very strict standards on how specimen and individuals might donate their bodies to that. But long before those policies were in place, there were very often frequent circumstances of grave robbing, where medical schools, Medical College of Virginia, Medical College of Georgia, there's a history in several of our medical schools and training grounds that there was a habit, unfortunate habit of robbing graves, specifically of Black cemeteries. So of course, segregation and the separation of society was still very prolific at this point, and there were white cemeteries and there were Black cemeteries, and the Black cemeteries would often be robbed, and bodies from those cemeteries would be taken to medical colleges and medical universities, excuse me, and would be used for anatomy and physiology. And so you see that there's ongoing a constant betrayal, if you will, in the Black community in particular. And the Black community is not the only one, in which somehow this group of people constantly became kind of the foundation for our healthcare system, and many of the procedures and lots of the learning that has happened over the years. Many of the medical breakthroughs have been at the expense of the use of Black bodies. And the last picture, here's one you may have seen before, and if you haven't, I encourage you to learn much more about it. It's referring to the study of untreated syphilis in Black men at Tuskegee University. Now, this is often pointed to most frequently as being the biggest example of the lack of trust that many African Americans still have in the medical system. What happened in this study is that there were a cohort of Black men in Tuskegee, Alabama, who were not necessarily who were monitored essentially for their exposure to syphilis. Now, when a treatment was actually penicillin was actually discovered, like a period into this observational study, which is really what it was, that treatment was not offered to these men. And so syphilis can be deadly. Syphilis can cause blindness and congenital defects and lots of different challenges. And these men were just kind of followed and watched and monitored, but there was never an intervention to provide them with care that we actually know would have saved them. And just for some context, I mean, this went on for 40 years. It was not until the 90s that then President Bill Clinton actually apologized to the last living men of the syphilis study at Tuskegee University. He actually rendered them an apology on behalf of the United States. And this was also a study that was carried out by the United States Public Health Service Corps. So this was carried out by the government. And this, by and large, really is a very big illustration that's compounded by all of these other examples I've given you, which, by the way, are only one of a few of a few hundreds, if not thousands, of examples of the ways that the healthcare system has not always been welcoming to people of color. If we fast forward a little bit more to the early 2000s, we have very concrete evidence of the ways that racism still continues to play a role in healthcare outcomes. In 2003, the then Institutes of Medicine, now the National Academies of Science, Engineering, and Math, I think, Congress commissioned a study to really look at health disparities and health inequities. That created this really deep expose, if you will, called Unequal Treatments Confronting Racial and Ethnic Disparities in Healthcare, which basically elevated the fact that racial disparities exist and health disparities exist because of racism, that there are documented examples of how African Americans who presented with diabetes were offered amputation more often and unnecessarily as opposed to their white counterparts, how so many other chronic conditions go undertreated in African Americans, that when we control for all of these other variables, socioeconomic status, education, and so many other variables, that we still find that there's a difference in health outcomes, which tells us that it has to do with racism. It not only has to do with racism, but it also has to deal with mistrust. And mistrust is really not just about what happened 40 plus years ago. And let me remind you that, again, most of the, when we talk about, for example, like the lack of confidence in the vaccine or vaccination, COVID vaccination, a lot of the points and examples that people point to are from the study of untreated syphilis at Tuskegee University, right? And that was 40 plus years ago. But we don't have to look that far into the past to see examples of how racism continues to play out today and in healthcare, and how that engenders a consistent kind of narrative in not even narrative, a consistent need, a reason for mistrust in certain communities. So I pulled just a couple of examples, and these were actually from a couple of months ago, but example of a man who died in a parking lot after the hospital refused to treat him. How COVID-19 has had a disproportionate impact on Black men, on young Black men, and how racial data around COVID vaccines really did not include Native Americans for a very long period of time. And so mistrust is, again, it's not just about what happened 40 plus years ago. We don't have to look that far into the past. We can look at the ways that African Americans and people of color have to navigate society today to see that the lack of trust that is in other social systems also has an impact on how people view the healthcare system. But I actually think there's an opportunity for us, and you all as pre-health students and with an interest in making a significant impact on health outcomes and healthcare, there's an opportunity here for us to shift our focus from mistrust to trustworthiness. Mistrust really is about suspicion. It's when you don't have confidence in something, and mistrust to me is a very it is a very individualistic perspective on something. So to me, when we say that Black Americans or African Americans have mistrust in the healthcare system, to me that says that it is somehow on this group of people who has been wronged and exploited for so many hundreds of years to find a way to trust a system that has never really made themselves to be worthy of trust. Alternatively, I think we have the opportunity to shift our focus to trustworthiness. That is, how do we build healthcare systems? How do we build healthcare leaders who are worthy of our trust? That is, they have the ability to be relied on as honest or truthful. What would it look like if we had a healthcare system that was actually trustworthy and that was then worthy of the trust of a group of people, people of color, marginalized people who have been exploited and harmed by these systems previously. The impact of biased treatment in healthcare and the mistrust, the lack of trust in the healthcare system has truly been debilitating and continues to be a challenge today. We know that there is a disparity in inequity really in why Black men in America have worse health outcomes than white men. And that extends to Black women as well and women of color as well. We know that racial bias and pain assessment and treatment recommendations are still a problem and a challenge. Remember, when I went back and talked about J. Marion Sims and the ways that he experimented on his subjects without the use of anesthesia, and that set a precedence, right, for the fact that Black people may not experience a false belief that Black people may not experience pain the same way. We see very modern examples of that as recent as 2016, I believe, that a study, this study actually, about racial bias and pain assessment and treatment recommendations that continue to underscore false beliefs about biological differences between Blacks and whites, and really thinking somehow that Black people have thicker skin, that somehow can tolerate pain more readily than white people and white patients. And that medical mistrust racism also contributes to delays in preventative health screenings among African American men and women. So the impacts of biased treatment in healthcare, the impacts of racism, and a legacy of racism in healthcare continues to impact us even today, even in the midst of the global pandemic that we are also navigating. One of the most challenging and heart-wrenching, I think, examples of this was the case of Dr. Susan Moore. Again, if you are not familiar with this case, I would encourage you to Google it and read about it. Dr. Susan Moore was a Black woman. She was a doctor who died of COVID-19 after complaining of racist treatment, of experiencing racism as an inpatient in the hospital. What happened is she actually filmed a message from her, what would then become, unfortunately, her deathbed, saying that she felt like the white male doctor who was treating her was downplaying her complaints of pain. Remember the connections to pain that I have already kind of explained in several ways throughout this presentation, that he thought that she was downplaying her complaints of pain and suggesting that she should be discharged. And he made her feel like a drug addict and so many other things that she articulated in her video. The scary part, I think, for many in the Black community was to consider, if a well-educated Black woman who's also a physician was treated in this way, what would the rest of us experience? What could the rest of us experience? So again, the ways that a legacy of racism continue to have a real-time, modern-day impact on health outcomes. Dr. Susan Moore unfortunately passed away in December of 2020. I want to remind you that this happens everywhere, not just in healthcare. I'm sorry, I'm trying to move my comment out of the way. I'll get to your comments in just one second. That this happens everywhere, not just in healthcare. And I want to remind you and very much center you on the fact that it is racism and not race that is the culprit here. Often, and incorrectly, people associate race as being the problem. It's not the problem that we have a lot of different types of races and ethnicities in this country. It's a problem that there's a system that classifies the way that those people should be treated and the value of those lives. And so I want to just remind you that it is racism as a system, as a construct, that is the problem here and not race. Finally, I want to leave you on a high note and give you some things to think about. I like to end with solutions, right? We know that racism, the legacy of racism, is a problem in healthcare. That you, as the future leaders and future professionals of health and healthcare and public health and mental health and everything related to health and wellness, you have an opportunity to shift the history of what the system has been into something much better. How can we do that? I think you can do that through health equity. Health equity really requires us to wrestle with racism and systems of power and privilege. That means if we're not doing that, then we are not working on health equity. If we are overlooking kind of the intrinsic powers of community, if we are not clear with ourselves about the ways that racism, homophobia, transphobia, xenophobia, sexism, all of these other isms and forms of oppression are operating within our systems and also within society, and we are not actually working on health equity. Health equity, for your reference, is when all people and communities have the opportunity to attain their full potential and highest level of health. Very, very important note here. If you remember nothing else from this presentation, please remember that equality is not equity. Equality is not equity. What we see here is a graphic from the Robert Wood Johnson Foundation. And by the way, the Robert Wood Johnson Foundation is a very powerful entity in the public health and healthcare world, very big philanthropic arm of healthcare that really focuses a lot on health equity. What we see in this graphic is on the top, we see equality. On the bottom, we see equity. Equality is giving everyone the same thing. So what we see is people on the top with differing needs getting the same thing, the same amount of resource, allocated in the exact same way, regardless of the fact that their needs are different. And because they have differing needs, but have all been given the same thing, they can't all take advantage of the resource that's been given. In fact, what we see is the person who is most privileged, actually, we only increase their privilege through the lens of equality because we're adding to the leg up that they already had. What we see on the bottom is equity, though. That is people with differing needs getting exactly what they need. And because they're all getting the resource that they need in the way that they need it and the amount that they need it, they can all make use of the resource that's been given. Equality is not equity. If I put it to you another way, I happen to like shoes. If I put it to you another way, equality is giving everyone a pair of shoes, but equity is giving people shoes that fit. When we think about health equity, that is our goal. How do we make sure that we are allocating our resources, that we are tailoring our approaches, that we are meeting communities and individuals right where they are to ensure that they can all meet and attain their highest level of health and wellness, and that we are giving them the resources that they need in the ways that they need it at the time that they need it, which will also mean that some communities will need more than others, right? That is equity. Equity is not equality. What can we do to stop racism in healthcare today? Racism has recently been declared a public health crisis that we have been navigating in this era and in this moment, two deadly pandemics, right? COVID-19 and racism. So what can we actually do to stop racism in healthcare treatment? I'm glad you asked because you are the future. And so I hope that you will take note of this. Detection first, I think I can break it down into 4 Ds. One is detection. So leveraging data to highlight the problem. Now we have to be careful here though, because leveraging data means that we leverage it for the use of action, right? That means that we are smart and we are mindful about the ways that we are collecting data, about what data we're collecting, and ultimately we use it to power us into action so that we're not necessarily reinventing the wheel. We're not constantly investigating a problem that we already know exists. We know that racism is a problem in healthcare treatment, that racism contributes to healthcare outcomes, that racism is a social determinant of health. We know that. So how do we leverage the data that we have now to highlight the problem, but then move us into action? It will take discipline. We have to have real accountability for healthcare leaders who are clearly found to have bias in the ways that they treat people, that clearly are shown to be racist, that are clearly are shown to perpetuate the disparities and the inequities in the healthcare outcomes we continue to see. There must be discipline for that. disciplinary action. 3, there has to be dedication. We have to dedicate time, resources, and people to combat this issue. We're seeing an explosion of leaders in health equity, leaders in diversity, equity, and inclusion practically in every institution in the United States. I think that's wonderful. But the question is, do those leaders have the resources that they need to actually make sustainable change? So we have to be dedicated beyond this moment, which I hope doesn't become just a flash in the pan. But we have to be dedicated in the long haul, so that when people like you, when you are as young healthcare professionals, when you become our leaders, that we are still dedicated to this issue. And then finally, determination. We have to have long-term commitment to change. This is not going to change overnight, but we have to be committed to the long haul. I'll leave you with a quote that I think is very important from activist, scholar, and leader, and writer, I think, James Baldwin. Not everything that is faced can be changed, but nothing can be changed until it is faced. It is my hope that we continue to face the ugly ways that racism has impacted healthcare outcomes, but that we find ways to fix that. We find solutions to that. And that ultimately, I'm so inspired by you all. I wish you nothing but success and perseverance as you move towards your goals of being healthcare leaders, because we need you to help us continue to face these issues. Thank you.
Thank you so much for all your insight, Dr. Powell. We can go ahead and start our Q&A. So if you would like to stop sharing your screen.
Yes, thank you.
Okay, so we have a couple questions, so I'll just read them out. Our first question is, do you consider possibly the fact that these medical researches made back on Black people may be taking place again now to learn more about the human body against a person's will?
So the question is, if I'm understanding it, do I think that, oh, I can see the Q&A. Okay.
Yeah, you should be.
Thank you. Do I think that it's possible that this could happen, this could be happening again? I do think it's possible. I think that, I hope that it's not happening again, but I do think it's possible. I think that because we have not been as, I don't know, I think we haven't had the hard conversations we need to have about racism in this country. We have not really worked to overcome and change the future by kind of dealing with the past. I do think it's still possible. I think that our healthcare systems are not teaching about the ways that Black bodies, and not just Black people, but the disability community, the LGBTQ plus community, Native American communities who have also been exploited by science and healthcare. We're not teaching about that. So until we're actually making sure that that's a core part of the curriculum, that's a core responsibility of learning, that you have to have mastered these competencies to be healthcare professionals. I think that this will be possible until we really hold people accountable for their actions, until we require that they show that they have mastered and understand the history so that they don't repeat it. I do think it's possible, unfortunately.
So just to follow up on that, are there any classes in medical school that you know of that focus on things like ethics and race at a larger scale?
Yeah, thanks for that question. It looks like Leslie. Thanks for that question. So I should say I'm not a medical doctor. I did train at a medical school. So I have a lot of friends who are med students and a lot of friends who are doctors. But I think that there are some medical ethics courses. By and large, a lot of schools are starting to incorporate classes on the social determinants of health, which will kind of get at some of this, but not super precisely. There are bioethics courses that may get closer to the opportunity to explore. And there are some medical ethics courses, but I'm not sure that they are deeply rooted in medical schools. I think medical anthropology might also be another lane to explore there. But there are a lot of schools that are really trying to um, they're trying to find their way on how to include more of this information in their curricula. And I just honestly, I hope that this becomes a core requirement. Understanding health equity and understanding social determinants of health. This has to be a core requirement for any pre-health student and for any future practicing healthcare provider.
I completely agree. Another question we have is, someone asked, as a white woman willing to be a physician, how can I contribute more to an equitable treatment of all patients that does not depend on race?
Yeah, this is a great question. And I appreciate these questions rooted in allyship and really wanting to be a real ally. I think I always start first with educating yourself. I think it's important to take the onus. Google is a powerful tool, right? There's so much you can learn there. There's a lot of factual history you can read about, webinars, podcasts. I mean, videos, it just goes on and on, documentaries. I really encourage you to educate yourself first and foremost, and to not put the onus on people of color to help educate you. I think it's important to have intelligent conversations with lots of different communities and people from lots of different communities, but don't put the onus on them to educate you on these challenges. Second, I would say, speak up in classroom settings, speak up in private settings. And that's the hardest. Speak up in conversations with family and friends, and really put put racism and put oppression into context for people. Third, I would say, find ways to learn from your patients and learn from, those patients that you will come in contact with, and recognize that that is a significant part of learning as well. And finally, I just say, remain open to knowing that you don't know everything. I remain open to that as well. That's a commitment to cultural humility. That means that I recognize that I can never be competent in one culture, including my own, and that I constantly remain open to learning that what I thought may have been, fact and truth, may not actually be so, and be open to new perspectives.
That's amazing advice. Our next question is, what skills did you need to deal with racism in healthcare when you were studying for your PhD?
Oh, this is a really, really good question. Thank you. Rana, I think. Hopefully I said that right. My apologies if I didn't. I think there are several skills. I think tenacity. So, like being a graduate student of any kind, being dental student, a medical student, a PhD student, a master's student, being a student of any kind, you need tenacity, right, for the coursework and for all of that. But I think specifically as a Black woman, I needed tenacity to navigate everything else that came with being in a largely white academic setting. So I needed tenacity. I needed strategy. I think that is, being strategic is really an underrated skill. And I think as people of color navigating academic systems that are largely ivory tower-esque, you have to be strategic about making contacts, about finding mentors, about finding support systems. I think strategy and being strategic about who my allies were, and actually finding allies was really important. And then I think, I don't know, I think finding community, finding community outside of just my program. I was the only Black student in my program for 4 years. It's a very hard time to be the only Black student anywhere. It was 2012 through 2016. And so if you think about what was happening during that time, this was the genesis of the Black Lives Matter movement. This was the murder of Trayvon Martin, the murder of Michael Brown, the murder of Freddie Gray. I mean, there were a lot of flashpoints that were just so significant in kind of the modern Black liberation movement, if you will. And it was a hard time to be the only Black student in a program. So I had to find community elsewhere. Um, I had to hold on to my friends and my family and people who knew me best in places where I could vent and just be honest about what I was feeling. But then I think one other skill I'll add here is transparency. Like sometimes it's not always on us, and I don't want to put that on students of color, but sometimes there is an opportunity for you to just be, very transparent and almost just raw about how things impact you, because unfortunately there are so many in our institutions that just have no frame of reference. And so at points, if you are comfortable with that, if you feel emboldened to be transparent about the ways that racism have impacted you, which I very much was towards the end of my time in graduate school, I want to encourage you to know when you have the power to do that and know when to leverage that in a moment. But above all, I had to really embrace self-care, because I could only be the leader that I am. I still have to embrace that now. I can only be the leader that I am when I have the energy and I have the mental capacity to do so.
Thank you. And in your answer, you mentioned the Black Lives Matter movement. So have you felt that the BLM movement has reduced racism in healthcare at all, or do you think it's made no impact?
Oh, that's a tough one. I think Black Lives Matter has elevated, it's placed the impacts of racism on top of mind. It's made it top of mind in ways that I'm not sure any other movements in modern day really have. The combination of social media, the combination of it being a hashtag, but then growing into a decentralized movement is something that's very powerful. It's very unlike the civil rights movement, which was more centralized and was really had like very specific leaders. But Black Lives Matter is very different, and it has provided a way for lots of people to plug in, and lots of people who may not have plugged in if it were a centralized movement. So I do think it has definitely had an impact on healthcare institutions. Has it reduced racism in healthcare? I'm not sure. I'm not sure that that's been the case yet. I think it would take some time and some data to actually show us whether that's the case. But I think elevating this and making it a like household conversation. It's a tabletop conversation now with a very recognizable brand, for better or for worse. And I think that hopefully helps, it helps keep this at the forefront of the conscience of America. And for that, I'm very grateful. And I do think it is having a strong impact on the nation and the world.
Awesome. So the next question is for our attendees watching. Do you have any books or reading recommendations off the top of your head to learn more about healthcare disparities in the past and present?
Yeah, there are a couple. Most recently, there's a book, The Political Determinants of Health, which is by a colleague whose name just slipped my mind. I'll come back to the title, but it's The Political Determinants of Health. It's really good. There is a book that was written several years ago that's actually I referenced in my dissertation too, Medical Apartheid by Harriet Washington, which really goes through the history of exploitation and experimentation on Black bodies, and is a really important read. There are a couple of books by Thomas Leviste on race and ethnicity in healthcare that has it's like a big compilation, several different chapters. Congresswoman Robin Kelly, who actually leads the Congressional Black Caucus, the Congressional Black Caucus Health Brain Trust. That's right. She is a representative from Illinois, but she wrote the Kelly Report, and it came out, I think, in maybe 2019. The Kelly Report really is a modern day, very modern, probably the most modern day report we might have on health inequities and the impacts of health inequities on the Black community. It's also a compilation, chapters written by several of the nation's leading healthcare leaders, and something else I would really encourage you to check out.
Great. Our next question is a little bit more specific. So someone asked, I'm an attorney who is transitioning to healthcare with an intent on focusing on pain management. I want to run clinical trials and develop medicine and provide care after my experience with an undiagnosed pain condition that impended my life. I'm going to get a PharmD and MPH. Any suggestions for schools or programs with a focus on pain management?
Wow, this is a really interesting question. Thanks, Jaconda. And I love your story, and thank you for sharing so much of it. And I think this is also super important. Pain management is something that is never going to go away, especially, unfortunately, as we think about COVID-19. The people who survive COVID-19 often have a lot of things to manage, pain being one of them. Unfortunately, maybe for the rest of their lives, we're not quite sure yet. The data hasn't totally shown that, but certainly a field that is never going to be out of need and necessity. I don't necessarily know any specific schools or programs, but I think that this will be an increasingly important area, especially as we think about the ways to manage pain, but also thinking about like the overprescription of pain medication, which really contributed greatly to the opioid crisis. So I would think that there are several MPH schools or schools of public health, as well as medical schools, who would offer some specific guidance on that. You may also think about if there are some fellowships. I know there usually are fellowships and additional training opportunities that are focused on specific kind of disease areas or specific skills. And I think pain management would be one of those.
Perfect. Our next question is, what are your thoughts on pharmaceutical companies that aren't testing vaccines on minorities?
Yeah, so I will also fully disclose that I work for a pharmaceutical company in my day job, but I'm representing the equitist here. And, I think that it's no secret that pharma and just the medical device industry altogether really have to do a better job of diversifying clinical trials, that there have been significant disparities. This is actually what I worked on for my dissertation. I went to graduate school to think about ways to increase the underrepresentation of minorities, or to address the underrepresentation of minorities in clinical research. And so I've thought a lot about this. I don't think it's right. I think that there is a lot of work. There's a lot of room for improvement on better including minorities and people of color in clinical research. I also think we could do a better job including women in lots of different segments of the population in clinical research. But I also think, again, this goes back to part of my presentation when I said, it's not just about mistrust on the side of the community that's been wronged. It's about creating trustworthiness. And how do we create institutions, including pharmaceutical companies and medical device companies? How do we create institutions that are worthy of trust, that have, long-standing relationships in communities, and are ultimately invested in health equity beyond just participation in clinical trials? So I think we have a lot of work to do there. And I'm hopeful that, with the leadership of many of you all who are tuned in today, in the future, that we will get there.
Great. So I also have another question for myself. So as you are a woman of color in the healthcare profession and science in general, have you ever felt imposter syndrome, and how do you cope with that?
Great question. Yes, I have dealt with imposter syndrome. I still do. I deal with it every day. And for those who may not fully appreciate what imposter syndrome really is, It's any feeling that you don't belong. It's any feeling that you're underqualified, that, why would people listen to me? Why should I be the speaker? Why should I be the student selected for this opportunity? It's just at the core of it, questioning your greatness is really what imposter syndrome is. I do still deal with that. And quite frankly, I started the Equitist a little over a year and a half ago. So right before COVID was declared an emergency, I started the Equitist. And since then, I have been really working on imposter syndrome because when you step out and really start to imagine your dreams through an entity you're building yourself, a lot of kind of deeply seated kind of questions about your abilities start to rise to the surface. And I've been actively working on that with some personal branding. I have to actively tell myself some mantras, and I challenge myself, and I actually have to go back and look at the things that I have accomplished to remind myself that I am highly qualified to be where I am. And I have worked very hard to be where I am, that nothing was handed to me. And I worked really hard. So that's how I deal with it. I stay grounded. I stay grounded in people who remind me who I am sometimes when I forget. And I work on staying positive. Like it's easier said than done, but like positivity and manifesting positive affirmations are so important on this journey as pre-health students. You will face many barriers, many twists and turns. Things may not all go according to plan, but try not to question your greatness, and don't question how it all turns out, because it will ultimately turn out just the way it's supposed to.
Thank you so much. I know that was definitely wonderful advice for all of our attendees watching. More specifically, what advice do you have for any students that are interested in spearheading their own health equity efforts?
Yeah, this is great. Thanks for that question. I want to remind you, like, you don't have to be a medical doctor or public health leader, former state, health official to champion health equity. At the core of it, we need equity in society to power us towards health equity. And I think there are several ways you can work on that, especially as pre-health students. One, I think you can, constantly think about in your discussions, in your classrooms, in your community endeavors, even as pre-health students, who are the communities who are not represented at the table when decisions are being made, when interventions are being discussed? Who's not at the table, and how do you find ways to flag that for people and make sure that those people are actually invited to the table? So, basically the mantra, like, nothing about us without us, right? So think about the ways that decisions are being made about communities and the ways that you're talking about communities, even in your classrooms, and call that out. You have the power to do that. Students have so much more power than I think sometimes you even realize. Second, I would say, challenge your studies, like challenge the things that you're learning in classrooms. Bring additional material to your classrooms. Bring the things that are happening every day, current events that are happening every day, to discussions in your classrooms, and start to learn the communities that you are situated in, especially if you end up going to a school that is not within a community that you're from. Learn the history of the community that you will be rooted in. It's so important. And I really hope that becomes a requirement in the future for all of our pre-health programs, and for all of our graduate medical degree and dentistry and all of those. Like, it should be a requirement that you understand the history of the communities that you'll be serving. And then finally, this is going to sound like it doesn't relate, but it really does. So we often kind of underestimate the amount of influence that government and like policy and laws have on literally structuring health. So we talk about the social determinants of health, like a lot of that is decided by like government. So the last thing I'm going to tell you to do is to please involve yourself in democracy. Please be a part of democracy. Please vote. I can't tell you who to vote for. I'm not going to tell you who to vote for, but I would really encourage you to be involved in active part of democracy, an active part of your community, an active part of making decisions about who will make the decisions about policies and laws that govern all of us. So that has such a significant impact on health.
Thank you so much. We have one more question. So this is also from Jaconda. When I grew up, we had Black hospitals because of discrimination. Those hospitals were eventually closed due to integration, but is there an argument to be made for reopening Black hospitals?
Oh, this is a dissertation long question, Jaconda. Thank you for that. I think you could make the argument in several different ways. On one hand, no, because we should be able to hold systems accountable for treating everyone equitably. On the other hand, we have seen that these systems are not capable of that. My concern would be in resegregating hospitals. My concern would be resource allocation, because in the segregated hospitals never had the technology and never had the infrastructure and never had the funding that they really needed. They took better care of their people, but they didn't have the resources they really needed to do it. So I'm actually not sure. I stand on both sides of the fence, depending on the day and in the week. Sometimes I think that Black doctors could do a much better job of taking care of Black patients in kind of in their own solitude. But I also know, because of how this country is created and how these systems work, that somehow we would still be on kind of the losing end of the spectrum because of how resources are allocated. Like, who would then contract to do clinical trials in those sites, and who would be their vendors and supply chain, and like so much that goes into healthcare, and healthcare is so much more complex than it was when our hospitals were segregated, that I fear that Black patients would still lose out, even in a segregated circumstance, because of how resources will be allocated.
We are nearing the end of our time, but thank you so much for all your insight and the wonderful presentation, Dr. Powell. For our attendees, we would love to hear your feedback from the session, so there will be a short anonymous poll that will go live soon. Other than that, be sure to be back in a few minutes for our next session with the Minnesota Ovarian Cancer Alliance. Thank you so much again, Dr. Powell.
My pleasure. Thank you all.
Bye.
Thank you so much, Dr. Powell. And now I just want to remind everyone of the free Kaplan resources and BMO resources. I think we forgot to send this earlier today, but I just put it in the chat. So please sign up as soon as you can. And we will be back in a few minutes for our next session. So stay tuned, and we are looking forward to seeing you.
Hello, everyone. Good morning. For those of you who don't know me, my name is Angela. I'm a student at the University of Minnesota, and I am one of your NPHC hosts. Today, I have the pleasure of introducing the Minnesota Ovarian Cancer Alliance. The Minnesota Ovarian Cancer Alliance is a statewide nonprofit organization dedicated to funding ovarian cancer research, providing support to women and families, educating the medical community, and raising awareness. MOCA has a program specifically dedicated to educating the healthcare community about the signs and symptoms of ovarian cancer so that women can be diagnosed early when the disease is most treatable. Today, I have three lovely survivors who will be joining us to tell us their story. But first, I would like to give the floor to Ms. Stephanie Giuliani, the Community Support Program Manager for MOCA. Let's give a warm welcome to Steph.
There we go, unmute. Thank you so much for that introduction. I am so happy to be here with you guys. And like you said, three amazing ovarian cancer survivors that they're gonna share their stories with you. So I'm gonna share my screen before we get started and do just a little brief presentation on ovarian cancer. So like Angela said, we are a statewide nonprofit organization and we work with women all throughout the state and their families. We do a lot of awareness in outreach. We do a lot of things within the medical education programs within Minnesota. And most importantly, we fund ovarian cancer research. So we are one of the top funders in the nation for research. We've given over $9 million to ovarian cancer research, which we are really proud of. And so I will share a little bit about ovarian cancer, and then I will hand it over to really the most impactful part of this presentation, which is hearing from three survivors themselves. And then I know we'll have time at the end if you have questions for any of those. So just a little bit kind of about the facts of ovarian cancer. Ovarian cancer is the 11th most common cancer in women, but really the big thing that sticks out, it is the deadliest of all gynecologic cancers. It affects women of all ages. The average age is 63, but we have a young survivor network at MOCA. We know that it affects women of all ages. It's not a postmenopausal disease. So there are risk factors when it comes to ovarian cancer. There are some things that can put you at increased risk and some things that can decrease your risk. So some things that put you at an increased risk for ovarian cancer is a personal or family history of breast, ovarian, uterine, colon cancers. Certain genetic mutations, the ones that are the kind of the most common is the BRCA1 and 2 genetic mutation. But there is a wide panel of genes that every woman with ovarian cancer should get tested for. Hormone replacement, more menstrual cycles, increased age. Some things that can decrease your risk is removing your ovaries or fallopian tubes. The new research shows that ovarian cancer actually likely starts in your fallopian tubes. Giving birth, breastfeeding, taking birth control, and tying your tubes. So early detection is critical, but very difficult. A pap smear does not pick up ovarian cancer. There is not an effective screening test. And so that is really our biggest, mission to fund research. And we do fund nationally for early detection specific for that reason. 90% of women do go in and actually report symptoms when they're early stage, but only about 15% are diagnosed early. The average stage for ovarian cancer is 3C, which of course is harder to treat. And so we really need an early detection test. So some of the main symptoms, these are the main 4 symptoms of ovarian cancer: bloating, pelvic or abdominal pain, difficulty eating or feeling full quickly, and then urinary symptoms, either having the frequency to go or the urgency. So these are the 4 main symptoms, which are very vague. Men and women have these symptoms. And so we really say, if you have any of these symptoms, if they get worse over a couple weeks, go see your doctor. And so when ovarian cancer is suspected, these are the following that should be performed: a pelvic and a rectal exam, a transvaginal or pelvic ultrasound, and then there is a CA-125 blood test. The normal range is 0 to 35. Unfortunately, some women are diagnosed in that normal range, so it's not necessarily an effective tool for everyone. And then very, very important, refer to a gynecologic oncologist. They specialize in ovarian cancer, and there are many studies that show if you are seen by a gynecologic oncologist, you are going to live longer. We work with many in Minnesota. I know there are people from all over, the world right now listening, but we have an advisory committee with MOCA. So happy to share that with you if you want to go to our website. So last, again, I know there's people from everywhere, but if you are in Minnesota, we'd love to have you get involved and yeah, be involved with MOCA. We're a great organization. We do Ovarian Cancer Awareness Month is September, so we are looking forward to that. So I will now hand it over. So I have 3 speakers that I would love to introduce. If you guys all want to share your cameras and put yourself off mute. Good, Catherine, Lori, and I know Nancy. Wonderful. I just want to say thank you so much for being here. This is really the highlight of this presentation, is hearing from survivors. So I think we will hand it. I don't know if anyone prefers to go first. Why don't Nancy? Nancy, do you want to go first? And then we'll hand it off to the rest. And Lori, if you want to put yourself on mute, and I will do the same while while Nancy speaks. Nancy, thank you for being with us.
Well, thank you. And nice to see you too, Angela. It's been a while. My name is Nancy Adsom, and I'm a almost 22-year survivor. And probably next week I get the number 22, and those are really significant when you're a cancer survivor, is to know you just don't forget. So it was actually in 1999, and I was at that time 49 years old, and I was diagnosed with a stage 1C. So we caught mine really early, and I've had no recurrence since that time. So what I kind of like to say in these sessions is nobody wants an ovarian cancer story. Nobody wants a cancer story to begin with. But if you have to have one, I guess you'd pick mine because it was caught early. So in the spring of that year, I was having severe stomach pain and cramping, which is one of the 4 symptoms, which seemed in my mind to be connected to my menstrual cycle, because we all try to self-diagnose to some degree what's going on. And I decided to see a gynecologist, because at that point I hadn't been seeing one. I'd just only been seeing an internist for my annual checkups because I'd been perfectly healthy. I assumed it had something related to menopause, since I must be at that age, whatever that age is. And during that first visit with this new gynecologist, I reported symptoms of intermittent constipation, and I couldn't relate to my cycles, pain during intercourse, and frequent urination. And of course, the frequent urination is another one of the symptoms. So I had 2 of the 4. And actually, when I put this presentation together a few years ago, it had been a long time since my cancer. So I actually pulled my medical records out of the system, so that a lot of these words were right from the doctor's notes that I'm speaking this morning about this stuff. So I've really been, as I said, very healthy up to this point. I'd had a tonsillectomy at age 6, 2 vaginal deliveries at age 27 and 35, which should have been a positive risk factor, and a removal of a Gardner duct cyst. So I've been very healthy. So during this first visit, the gynecologist in this order did a pap smear, performed an endometrial biopsy of my uterus, and then did a pelvic exam. So I left the appointment confused and with many questions. I wasn't sure how to handle this confusion in my now health history. Well, a week later, the results of that endometrial biopsy came back, and they called me and said it was showing complex hyperplasia. And I was treated with Provera, a progesterone, for 2 months, and they told me then to come back and they would do another endometrial biopsy. I did as I was told. I've always been a really good patient, but I still had many questions as we went along. So I took it for 2 months, and then I made my appointment to go back, and the severe cramping was still there and actually seemed to be worse with bowel movements and when my bladder was full. Again, notes right from my doctor's notes. I also complained of this second appointment of a lump that appeared just above my pubic bone in my lower abdomen. And I remember telling the gynecologist on this second appointment that I thought we should do another pelvic exam. And his initial reaction was, no, we just did one 2 months ago. And I'm sure he was thinking insurance won't cover it. But he finally did agree, and the pelvic exam revealed a very large 8+ centimeter cystic feeling mass that was quite tender and reproduced my symptoms fairly dramatically. Again, right from my doctor's notes. So at this point, he ordered a pelvic ultrasound and a CA-125, which, as Stephanie already went over, would have been two of the very appropriate things to do. I was just starting to learn that I needed to be proactive and be the leader of my healthcare team. Well, the ultrasound showed that the mass was actually 16 centimeters and needed to be removed, and that CA-125 was above normal. So again, normal is up to 35. I think it was 85, so it didn't seem like it was that much higher in relative to other people. But again, it's not. It can only be used as an additional piece of data. Well, the gynecologist met with me then and discussed what my options were. Now, again, this was 22 years ago, and he told me that he could do the surgery and remove the mass, or he could refer me to a gynecologic oncologist. Now, that wouldn't happen today. Because of people like us speaking out, all these doctors would definitely refer me to a gynecologic oncologist at that point. But at that point in time, I had an option, and luckily I chose the gynecologic oncologist. My surgery was performed 3 days later. And before the surgery, I remember asking the surgeon how long it was going to take to do this surgery. And she told me, I can't remember what the exact time frame was, but she says, if I don't have to do that staging, it will be this long of time. But if we think it's malignant and we do the staging, then it's going to be this amount of time. So guess what? The first thing I asked the nurse in the recovery room was, what time is it? And her answer told me that they had to stage, it must be cancer. So that's actually how I found out that I was a cancer person. Well, following that hysterectomy and the appendectomy, I began the chemo. And at that point in time, there were two differing medical opinions on how many courses of chemo I actually needed. The gynecologist that was going to be administering the chemo felt that 6 courses were the norm, and that's what I should do. But I remembered that the gynecologic oncologist that did the surgery had told me about recent studies indicating that because I was a stage 1C, that my condition only called for 3 rounds, that I could cut my amount of chemicals in half. But it was my decision. Again, another point in recognizing that I was the lead in my healthcare. My husband and I had serious interviews with both of these doctors, and then I made the decision to go with 3 rounds. Well, all this medical talk, I still had a family to tend to, and I had friends that were concerned about me and a future that I hoped would stretch out. And because it's been so many years, I think I've blocked a lot of memories that weren't pleasant. I don't remember fear. I do remember that I couldn't say that C word for a few weeks. And at that time, I felt like I had little control over my life. You get diagnosed, and then you have to be here at this time for lab work and over here for imaging the next day. And there's always something on your calendar eating up what you perceive as your precious lifetime. But what I remember is that what I ate made a difference in how I felt. And I could control that. A lot of things I couldn't control, but I could control what I ate. So I remember I recorded all my meals in a journal. And I remember if I ate protein for breakfast, I was going to feel better. And if I had a box of raisins in my purse when I took my 13-year-old daughter to basketball this afternoon, I might need it, better have it on hand. I could control that. So for the first few years, I continued these follow-up visits with my gynecologic oncologist and gradually brought back my regular gynecologist into the visit schedule. Again, understanding that I was in control of who was my provider and at what point was I going to bring him back, and if I was going to bring him back, or was I going to change? And then that evolved into, after 5 years, my oncologist cut me loose. And that was in 2004. I remember her giving me a pin. It had a teal, it was teal because that's the color of ovarian cancer, just as Stephanie's shirt is indicating for us today. But I remember she gave me the pin, and then as I was leaving, her parting words to me were regarding DNA and genetic testing, and my daughter and my son and my sisters, but I wasn't listening. I just wanted to move on. 5 years, with no disease. She told me I didn't have any more chance of getting cancer than the person walking outside on the sidewalk, outside the window at that point in time. It was only many years later, after listening to many of these fine MOCA speakers that I participate with, that I paid attention and went in for genetic counseling and then the testing. And I was happy to find out that I was negative for BRCA, and my kids, as well as my extended family, were grateful that I did complete that assessment. It also showed me how important family medical history is. We do a lot of family history with all these, just send in your a drop of blood and they can tell you all about your family background, but family medical background is just as important. And because I did the testing then, I could tell my family to add to their family medical history that Nancy, their sister, daughter, was diagnosed with ovarian cancer at the age of 49. That's all they needed, but they might need that someday. Well, I was really grateful that I requested a second pelvic exam and that the OBGYN changed his mind and agreed to do it. I could feel that mass, and I knew my body, and it was, I think, the key turning point in my early diagnosis. In discussing with him later, he did say he would change the order of the exam to better feel that mass in my stomach earlier. The early diagnosis caught it at a 1C, and it allowed me to reduce my chemo dramatically. So I know there aren't any guarantees going forward, but I've had almost 22 years extra, I think, to spend with my family and with my community, and to help in this message to our medical people, to other survivors, to caregivers, how important it is that this community rally together. There's one piece that popped up afterwards. There's always the chance for complications down the road. And though it was never described to me or even mentioned as a possibility, I developed lymphedema 14 years after my surgery, which means that all the lymph nodes that were removed from my body to stage the cancer, my body was missing them. So my right leg swells up. It's constantly swollen. I have to wear compression 23 hours out of the day. And I have very specific routines I have to go through to keep it under control, but it's chronic and it's progressive. And, but I'm alive today. But there's always little giddy up hitches along the way. So just another thing for me to be proactive about. So thanks, Stephanie. Thanks, Angela.
Thank you so much, Nancy, for sharing your story. We greatly appreciate it. Lori, do you want to share yours next? And then Catherine can go last. Perfect. Thanks, Lori.
Sure. First of all, I want to congratulate and thank you, students, for choosing healthcare as a profession. We need you. We need good healthcare providers. I've been a nurse for 45 years, and it's not an easy road to take, healthcare, but thank you for choosing it. I could be the poster child for a saying that goes, ovarian cancer whispers, so you must listen carefully. And that means the patient and the providers. There's a reason that 90% of women say that they had symptoms early on, and only 15% of them get caught early. We need to make people, healthcare providers, more aware. And the funding that MOCA gives to research is very important, because we really need a test that we can give women. We don't have one now. So my journey started when I was, like Nancy, 49 years old, which is considered a young age, actually, for ovarian cancer. And in July of that year, I started having changes, bloating, constipation. I just didn't feel right. I just knew something was wrong with my body. I went in, and it was get more exercise, eat more fiber, take Miralax. Okay. It didn't go away. It got worse. And now I was getting up at night, needing to urinate, because somehow it just felt like my bladder didn't have the capacity it used to have. So in September of that year, I went in again, constipation, bloating, and now urinary frequency and urgency. Well, you're 49 years old, you know you're going to start seeing some changes in your body. Get exercise, eat fiber, take Miralax. In December of that year, I noticed when I put my black pants on to go to a Christmas party that I've always fit, and I hadn't gained weight, there was 3 inches between the ends, which was just seemed strange to me. And I just was feeling more and more. Now I had the sensation that if I ate, I couldn't take any more. I just got full really fast. Well, we'll make an appointment for you. The appointment was in mid-January. By this time I had turned 50. When I went in mid-January, the provider that I saw said, Lori, are you pregnant? And immediately did a pregnancy test on me. Also, this time did some more extensive testing with the CA-125 and an ultrasound, and saw a mass about the size of a cantaloupe. And no wonder I couldn't get my pants together. That was on a Friday, and I was in surgery on Tuesday. But like Nancy, I went under anesthesia not knowing, because ovarian cysts are common and they can get really big. So, but I said I didn't want a biopsy because I knew it needed to get out of there. It was causing so many problems. So I went into surgery not knowing either. I did not have a gynecological oncologist available to me in my community. I could have gone down to Mayo, but it was more important to me at that point to stay where my family was, so my family didn't have to make this 5-hour trip. But my oncologist was affiliated with Mayo and was using the Mayo protocol. So I felt safe. Looking back, I should have gone to Mayo, but I did. So they did the surgery. It took about 4.5 hours. a GYN surgeon did the surgery, an oncology surgeon did the staging. When I did wake up, the first thing I asked, of course, was, what was it? And I was told that, yes, in fact, it was ovarian cancer. And also upon the pathology report, found out it was also uterine cancer, a different cancer. They were just happening at the same time. So after about 3 weeks of recovery after surgery, I did go through 6 chemotherapy treatments. And that was the most scary thing for me. In hindsight, I look back, and I was a nursing instructor at the time. I had been a nurse at that time for like 30 years, and I had never taken care of one patient with ovarian cancer that lived. And that was my base. That was my frame of reference. So I was pretty scared. But I went through the chemo, and I was extremely afraid of the chemo. That's strong stuff. It's really kind of, in a way, it's strong chemicals, it's poison. And to just watch that go in your body, it's hopefully killing the cancer cells, but you also know it's killing a lot of other things. Of course, you lose your hair, and I ended up and still have peripheral neuropathy because of the nerve damage that it did. But it was a very scary time. And it kind of hits home that this is a journey. It's not just from diagnosis to the end of surgery. Then you're going to have chemotherapy, and you have to have support and good healthcare providers during that. And even afterwards, I have had issues that had been caused from chemotherapy, and it's been 16 years now, or 17. And so I still have those issues. One thing, a story I always like to tell, especially to healthcare students, is that when I was working, I was a nursing instructor, and one of my students had finished her program and needed to take her state exams, and she didn't have the money. And she was going to be a really good nurse. And I said, here's the money, take your exams. You need to get out there and start working. And she said, oh, well, I can pay you back the first paycheck I get. I said, nope, your payback to me will be the best nurse you can be. Well, that had happened probably 15 years prior to my diagnosis. And I remember sitting in this big chair. It's kind of like a dentist chair when they give you chemo, being scared to death that first time. And I was told that the oncology nurse would come in, and she would start my treatments, start the IV, and get the meds running for the treatments. I was almost paralyzed with fear. I was more afraid then than I was even prior to surgery. And when the door opened and the nurse walked in, it was that girl. And so remember, everything goes into a circle. And as a healthcare provider, it'll come back to you tenfold. So good luck in your profession. And remember to listen closely to your patients. We all know when something's wrong with our bodies. And so listen, because ovarian cancer whispers, and you have to listen carefully. Thank you.
Oh, Lori, thank you. That story gets me every single time, as many times as I've heard it. So thank you for sharing. And now I will hand it over to Catherine, and then we'll open it up for a Q&A. Thanks, Catherine.
Yeah, thanks, Steph. Hi, everyone. My name is Catherine, and I was not 49 when I got diagnosed with ovarian cancer. I was 24. So I just passed, in May, I passed my 6-year mark. So not as many years so far, but I'm pretty happy. 6 is pretty good for me. So my experience prior to my diagnosis is really similar to Lori's and Nancy's. Cancer that Stephanie mentioned, I was kind of sick to my stomach. I didn't really have an appetite. I was bloating a lot, but this was in conjunction with a breakup that I had. So I'm married now, so I can confidently say that this was the only time in my life I was ever broken up with. So, so it was really bad for me. I had never, like I said, I've never been dumped. So I was really depressed. I was drinking a lot, eating a lot of junk food. So when I had these symptoms, I wasn't really that surprised. I was like, okay, I'll just try to take better care of myself. The other thing that I had at this time, I had a really bad cough, but again, you know, I was kind of preoccupied and I didn't really care. So this was in November of 2014. So my family was going to go to Mexico for Christmas that year. And right before we were leaving for that trip, I felt like I had a urinary tract infection. So I went to a walk-in clinic. You know, I'd had a UTI before, so I just wanted to get it out of the way. You know, go to the doctor, get antibiotics, and go on my trip. So the doctor put me on a 10-day course of antibiotics, and I went on my way to Mexico, and I had a terrible time. I was still super bloated. I was still, you know, sick to my stomach. I couldn't go to the bathroom. I was actually so bloated that I had stretch marks. So like, I didn't want to do any of the activities my family was doing. And so while I was sitting inside by myself, my entire family was, you know, whispering to each other, wondering if I was pregnant. So that was really fun for me. We got home, and my mom was, you know, we'd been together for like 8 days, and she's like, you need to go to a doctor. You look and seem just terrible. And I agreed. You know, I had these terrible stretch marks. I was humiliated. I was super tired, and I could barely go to work, much less do any work. So I went to urgent care because I had the doctor that worked at that urgent care clinic was a family friend of ours. So I wanted to go to someone that I trusted. And his first thought was that I was pregnant, like my family all thought. And, you know, knowing my recent history, I knew that I was not pregnant, but I did a urine test anyway, and it actually did come back positive. And I was like, no, that's actually impossible. So what is going on here? And he's like, I don't know. So he sent me to get an ultrasound, and they did confirm that I wasn't pregnant, but that I did have what they called something in there. That was the exact words they used. I was like, great. So obviously this was expanding outside of the urgent care setting. So I went to my primary care hospital the next day, and they did a CT scan. So that was a little bit more detailed, obviously, than the ultrasound, and that showed that I did have a mass on my ovary on my right side. So they scheduled me to see an OBGYN. I didn't have an OBGYN. I would just go to, you know, family practice for all my checkups and pap smears and stuff. So this is the first time I'd ever been to an OBGYN. And she kind of said the same thing. I had a mass, but they hadn't, you know, opened me up. They hadn't done any biopsies, so they weren't going to say what it was or what it wasn't. So I had that appointment. She told me that she would send my chart to a gynecologic oncologist. There was only one in the health system where I was getting treated. So she was sending it to her, and they would schedule my surgery to take out my mass for 2 weeks after my current appointment. But if the gynecologic oncologist reviewed my chart and thought I should get my surgery sooner, they would do it the following week instead of 2 weeks from then. They didn't move my surgery up, so I was like, wow, it must just be like an ovarian cyst or something benign. But I did still feel really tired. I was really cold all the time. My skin was super itchy and flaking off. But again, it was December, maybe January at this point. So I was like, it's not that big of a deal. It's just winter. So I was living with my parents then, since I was kind of just so weak and everything. I was living with them so they could take care of me. And I woke up and my legs were just kind of like mottled with purple and red. It was like really gross to look at. And again, my mom dragged me to urgent care. And again, at urgent care, they didn't really know what was going on, but we explained everything that had happened since the last time I had seen him. We assumed it had something to do with my mass, so I got a steroid ointment, and I was going to have my surgery like 4 days after that anyway, so we didn't think much of it. So like I said, the gynecologic oncologist was the only one in the system, so we had to travel for my surgery to where she was based. I had a pre-op appointment with her the day before, and she, during that appointment, said that I had cancer. I had seen several providers at that point, nurses, doctors, imaging techs, everyone in between. And no one had said cancer. They all were, very kind of wishy-washy about it. So I was really surprised to hear that. No one had said that. They always just said it was a mass. I liked hearing it like that. I liked that she was very straightforward. I was surprised that she could be straightforward. And similarly with Nancy and Lori, they hadn't done anything with the mass. So I don't know how she knew that. I guess just because she had had so much experience, she knew. So I personally really liked that she was really direct with me. It was terrifying, but at least I knew what was going on. So during my surgery, they took out my mass, which was 3 pounds. They said it was about the size of a Nerf football. They took off my right ovary, my right fallopian tube, and then a bunch of lymph nodes. And I spent 3 days in the hospital there. While I was in the hospital, I saw a dermatologist about my skin issues that I was having. And they actually realized that the skin issues with the flaking off and the modeling of colors was actually an allergic reaction to the antibiotic that I had taken for the UTI I thought I had. So she actually said, the dermatologist I saw actually said that I was really lucky that I had cancer. Otherwise, if I never saw a doctor, the allergic reaction would have killed me. So I was lucky I had cancer. And then while I was in the hospital, I was there for 3 days. And I was kind of loopy, of course, following surgery, but the main things that I remember were how kind everyone was, every single person at every single level. I had people coming in and out of my room all the time. It was so disgusting what was going on with my skin. It was just pouring off of me. And everyone who came in my room, from, the housekeepers who had to come in and sweep up all my skin off the floor, they were always so kind to me, never, made a face or anything, even though I knew it was gross. That is a memory that I have. My room was disgusting, and they were just so nice about it and really just caring for me. And the other people that really stick out in my memory were the nursing assistants when I was there. So they had to get me up and get me walking around, and I didn't want to. I was in pain, and again, just so kind, so patient. They're students. I work in healthcare now, and so the people that I work with who are nursing assistants, they're nursing students, or and from all ages, all different backgrounds. And they were the ones when I was in the hospital who made the biggest impact. So after I got home, they had, taken my tumor to stage it. I got a call about the staging of my tumor, and they told me it was stage 3C because they had found cancer cells in one of the lymph nodes that they had taken out. I did not like that they told me that over the phone. I understand not wanting to drag me in to tell me this, in a 5-minute conversation, but it was something really serious that talking over the phone about was really uncomfortable. So knowing that I was stage 3C, I did have to do chemotherapy. And since the gynecologic oncologist was in a different city that was 3 hours away from where I lived, they transferred my care to a medical oncologist for the chemotherapy. So I also had a PET scan, and they did find cancer in that lymph node, but it hadn't spread anywhere else in my body. So that was good news. I did also, in between having surgery and starting chemotherapy, I went to reproductive endocrinology. So those are fertility specialists. Like I said, I was 24 then. I didn't have any kids. I didn't know if I want any kids. I still don't have any kids, but I still might want them. But going into chemotherapy, I knew I could lose the option to have kids from the chemo and then already having one of my ovaries taken out. So through reproductive endocrinology, I did fertility treatments and had eggs harvested and frozen, and they're still sitting there. So, but again, really great experience with the reproductive endocrinology. I know that they have a really tough job with a lot of people struggling with fertility from any walk of life, you know, whether it's just fertility issues or fertility issues related to cancer or whatever it may be. Everyone there, again, really patient, explained everything really well, which, you know, I love because I was super confused and scared all the time. So I started chemotherapy in February of 2015. I had 4 rounds of chemo. Each of them were 3 weeks long. So I would have to be actually in the infusion center, hooked up for like 8 hours a day for like 6 of those 6 days every 3 weeks. So it was really long and super boring, and because most of it was just fluids. But again, in the infusion center, a lot of nurses in there, oncology nurses who were patient, kind, just wonderful to work with, always explained things if I had questions. Same thing with the nursing assistants there as well. I think I probably went through more warm blankets in the infusion center than anyone who'd ever been in there. But they didn't care, they just kept bringing them. One thing that really helped me during my treatment was weed. I didn't use it a lot, but I did sometimes when I was feeling really down. You know, I, again, still had no appetite, kind of queasy all the time, a lot of headaches and fevers from the chemo drugs, and the marijuana did really actually help with those symptoms. It was not prescribed to me. Where I lived, it was not legal to be prescribed to me at that time. But even in the last 6 years, that has changed a lot. And I think that is something that if I were in medical practice, that I would definitely consider for chemo patients. So I had my last treatment in 2015, in May of 2015. And since then I've been going to just having checkup appointments, blood draws with either my oncologist, who I love, or his physician assistant, who also is just delightful. I also, since I was 24 when I got cancer, and I have a really strong family history. Every single one of my grandparents has had cancer or died of cancer. My aunt just got diagnosed with multiple myeloma. So with that strong family history and, you know, me being an outlier, getting it so young, I did have genetic testing done, but I actually didn't have any genetic markers found that are known to contribute to ovarian cancer. So I did that right after I finished my treatment 6 years ago, and I have asked since then if I should get retested, but there have been, even though genetic markers are coming up all the time, there haven't been any new ones identified since my last test. So just thinking about my experience, I was really lucky, kind of like what Nancy said. I mean, my staging was higher, but the type of cancer that I had was very easy to treat. So it was, you know, a very straightforward treatment plan. I had a really supportive family and group of friends who helped me through it. The oncology nurses at the cancer center were incredible. Like one of my favorite memories was, you know, you get to ring a bell when you finish your cancer treatment, and all the nurses came out and, you know, applauded when I was ringing the bell. And actually, when I was at the cancer center for my last appointment this summer, just a checkup appointment, someone was ringing a bell and all the nurses were out there cheering them on. And I was just in the waiting room sobbing because it was, you know, brought everything back. But those nurses just made everything easier. Same with the nursing assistants. And, you know, I had every single medical professional that I worked with was incredible. There's only one person who I didn't really like, who was the person who put in my port. So I had a port for my chemo to go into. So I was under sedation. I was awake, but I was sedated. So like I could hear them talking, and like he was just like talking about, which I understand, like what he's doing that weekend and he should go fishing and all this stuff. And then he was like bragging about how my scar would barely show up, which like you can definitely still see it. That's the only person I didn't like. And that was just a tiny outlier. And I want to particularly call out my mom. I talked about my mom a lot in this because she really was a great fighter for me. She made me go get checked out in the first place. She asked a ton of questions. She went with me for every single appointment. But not everyone has someone like that. I mean, if I didn't have her, I wouldn't have asked even 1/3 of the questions that she had asked or even known to ask. So I definitely wouldn't have been a champion for myself. And I would just, like, my parting thought for all of you is just to think, if you have a patient like one of us who, you know, is really scared, kind of shell shocked, they might not be able to be their own advocate. They may not have someone in their life who can be their advocate. So whether you are their nurse or their nursing practitioner or their nursing assistant or their doctor, just be the person that stands up for your patient and know what's right for them.
Thank you, Catherine, so much. I know Angela will be jumping back on to do our Q&A, which we've had a lot of questions come in. So hopefully we can get to them.
Yeah, thank you so much. Wow. Every time I listen to these sessions, I always cry a little bit. And I know I've heard like Nancy and Lori, I've heard your stories multiple times. So every single time I'm like, it's the reason I want to be a gynecological oncologist. So audience members, please remember you can continue to ask questions in the Q&A box. Also, you can raise your hand and actually ask these questions live. So we'll wait for those to come in, but why don't we start? So one of the first questions we got was, are there any emerging screening tools to detect early ovarian cancer?
Yes, and I see another question too about what research is MOCA currently supporting. So I will kind of answer both of those since I know we have a handful of other questions, but we do fund nationally for early detection specific. We actually fund a researcher in Minnesota, Amy Skubitz, who is one of the leading researchers, wanting to detect early detection. And I know she is looking at blood, or taking a sample in a pap smear. So as we know, pap smear does not pick up ovarian cancer, but I know she is looking at ways that if there can be something in that pap smear that picks it up. And so that's the biggest one. I think people all throughout the United States are looking at that pap smear, if we can add something in there, because the CA-125 is not given, the blood test is not given to everyone. It's only if ovarian cancer is suspected. And so we do fund research though on new targeted therapies, new treatments, recurrences. Recurrence is very high for ovarian cancer. So we are looking at new targeted therapies for especially people who are platinum resistant. So they're not, they don't take chemo, if they recur. So there is a whole wide range of people. We will be awarding new awards this fall. So you can find everything also on our website of our past research and different grants that we've given out. So thanks for that question.
Awesome. I have a little bit more of a personal question from Jasmine. She says, I am 3 years in remission and post chemotherapy. It is so inspiring to hear journeys I can relate to. I wish to continue making an impact with my story as you ladies have had with me today. How do you cope with the emotional aspect of being a survivor years down the road?
I will open, if you guys all want to maybe be off mute, I'll just open it up to whoever wants to answer.
I'll take that first question. I myself doing this helps me cope. You're always afraid every time you have an ache, pain, something goes wrong. You immediately, because you know how much it does reoccur, you're scared. And so you're constantly scared whenever you are going to the doctor because you think something's wrong with you. But the best way I found to cope was to help others and to get involved with ovarian cancer research, with ovarian cancer education. So that's how I do it.
I would agree with that. And if it was not obvious, also humor. I just, I can't take it too seriously. Otherwise I go into a deep, dark place. So I just try to, think about the things that were the good things about it and try to make a joke out of everything else. Maybe not healthy, but that's what I do. That's why I'm a therapist.
And I would add, take good care of yourself. With diet and exercise, there's lots of research on post-cancer rehab, the positive impact that exercise and diet can do. So pay attention, listen to your body, pay attention. And honestly, the diet and exercise is going to make you feel good. That's a plus.
Absolutely good answers.
Amazing answers. Next question is specifically for Catherine. What is the egg freezing process like? My mom thinks that I'll need to do it to have kids as a doctor down the line.
So one thing I know is it's very expensive. For me, since I was doing it as a result of cancer, I qualified for some grants and stuff for the fertility treatments, which was really lucky. And then I was also really lucky that my parents helped with the rest of the cost, because even with the they're not scholarships, but the money that I got through those programs, it still was thousands and thousands of dollars. But outside of that, I think, if I'm remembering correctly, I was taking the fertility treatments for 2 weeks. It was really regimented. You have to take them at really specific times of day. You kind of have to mix them yourself. And just like they, depict it in media, you're stabbing yourself with the little injection. By that point, I had been taking blood thinners that way, so I was really comfortable doing it, but it was scary at first to be stabbing myself with these little needles. So I was doing those for 2 weeks, and you have to go in, I think every other day or every third day to have an ultrasound to see how your follicles are developing, and get blood draws to see what your hormone levels are. And you're doing that so that they can schedule the egg retrieval at the exact right time when you have the most eggs developed. So it's kind of dramatic, and you're in there every day, and they're when it's time, they're all right, go, go, go. We're doing it now, it's time. But I mean, it was super time consuming. Obviously I wasn't doing anything else at this time. I wasn't working or anything, but I can't imagine going through the fertility treatments and working or having kids or anything else. Because I was going to the doctor every single day or every other day. I had to make sure I was doing the treatments at the exact right time. And I would have had to drop everything to go in to do the egg retrieval, which is not super invasive. I was up and moving around and fine immediately afterwards. But, after that, it was I'm really glad I did this. And like I said, I haven't used it yet, but I like having the option. So I am really glad that I did it.
Mm-hmm.
Yeah, I will say off of that, Catherine, and I know there's another question about the uterus. Most women with ovarian cancer do have a full debulking hysterectomy. Uterus, ovaries, fallopian tubes, any other, anything else, which is the biggest thing to decrease your risk, beforehand, if you're looking at that. There is also another cancer within ovarian called primary peritoneal. So even if you do have your uterus and your ovaries removed, the primary peritoneal is like the lining over your abdominal. It's much more rare, but it just does kind of fall in the category of ovarian cancer. So I'm thankful that you had that opportunity, Catherine. So
yeah, the only reason that they didn't take out everything was because I was so young. They wanted to keep as much as they could just in case. So I'm thankful that they did that.
Yeah. And I know we're cutting it close, Angela will cut us off, but those questions that we don't get to, I will respond to you directly. So I just wanted to mention that because I know we won't get to all of them, but I will respond.
Yeah, speaking of time, we are actually unfortunately done. I know you can answer questions. You can type answers to questions if you'd like to do that. Otherwise, if you feel comfortable putting your email in the chat, audience members can reach out to you. Thank you guys again for sharing your stories and for being brave and amazing.
Thank you for having us and best of luck to everyone.
Thanks for having us.
Thank you.
Audience members, we will be sending out a short little feedback survey, so please make sure to fill that out really soon and stay tuned for our next session, which will be scientific communication and research and medicine. Thank you and see you soon.
Hi, everyone. Unfortunately, we're having some difficulties reaching Dr. Rasaniello, and we hope that he can join very soon. But in the meantime, we will go ahead and play a backup game that we have prepared for everyone. So we hope that he can join us very soon. But Ruhi and I will be leading this game called 4 Picks in 1 Word. So I will explain very quickly how we play it. So sorry about this. So here are the instructions. It's called Medical Terminology 101, and we will have a few pictures that we will be showing to all of you. And within 10 seconds, we're planning on having you guess the word based on the pictures and scrambled letters that we will show. And the fastest person to type the word in the chat will be winning that round. So please, let's get started. I'm gonna go ahead and do the timer. It's gonna be 10 seconds. Just give me 1 second. So this is the first one. And I'll give 10 seconds and let's see who can guess the word. All right, I think we saw a few people already guessing. God, so sorry about that. And, oh, sorry, why does this not say the answer?
I think it said, yeah, it said just, yeah. So Juliana was the first one to get that. So congrats.
All right, awesome. Now we'll give everyone a few seconds to look at the pictures. Now the scrambled words. All right, it seems like someone already got it. Was it Maddie? I'm sorry if I'm mispronouncing that, but yes, glaucoma. Now this one. Yes, so I think this one was Krishna, right?
Yep.
Awesome. Next. This one's a bit harder, but it seems like Juliana got it first. We also see Krishna again. And yes, tachycardia. What about this one?
I see a lot of hypertension.
All right. Yes, I think Krishna got it again. So it seems like Krishna and Juliana are leading the way. So great job, guys. This one. Oh, I'm so sorry. This one showed the word first. So I guess this one wouldn't be able to do it. This one's a bit harder. So, oh, we see,
Juliana got it.
Yeah, awesome. Great job, Juliana, Krishna, Elizabeth. And to everyone who's not getting these words, don't worry. Medical terminology is not really something that pre-meds do that much unless they have like some sort of clinical job. A lot of these, like, I wasn't too familiarized with until we made this game. So this one. Yes, I think we had Joshua. Got it this time. Schizophrenia. And if you guys remember, we covered psychiatry on Monday session. So if you're interested in schizophrenia, usually psychiatrists are the ones who treat with these things. All right.
Yeah, Krishna got it very fast.
Yep. Oops, sorry. Yeah, it showed it. Now this one. Yep, I think this one was Sarah, right?
Yep.
That's true. I'm not sure who got this one, but I see a lot of people who
I think it was Juliana again.
Awesome. Great job, guys. Yep, a lot of students are getting this one. Yep, I think Joshua. Oh, there are some people who got it. I think it was Leslie this time. This one is harder without the word. I see a lot of people put dementia, very similar. This is a type of dementia, so Alzheimer's.
Yes.
Awesome. All right, I think some people are getting it. Yes. Perfect. What about this one? Yep, I think a lot of people are getting it too. I'm not sure who was the first one for this one, but
I think it was Kirtana.
oh, perfect. Good job.
A lot of people got this one. Hypothermia.
Awesome. Oh, here he is. Welcome. Hi, Dr. Rosaniello.
Hello. Sorry, I thought it was at 1.
Oh, I apologize for that. Thank you so much for being here. We're very excited to hear your presentation, and Ruhi will go ahead and introduce you.
So, hello everyone. I'm thrilled to welcome you all to our session titled Scientific Communication in Research in Medicine with Dr. Vincent Racaniello. Dr. Racaniello is a professor of microbiology and immunology in the College of Physicians and Surgeons of Columbia University. In addition to conducting laboratory research on viruses since 1975, he founded a podcast, Microbe TV, and hosts a virology blog to educate individuals about viruses and viral diseases online. So attendees, just a reminder to feel free to put any questions that you have throughout the presentation in the Q&A section. And let's welcome Dr. Racaniello.
Thank you so much. It's a pleasure to be here. So I'm going to talk to you about communicating science and give you our experience, why you need to do it, and how you could contribute as well. So I'm all about scientists communicating science. And it's quite clear that scientists have a responsibility to engage in discussions about how their work may be used in society. And there's a division of the National Academy of Sciences called the Public Interfaces of the Life Sciences that provides scientists with tools to do this. And you can go to this site and get more information. Now, why should you communicate science? Well, there are many reasons. During the previous administration, we had a president who waged a war on science, was anti-science. And so this was an editorial early on in that administration. which is unfortunate because, as you know, science and politics should never mix, but politicians always take the opportunity to manipulate public health to their benefit. And that is very sad because, as you know, it's our job to take care of people, to make sure they're healthy, not to use public health for political purposes. Here's another reason. This was an op-ed published in June of 2019, and it's so prescient. When the next pandemic strikes, we'll be fighting it on two fronts. The disease, okay, researching a cure, inoculating. The second is new, fighting the deluge of rumors, misinformation, and flat out lies that will appear on the internet. And of course, this is so true. There's misinformation, there's rumors, and flat out lies, and most people don't know how to deal with them. And that's one reason we, as scientists, communicate science. I want to show you a few polls from Research America that they conducted. These are a number of years old now. They conducted these with non-scientists in the public. How trustworthy do you consider each of the following to be as spokespersons? And scientists win over everyone else, including healthcare professionals, journalists, bloggers, et cetera. Elected officials are, as they should be, at the bottom because they shouldn't be talking about science. How about, is it important for scientists to inform elected officials about their research? Very important, 51%. Of course, they don't listen. However, do scientists effectively communicate? There's a bit of a split here. Yes, no, and not sure. So we have to do a better job. And I can absolutely see why this is questioned. Should elected officials listen to advice from scientists? Well, here, unfortunately, the public, 38% think it's very important, but 42% think it's only somewhat important. I think that's wrong. And that's, again, where communication could help to improve that, because elected officials need to listen to scientists because they are not scientists themselves. And even if they're MDs, that's not being a scientist, as you know. Here's one I threw in because it is driving our pandemic, the unvaccinated population in the US. And this is 2015. How confident are you in our current system in the US for evaluating the safety of vaccines and recommendation? And look at this. In 2008, 53% were somewhat confident, 32% very, and it kept going down and down. And now we're in a condition where half of the US is fully vaccinated against COVID, and it's getting very, very difficult to do the rest. Should science be partisan? Is it the business of one political party or another? And they agree. The public agrees that science should not be partisan. Yet you find states where the governors say you can't have a mask mandate, which is a political statement, not a scientific one, because we know that masks work. So how can you say you can't have a mask mandate? Should we get rid of seatbelts too? Anything that you don't have a choice with? It's absurd. Finally, my most favorite, name a living scientist. Most Americans cannot, 70%. Here's our problem, folks. If you want to be a scientist, you need to communicate. You can't just focus on your science. And the ones who could, at the time this was taken, Stephen Hawking was alive. So that's good. But then many of these other people are science communicators. They're not doing science. Jane Goodall is a scientist for sure. But everybody else is a science communicator. And Mehmet Oz is a fraud who doesn't know any science, unfortunately. All right. So those are some of the reasons why we communicate. One of the first rules is to know your audience. I think there are three general audience out there. There are people who don't know any science and don't care. They're not interested. They can barely get a job and pay for their family. And I understand that. There are people who are science literate. They seek out science, and that's mainly who we get, although it's changed during the pandemic. And then, of course, there are scientists who are interested in science. Before the internet, you could communicate science in three ways: by writing, by teaching, or by engagement, which means you give a talk, you go to a restaurant and you could give a talk or a cafe. But of course, post-internet, we have the world at our fingers with the internet and apps and social media. So there's no limit to what you can do. I am a scientist. I am a person who has a PhD. I was trained to do research. I have been doing research for over 40 years on viruses. I write grants. I train students and postdocs. I write grants to support the laboratory. I publish papers. Traditional research scientists. A number of years ago, I found that communicating science was very important. So I'm going to tell you today how I've got interested in blogging, podcasting, videos, and social media. The driver for all this is the publication of a textbook, Principles of Virology, what's the first edition here, 2000. And then subsequently many editions, and the last one was just published in 2020. And because of doing this, I learned a lot of virology. This book is a different approach to teaching virology. It does it by process, not by virus. Teaching virology by virus is not teaching basic virology. It is giving a list of viruses, and you don't learn any principles. So we wrote the book differently. So in the end, we all had to have a lot of knowledge about different viruses. So with that, after the publication of that first book in 2006, I started blogging. I called my site Virology Blog. It's at virology.ws. And every week since then, I write a post. And I also have two other authors helping me write, David Tuller, who is a science journalist at Berkeley, and Gertrude Ray, who is actually a patent officer with a training in virology. Who reads my blog? Everybody. These are countries in the world that read the blog, and 85% of them are new visitors. There are a few countries that don't read it. Countries in Africa, Greenland apparently doesn't like to read it. Well, I'm sorry, Greenland, but most countries do. And here's just a breakdown of the numbers. We have over 1,600 posts and 18 million page views since the inception, about 270,000 page views a month. And here are the top countries. And you can see there are some interesting countries here that have engaged in this blog. So blogging is not dead. If anyone tells you that, they're wrong. You can still reach a lot of people if you like to write. It's a great way to hone your writing. And I make myself write once a week. I don't make myself. I make sure I do because I love the writing. Podcasts is the next thing I got interested in. What is a podcast? You all should know, but in case you don't, it's episodic digital audio distributed on the internet. Episodic is the key. That means you have to do it on some regularity, whether it's daily, weekly, or monthly. If you do it once every 6 months, it's not a podcast, and you'll never grow an audience. The technology behind podcasting, of course, the internet, digitization of audio files, syndication by RSS feeds was developed from the 90s to the early 2000s, and portable digital audio players were a major factor in the growth of this. In fact, the iPod was the first big one, and that's where the name came from. And in June 2005, Apple released iTunes version 4.9 with native support for podcasts, and that's what drove the explosion of this field. Now, there's no more iTunes anymore per se. So there used to be an iTunes podcast directory. You can still use iTunes or Apple as a directory for your podcast. But here, for example, was the podcast directory a number of years ago before it changed. And they had podcast categories. And one of the categories was life sciences. And our podcasts regularly appear in this category: TWIM, This Week in Microbiology, This Week in Parasitism. So it's a good way to get exposure. Of course, now podcasts can be heard on Spotify, Google Play, Pandora, etc. And everyone's getting into podcasts because advertisers have discovered them. And there are many big names in podcasts, like as you saw in this previous slide. Look, NPR, I mean, Gimlet Media, these are all big companies, National Geographic, and we're just a little bunch of academics. So I thought it would be neat to start a podcast where we have scientists just talking. We have great conversations in the lab, but nobody hears them. So let's capture these discussions. So I started it in 2008, This Week in Virology. And these drawings were made by one of our listeners in Australia and others. And now we have myself, Dixon Despommier, Alan Dove, Rich Condit, Kathy Spindler, and Brianne Barker, all people working in the field, and we just chat. And this has grown enormously. In fact, when we go at meetings, when we used to go to meetings, here's a virology meeting, and that's us up front doing a live TWIV. Look, at the room is packed. It's standing room only. And this is very exciting for us. And we have conversations about viruses. We talk about viruses in the news. We have our listeners send in email. We have guests. We do live episodes. And of course, since the pandemic, our audience has exploded tenfold or more. And many, many people are listening who didn't even know what a virus was. Every episode, we're now up to 790, has its show notes, which summarizes the episode, has links to the audio. We now do video as well. And on the bottom are links to the stories that we talk about. I want to give you an idea about the penetrance of podcasting. Now, before COVID, we published 577 episodes, about 6 million total downloads. And every week on Sunday, I release an episode. It gets initially about 3,000 downloads. You can see pretty steady there. And then some of the highest downloaded episodes get 10, 11,000 downloads. And the most popular one before COVID was one on bioweapons, one on CRISPR, et cetera. Now, here's the story after COVID. We're now at 790. We have 16 million downloads. So that is 10 million more than we had for the previous 10, 11 years. And in 1 year, we added 10 million downloads. And now when we release on a Sunday, we get 30,000 downloads right away. Here's our top episode of all time, TWIV 640, Test Often, Fast Turnaround with Michael Minna, 72,000 downloads. We had a episode with Tony Fauci, but it's not in the top 10 here. But you can see the numbers are great. I wish this were higher. This should be hundreds of thousands. But part of the difficulty is that I'm doing it myself. Early in the pandemic, my colleague Daniel Griffin, who is chief of infectious diseases at Northwell, he started doing clinical reports, COVID clinical reports with me. He's my co-host on This Week in Parasitism. We now do this every week. It's a 30, 40-minute clinical report. This is number 74. And he started doing them from the hospital parking lot. He would leave the hospital, go into his car, take off his mask, and record. And many, many people find this extremely useful. Who's listening? All kinds of people, from high school through healthcare, graduate students, professors of all kinds, even people who don't have a professional degree, sanitation engineers, painters, laborers, policemen. Once we had a letter from a policewoman, and she said, my only PPE is latex gloves and a Glock. We get great email from listeners. Here are just a couple of them. I'm beginning to understand how scientists think and how they work together, asking questions and solving problems. That's exactly what we want to teach people. I listen to your podcast every night. I find it inspirational in these dark times to listen to the erudite seek scientific truth when the world is drowning in folly and lies. And this person said we're their best source on COVID, which many people tell us. So this podcast empire, if you will, has now expanded into 6 podcasts. This Week in Parasitism, Microbiology, Evolution, Neuroscience, and Immune. 70% of our listeners are not scientists. On each show, I have different co-hosts who are experts in the field. And while TWIV is the biggest in terms of audience, the others have substantial audiences of very devoted people. Now, one of the issues with our podcasts is that they're typically 1 to 2 hours. We try and make them understandable, but we could do better. And so I'll tell you how I'm working on that. How do you make a good podcast? This is us in the early days before it really expanded. Have a conversation, I think, is the best way. I think teaching via a conversation is the best. You don't need to show slides. I think at a meeting, when people get up front and sit around and talk, that's the best way to learn. You have to have great audio. You have to follow a schedule. You have to engage your audience. We ask for questions and they're sent in. We answer them on the show and people feel like they're part of the show. There are different ways that you could augment that now. You could actually bring people in live if you wanted to. But you have to bring them into the show and not see them as something separate. Okay, so that's podcasting. The other thing I do is I teach virology at Columbia. I started teaching in 2010. I go down to the undergraduate campus And there was no virology course there. These students are paying tens of thousands of dollars in tuition, no virology. So I said, this is ridiculous. So I started in 2010, and as you can see, the enrollment has steadily increased. Now we have 130, 150 students every semester. I just finished teaching a summer version. I put these videos online, and back in 2010, that was novel. When Apple released iTunes University for the iPad, they featured my course on their app for the first week or so. And this got us a lot of subscribers. They used to run iTunes University, and I put my videos there. And you can see the first year I put them up, 88,000 people subscribed. It went down because then we put our course on Coursera, this massively online open courseware site. And I did this only twice, but we had 54,000 and 35,000 people register for the first two installments. We split the course into two pieces. And now I put all the lectures online every year. This is not in date. I have many, many more lectures and hours, including the most recent is 2021. So then our YouTube presence expanded. As a consequence, I have a channel on YouTube where I post not just the virology lectures, which are down here. By the way, the first virology lecture for the 2020 course, because of the pandemic, got 600,000 views. And I think that's amazing. I continue to release them every year, and many people watch them. They're free. We also release our podcast now because we do video, This Week in Virology, This Week in Evolution, etc. And I've also discovered live streaming on YouTube, where once a week I go on with my colleague, Amy Rosenfeld. We do a live stream where we answer people's questions every Wednesday, 8 p.m. Eastern. And this past Wednesday, we had 750 people there asking all sorts of questions. And live streaming is is really a good way to reach people because they come to ask questions. You can interact with them. It's recorded, and so people can go back and look at it. And it is a live way to reach people. And I'm going to teach a virology course in the fall, live streamed on YouTube as an experiment, because if it works, then I'm going to teach a lot of courses online. I think it's a great way to reach a lot of people. I also use social media. I have a presence on Twitter. I've been on Twitter a very long time. Just after it was established, I recognized it would be valuable. I don't spend a lot of time engaging, but if you would like to do some in communicating, it's a good thing to do. I have too many podcasts to run, but we have a good amount of followers. And the really exciting news is that we have now opened a recording studio here in New York City, right near Penn Station. We call it the Incubator. It's kind of a takeoff on Andy Warhol, who called his art studio the Factory. We're going to make science content. We're going to make videos and podcasts. We're going to do interviews. And this is actually the studio part, which was just refinished. And I am going to be putting interview stations in here. I'll be doing all my podcasting, live streaming, videos, etc. here. And I've made a company called Microbe TV Incorporated, and I filed to be a nonprofit so we can get donations to support us. And my colleague Daniel Griffin has a nonprofit called Parasites Without Borders, and he's also a nonprofit. And he and I are co-leasing this space. Very exciting next phase in my career. So just to round out the end here, what can you do? Well, blogging is cheap. It's just a matter of time. And if you like writing, I would say start a blog. You have something to say. People always say to me, well, you've got the virology space. No, you have something different to say for sure. You just need to find it. It may take some work. You'll find it if you like writing. Podcasting is a bit different. You need some equipment and you need to do it right. You can't just pick up your phone and record a podcast. The audio won't be good enough. And when you do a podcast, that's all people have is audio. You can do social media. I've done science cafes at restaurants and so forth. That really works. I also teach at local high schools. I go in for a day and talk to classes. So there are a lot of things that you can do. And, if you can't think of something to do what Mary Woolley says. She's the CEO of Research America. She says, if you're in an elevator or somewhere and someone asks you what you do, you tell them, I work for you. Because you do. If you're a scientist, you're doing science with taxpayer money. So you're working for them, and they're going to say, what? How is that so? And that gets you in. You can talk to them. Because if you say, I work on fruit flies, they're going to go, okay, and leave. So you tell them I work for you and then segue into it. Just communicate in some way. We all have to communicate in some way. In fact, that's what I do all the time now. I view it as the second phase of my career, communicating science. And once the studio is up and running, I'm going to be going there every day and making more and more content of different sorts. I'm going to experiment with short form. For example, something happens one day, I can make a 10-minute video and put it out right away and explain what's going on. And we have a need for that. I don't want to depend on the mainstream news to give people their science, because they mess it up. I mean, just the current pandemic alone, they mess it up all the time. This idea, for example, let me just give you one example. The vaccines are not preventing infection. Oh my God, we're all doomed. Really? Do you know any human vaccine that prevents infection? Well, there's only one. There's human papillomavirus vaccine. The others allow infection, but they prevent disease. If you knew some virology, you'd know that, but the journalists don't. And it's the fault of the scientists that they don't. So we need to reach out in different ways. I do a lot, but you don't have to do so much. You need to do something though. And I suggest you follow me to see what I do so you can learn. That's how I did it initially. I didn't follow scientists because they weren't communicating, but I followed other people who were communicating. I learned from them. I'm on Twitter, YouTube, Facebook. We have a great Facebook presence, many, many thousands of followers. I also find Instagram really good. That's a way you can communicate. A lot of good science communicators on Instagram. If you like taking pictures, especially if you're in a lab, people love to see lab pictures and explain what you're doing. And there is my blog. Microbe.tv is where you can find all the podcasts, or wherever fine podcasts are aggregated. Okay, I am happy to take questions at any time. Thanks for listening.
Thank you so much, Dr. Recchignella, for joining us and for giving that wonderful presentation. I personally enjoyed it as a researcher, learning from you. And we have several questions in the Q&A chat from our audience members. And so we have time at 10 minutes after 1 p.m. if you're still available to answer more questions. So just to give you a heads up, and to our audience members, we will be happy to take the next 20 minutes to do this Q&A. So Dr. Recchignella, I'll get started with the first question. This is from Joshua. What do you do to keep the science communication process interesting and enjoyable over so many years?
Well, science is enjoyable and interesting, right? It's an easy thing in my view. So there's plenty of content. I mean, just in virology, and I should say, our frequency of TWIV has gone from once to 3 times a week. I never have a problem finding content. But the other part of it, of course, is presenting it. And there are 2 ways you can do that. We have conversations that we record and release, right? And I pick people who are good chatters. Not everyone's a good chatter. Not everyone likes to talk. Some people, you ask them a question, they say yes, and that's it. And that's not what I need, right? I need someone who's going to go on and on and on. And maybe you have to say, that's enough, but that's what you need. And I think for all the pods, I've actually got the right people who like to talk and are knowledgeable. And there's nothing better than to get on and say, okay, there's this paper, this finding, what do we think it means? What's wrong with it? What does it mean for the general population? And people love to hear that conversation. So in the end, you need to be curious and passionate. And if you are, that will drive long-term interests in your work. And that's what I've always been curious and passionate. I learned that early on. That's what you need to be. And that's, if I gave you one bit of advice in your careers, be curious and passionate. Be curious about everything and be passionate and work hard on it, and people will be interested.
Thank you so much for that word of advice. Our next question is from Kirtana. How do you think podcasts and blogging have affected people's perspectives on vaccines? Have you seen anyone personally who changed their mind after watching or reading?
Oh yes, we get a lot of emails from our listeners. I get so many every day that I can't answer them. I have trouble getting through them. I really need to get someone at one point to help me. And that's the point of, making a nonprofit and raising money. I want to be able to help people because so far I've done all of the work myself. Many people have written and said, I used your show and what you say to convince my friends to get vaccinated, right? And people ask us, how can I tell my friend who is anti-vax? And we give them advice, very specific advice. And many people tell us it helps. Now, of course, it's a fraction of everyone that's out there. But a lot of people tell us, I have friends who don't listen, but every week I give them a summary of what you say. And so you're really influencing way beyond your downloads. So I think we've been doing this for 12 years. It's not something that popped up in the pandemic, right? And so we have a reputation, and there are a lot of pods that popped up suddenly and people want to make money on the pandemic. And I would say our advice is really good and people recognize that. So longevity in a field, it really helps, I think. So the answer is yes.
Thank you. I'd like to actually expand on that question personally. What is the advice you give to your viewers who have family members or friends who are against vaccines or against specifically the COVID-19 vaccine?
Well, there are two levels of advice, right? There's some people who think, and this is because they go on Facebook and they get the wrong information, right? I mean, unfortunately, there's a whole bunch of people out there that spew misinformation about vaccines. There are about 12 people that spew most of the vaccine misinformation. And the reason they do is because they get paid to do it, which is so sad that someone would pay to do that and cost people their lives. So we dispel those things like the vaccines will make you sterile. The vaccines have a microchip in them. They haven't been properly studied. They're risky. They're experimental. All that is easily dispelled. And you can tell people, here's the information. And we're scientists, and maybe it helps to hear it from a scientist. The other part is to make it personal, which is I'm vaccinated, my whole family, my wife and kids are all vaccinated. And everyone on the pod will say, we're vaccinated. Millions of Americans are vaccinated and they're fine. And I think making it personal really helps because a lot of people do ask us, what about you? Would you take this vaccine? And I would say, I've already got it. Yes, absolutely. And I'm here. So those are the two levels. There's the science and there's the personal. I think they're both really important.
Thank you. That was a really good answer. We have another question from Leslie. She asks, how can actual scientists and also non-scientists improve their communication?
Good question. By communicating. There's nothing like practice, right? So I started out, I had no communication training at all, right? But I actually liked giving talks and teaching. So I did more and more and more of that throughout my whole career. I taught a lot. And then when I came to Columbia, I taught even more, gave lots of talks, and then started podcasting. And, you listen to yourself, you can tell what you're doing wrong. And I have learned, for example, to pace myself, to say something that you want to emphasize and just pause very briefly, not run on quickly, don't speak quickly. And I found listening to other people, you learn a lot about how to present, and not just the podcast, right? So spoken word is different from a video. In a video, you learn to look right into the camera and talk to people and go slowly, use great visuals and so forth. I never took a course. I just learned, and I tell people, look, I'm a scientist. I can learn anything. That's what I'm here for, to figure things out. Now, I've actually thought of taking a speaking course here in New York City. I could take one where I learned to speak even better. Certain words that I don't pronounce properly, certain cadences, and I'm thinking of doing that. So you could do that, but I think you don't have to. I think if you just emulate others and practice. I mean, I do this almost every day, right? I listen to myself, and that combined with listening to other people, that's all you need.
Thank you. Our next question is from Rana. Can you be a scientist if you're going to medical school or pursuing the MD or DO route?
Absolutely. No, I don't mean to say that MDs can't be scientists, but I think you have to understand that if someone is an MD, it doesn't mean they're a scientist. Right? Medicine is not science. Medicine is taking care of people. You're not doing experiments on people. Science is doing experiments, but you could certainly get an MD and become a scientist. So you can do an MD PhD program, for example, where you do research. And I have had many students who do that, and they go on and have research careers. You could even just do an MD only and do research in a lab afterwards and become a scientist. So yes, there are many ways that you can do that. And having an MD gives you a different view of science, especially clinical science. It's highly valued, but the problem comes when, let's say, there's a very prominent cardiologist in California who gives a lot of advice on COVID, and a cardiologist is not an infectious disease physician, and I don't know why people are listening to him. He's often wrong. So, an infectious disease physician like Daniel Griffin is who you should be listening to. That's all I say, is that MDs are not necessarily scientists, but they can be for sure.
Okay, thank you. Another few questions from Kirtana. One is just, where can we find the virology courses? Are the Coursera MOOCs free?
So the Coursera's are not up. They did a revamp of their website a few years ago, and they took them all down, and they've told me you can repost them, but I just haven't had time to do that. And it's an old version of the course, so I really would need to repost all the lectures and break them into 10-minute chunks. That's what they want, and put questions, and it's just a massive amount of work. So you can't find them on Coursera anymore. I might do it one day, but they are all on YouTube, youtube.com/PROFVRR. And you can find all the videos there of every video in my course. Every year I post a new set of videos. There are embedded in the course questions as well. And so you can get almost the same experience.
Thank you. Kirtana also asks, what do you suggest to combat the huge amount of scientific misinformation? And how should one go about interacting with someone who's been scientifically misinformed? I know we already talked about this question, but if you'd like to chat about it a little bit more about, I just think more about the COVID vaccine and how what's going on today with, I know a lot of vaccinated people who are getting COVID. Could you touch on that a little bit more about what that means for the future of the pandemic?
So when you say get COVID now, that's a little bit not quite right? Because COVID is a disease, and what these people are doing, they're turning up PCR positive, and most of them are in fact not even symptomatic. And as I said earlier, vaccines don't prevent infection. So if you are vaccinated twice, you will get infected. However, you will make very little virus. Your immune system memory will kick in 2 days or so, and then they will prevent you from getting severe disease. Now, some people do get cough and headache and so forth, and a very few people end up in the hospital, but far fewer than unvaccinated. So it doesn't matter if you get infected. In fact, I think people should not get tested because it makes them scared after they've been vaccinated. And it doesn't do any good because there's no good evidence that you're actually transmitting. I mean, you will hear out there, the CDC, COVID vaccinated people still transmit. There's really not good data for that at all. And the reason is that they always use PCR. And PCR does not measure infectious virus. It just measures pieces of RNA. So if the CDC wanted to make estimations of how much a vaccinated person transmits, they should do infectivity studies, which they're not doing. And I think in the absence of those, what they're saying is very misleading. So in my view, vaccinated people do not transmit. And that's why herd immunity works, because if vaccines in general allowed transmission, we would not have such a thing as herd immunity, which means you can vaccinate, say, 80% of the population and the rest will be protected because you cut down transmission. So this is why the press is not the place to get your news from about science. Unfortunately, most people do, right? Because it's everywhere. It's on your phone, it's on TV. You can't get around. You go waiting in an airport and you get the damn CNN up there. You can't escape it. But we try to combat that because I think they propagate misinformation. They make people scared, and it's not valuable. And so that's the role of the scientist, to try and cut through that in a clear, and compelling manner. That's what we try and do.
Thank you so much. I work in a hospital setting, and that's really great to hear, as I'm vaccinated, but some of my family members are vaccinated, but also I'm afraid to give them COVID. But this is so good to hear that.
Yeah, I don't think you should worry. I think that the evidence that there's substantial transmission is really not there. Yeah.
Perfect. All right, we have a few more questions from our founder, Alejandra. She asks, she understands that establishing a nonprofit takes a lot of time and effort. How do you balance creating your nonprofit and keeping up with your research and podcast?
Well, making a nonprofit just involves a few hours of filling out an IRS form, and then you wait. And then when you're a nonprofit, then you can have people donate, and their donations are tax deductible, right? Which is very good. And then you can get substantial donations from individuals, from corporations, from foundations, right, who look to support nonprofit work. I cannot go out and raise money, right? So I just hired a fundraiser whose expertise is to link up people who want to donate with recipients such as myself. And this is actually someone who found TWIV last year, and he thinks we are doing amazing work. He loves it. And when I mentioned on one live stream, I need a fundraiser, he said, I'll help you, and so I pay him, and he's going to connect me with donors. We're going to have, a little party in the studio to introduce them to what we're trying to do. And he thinks we can raise substantial money. So the key is to get other people to help you, right? So many aspects of the studio, I get other people to help me. And we're lucky that we've had a lot of contributions in the past year to help pay for this. Now, the lab, that's a good question. I could not run a lab and do all of this at the same time. So 5 years ago, I hired a former PhD student of mine to come and run the lab and basically make it her lab, do the experiments, work with people, write grants, write papers, and she does it all. It's essentially her lab now, and she can do what she wants. I'm here and we chat every day, but without her, I could not do it. I would have to give up the lab. Now, when she becomes independent, when she has her own lab one day, I'll have to shut it down and just go to my studio every day, which is fine. That'll be, I've had a long and really satisfying research career, and now part 2 is full time, and I'm very excited about that.
Thank you so much for sharing. We have another question from the audience. Clea asks, do you think that the world will face a second pandemic in the near future, or a pandemic of a more deadly form of COVID?
So we will always have pandemics of various viruses. We have had influenza pandemics regularly, right? The last one was 2009. Before that, it was 1968. We have had this is the biggest coronavirus outbreak, which is actually a pandemic. The SARS-1 of 2003 was not a pandemic, but it just showed that viruses can come from animals in nature and spill over into people and cause problems. So there will be another flu pandemic. There will be another coronavirus pandemic for sure. It might not be the magnitude of this one. This is really once in 100 years, I think. So I think future ones will be more moderate, but we're going to keep having them unless we're ready. And we could have been ready for this one. I tell people all the time, we could have been ready with antivirals and vaccines that would have stopped this at the beginning, but we didn't because there was no foresight. We get our drugs from companies, from for-profit companies. And if there's not a market, they will not make a drug or a vaccine. And so that's why we weren't ready. I'm hoping we've learned a lesson, and now we can have antivirals. Well, for example, we could make a pan-coronavirus antiviral so that any new corona that came from a bat or whatever animal, we could stop in its tracks. We could do that, and it's not that hard. So I'm hoping we'll do it and be ready for the next one. We can be. Science is at the point now. Look, we made a vaccine in 9 months. That's a miracle. That's a miracle. And I think we could do other things that are equally miraculous, and it's just a matter of our will. So I'm hoping we do it. If not, then we will continue to have pandemics because we can't stop them.
It is really refreshing to hear you say creating a vaccine in 9 months is a miracle. As in a community that I've faced a lot of people say, oh, creating a vaccine in 9 months is a tragedy. It won't be as safe. I've had people say that to me, and I'm like, really, it is a miracle that we are able to prevent this disease within such a short amount of time. So thank you for sharing that.
What is sad is that
Yeah.
so many people are not taking advantage of this miracle, right? And
right.
I wish I could talk to every one of them personally and try and convince them. I know that doesn't work because I've had such conversation. It's not easy, but people really need to understand it's a miracle and it's safe. It's incredibly safe, and it prevents severe disease. It will save your life. And if you don't want to get vaccinated, and I don't care how old you are, I mean, even young kids die of COVID, or they get long COVID and never recover. It's not worth the risk, folks. It really isn't.
Thank you. We have another question. Do you think we should be retrieving data of antibody levels on those vaccinated throughout the world to see if the COVID vaccine is working on individuals?
We've already collected quite a bit of antibody data from vaccinated individuals. We can't collect from everyone, right? That's impossible. And that's why we always collect from certain numbers of people, and then we use statistical procedures to extrapolate to the entire population. So as long as we have collections from different populations, in the US, we're different from other countries. We're genetically slightly different, and we can respond differently to vaccines. And so in many countries that's been done, but I think what needs to be done is to do very careful studies to look at shedding, say, for example, after vaccination, because I think they will show that there's very little shedding and it's not a worry, as we said before, but the data don't exist, and I wish we would do that.
Thank you so much for sharing. We have one last question. Do scientists know if there's any long-term side effects to the vaccine?
Well, I think you've answered your question, right? Because we've only been a year out or so from the vaccine. But I have to say that we've never seen any long-term effects beyond 6 months after vaccination with any vaccine. And I've talked to a vaccine expert, Paul Offit, about this, and he says, if you don't see something in the first few months, you're not going to see anything in the long term. The only thing you learn, and many of these vaccines are being studied for 2 years in the initial clinical trial population. They are being studied for 2 years just to see how long immunity lasts. We need to know that, not to see if there's any long-term effects, because we already know after a few months there aren't any. I mean, there have been some myocarditis, right? There's been some blood clotting, but they're not long-term things. Those are things that are resolvable. So I don't think there's going to be any long-term effect, no, from any of these vaccines.
Thank you so much for sharing. And I know our guest speaker just shared their PowerPoint. With that, I think we will go ahead and complete the end of this session. Thank you so much for joining us, Dr. Racanello. It was a pleasure speaking with you. I know we'll have this session recorded on our YouTube channel after the conference is over. So I personally will be sharing it with my family members, and hopefully they will change their minds to get the vaccine. So thank you so much for all of your advice and guidance.
You're welcome. Thanks for having me.
Have a great rest of your day.
Thank you.
With that said, our host director, it will be up next and hosting the next session, which is emergency medicine in a rural setting. So Raniella, go ahead and share your video and audio and provide the introduction. Thank you. Oh, and don't forget to take the feedback poll posted right on your screen for this session. I think I will go ahead and give the introduction real quick. Oh, Bronny's back. Bronny, are you able to share your audio? Thank you, everybody, for your patience. Ronnie, can you hear us? Okay, that is okay. I will go ahead and give the introduction. Thank you so much, everybody, for joining us for this next session. And thank you so much, Dr. Cortez, for joining us today. So my name is Alexia, and I am the co-president and co-founder of the National Pre-Health Conference. And it is my pleasure to introduce Dr. Fernando Cortez. Dr. Cortez is a board-certified emergency medicine physician from the University of Arizona College of Medicine, and he's currently the emergency department site lead at Florence Hospital. He came to Arizona in 1987 and graduated from ASU in 2001 with a bachelor's degree in microbiology and a minor in history. He's also the founding member of FACES, along with the MHEP and ASU AMSA chapter. Furthermore, he's happily married with 3 kids and goes on camping and hiking trips during his spare time. And he will never pass up a midnight taco. Today, he will share with us his experiences of emergency medicine in a rural setting. Let's give it up for Dr. Cortez. Thank you, Dr. Cortez.
So much, Alexia. Can you guys hear me out there?
Yes, we can.
Okay, great. Let's do... We'll go ahead and I'll just do the presentation this way, or I'll go ahead and start the video. Not a big deal. Okay.
You can give the presentation with or without your video, whatever you
All right, cool. Let's see, awesome. So in emergency medicine in rural settings, so thanks, Alexia, for inviting me out to this conference. It's always exciting to be able to talk to pre-health students about emergency medicine and why I went into this, and just medicine in general. There's been a lot of interesting changes the last couple of years with COVID, as with everything else. But it's always a fun opportunity to be able to at least discuss what our job outlook is and what we have going on here in the coming years. Now, just briefly, I'm going to talk about just emergency medicine in general as a specialty. I don't know in regards to the audience as far as what your exposure has been to emergency medicine, if you know about it as a specialty. Usually it's not, well, since it's not one of the standard primary care or general specialties like internal medicine, pediatrics, OB, family medicine, not many people really think about EM during residency. There's always a TV shows that talk about it quite a bit. And you see all the exciting things on TV about it. It's not all that exciting all the time, but it can be sometimes. In any case, so just as far as any conflicts, there's nothing to disclose. I have no financial disclosures with any of the organizations I'm going to be discussing today. Just brief, a little bit of a history of emergency medicine. So EM essentially was founded by necessity by a couple different groups, one in Virginia and the other one in Michigan. In Alexandria, Virginia was essentially just a series of full-time docs that said, hey, we're going to do this full-time. And they started some of the first emergency departments. In Pontiac, Michigan, it was just a series of full-time docs that said, well, let's just do this part-time. Little by little, that just kind of floundered and then subsequently developed further. And the American College of Emergency Physicians was founded in 1968 as a response to the need for patients receiving unscheduled and emergency care. There was a big demographic shift in the 60s, and as more and more people were finding themselves without access to physicians, it necessitated the hospitals being open 24/7 and to have a physician staffing the ER. The first training programs were established in the 70s with the first residents graduating at that time. And emergency medicine was officially recognized as a specialty by the American Board of Medical Specialties in 1979, with the first certification exams coming out being done in 1980. Now, I apologize, the next couple of slides are a little bit verbose. But they pretty much sum up what I do as an emergency medicine physician every day, and was what we do essentially and as a specialty. So I'm just going to go briefly and just highlight a couple of points. And once again, I apologize if they're a little bit verbose, but they're straight from the American College of Emergency Physicians. So EM is a medical specialty designated to diagnosis and treatment of unforeseen illness or injury, encompasses unique body of knowledge, which includes the evaluation, diagnosis, treatment, and importantly, coordination of care among multiple clinicians or community resources to disposition any patient required expeditious care. So that coordination and the disposition is key. Usually you'll see us as the point of the spear in taking care of patients, especially the acutely ill patient or the patient that comes into the multiple trauma. Brief example, I had a young woman that was shot through the left side of the head that was pregnant. And essentially I was there leading the team. This is in a rural setting, by the way, in a rural setting, coordinating the different specialties, neonatology, OB, and then myself, as well as the air crew team, in stabilizing this patient and then sending her over to a trauma center. Her and the child eventually did fine, but it's that training that you receive during residency, and then you continue to develop that during your practice. We're not defined by location. We practice in a variety of settings: urgent care, standalone, small hospitals, large hospitals, disaster sites, or even telehealth, especially as during COVID, telehealth has become more popular. So EM encompasses the planning, the oversight, the medical direction for the emergency medical response as well. And we provide administrative and leadership services to not only urban centers, but especially rural centers. And that leads into what I'm going to be talking about today as far as practicing emergency medicine in a rural setting. We provide that leadership to be able to coordinate care to the patients that live in these communities. And finally, for better or worse, I believe this very strongly, that we are the safety net, or the foundation of the safety net of the healthcare system. Some clinicians maybe deride that a little bit, some don't believe in it. But I think as my role as an emergency medicine physician, I am the safety net of that community, and I'm able to provide that care that they need in an expeditious manner. In continuing, before I talk a little bit about emergency medicine training, if there's any questions or whatnot, we can have some Q&A at the end. We're a little bit, maybe a third of the way, I believe, through the slides, if you will. And, I'm leaving plenty of space to talk about emergency medicine in general. I'm more than happy to chat not only online, but offline with anybody that has any questions. So, excuse me, the training. So you start obviously medical school, you got 4 years, and then residency can be either 3 or 4 years. That comes from where emergency medicine, its origins, where it was a 1 year of general medical training and then 2 years or subsequent 2 years of emergency medicine. Those programs eventually became a 4-year program, and then the newer programs became 3-year programs. So it's a 3 or a 4-year residency. I think they're both beneficial. It depends on the type of person that you are and the type of training that you're looking for. There's academic training programs, community-based. I trained at an academic program at Penn State, but there's many outstanding community programs out there, just like, there's many outstanding academic programs. It all depends on the type of program that you want to go into. Urban versus rural setting. Quite honestly, there's different places where you can set up and practice emergency medicine. I myself tend to be more of a fan of a training program that has enough repetitions and enough exposure to the breadth and scope of emergency medicine. And that's something that we're going to talk about in a little bit. Education within a residency program involves trauma, general medicine, and critical care, both adult and pediatric. There are fellowships available after residency that can last anywhere between 2 and 3 years. They involve toxicology, pediatrics, ultrasound, undersea hyperbaric medicine, education, etc. Wilderness medicine is one that I enjoy, but there's definite fellowship opportunities as well. There are some controversies regarding residency program expansion. So within the last couple of years, we're going to talk about this a little bit more in regards to the training program expansion process, how more and more residents are graduating and causing almost like a surplus of emergency medicine physicians. And we'll delve into that a little bit further. There's also some controversies regarding advanced practice provider use in the ED, such as nurse practitioners and physician assistants. I see them as part of the healthcare team, others don't. I know in this conference already, there's been some, discussion about this, so to speak, but, I'll kind of give a little bit of an emergency medicine viewpoint on this. Once you graduate residency, there's a board certification process. It's a written and an oral board exam. You take practice exams during residency in preparation for this test. It's just like any other exam that you take during residency, during medical school, that's several hundred questions, and you get used to taking exams. I mean, it's not a big deal. It's something that you should be well prepared for by going through an EM residency. And then there's an oral board examination process afterwards where you sit in front of academic emergency physicians and you answer questions. It's not an inquisition, but it's more of just a question and answer process so that they know that you essentially do know what you're talking about, and then you can essentially be board certified. There's a maintenance certification process that occurs every 10 years by taking another official exam. It's a written exam, by written, I mean computer-based. And that exam is actually going away. We're going to do a certification called My EM Cert that starts every 5 years. And every 5 years, essentially what we're supposed to be doing is an exam a year. It's open book. It's breadth and scope of emergency medicine, just to keep us essentially educated in our specialty with the most recent advancements. LSA exams are lifetime learning self-assessment exams that we do based on current literature. They take the College of Emergency Physicians and American Board of Emergency Medicine chooses about 10 to 15 articles that we read, and we answer some basic questions to ensure that, yes, we did read and we understand those articles. It's actually not bad and quote unquote fun. They're actually, pretty informative, and they help you take care of your patients. So I'm a fan of them. Now, the job outlook. I'm going to spend a couple minutes on this slide, in full disclosure, and so that we all know essentially what we're going into as we're going into medical school, if we're planning on choosing emergency medicine as a career option. Now, there's been a series of job analyses over the past decade that have demonstrated a possible scarcity of emergency medicine physicians. And that led to a logarithmic increase in training programs. They've been popping up all over the place around the country and graduating numerous residents every year. In 2017, 2018, the American College of Emergency Physicians looked at it and said, well, we're getting a little full. We need to take a look at this and see if we need to maybe curtail, some of these graduates graduating or curtail the growth of programs, because at least 80% found, although 80% found had no problems finding jobs, in subsequent years become more difficult. Obviously, COVID screwed everything up. ED visits dropped 40% nationwide, and there was a contraction of services among hospital facilities. Hospitals started shutting down, and several EM doctors found themselves without work. I know my hours actually increased, and they actually expanded from 8-hour shift to 12-hour shift because of decrease in volume. There was a workforce study in 2021 that addressed this, and they said, well, holy crap, we screwed up in the numbers, our assessments. We're going to be full by 2030. But they're still looking at those numbers and seeing what's going on as far as, okay, are we going to continue expanding? Are we going to contract? Are we going to curtail the training? Because granted, with the increase in training programs, some of these programs are not the best in the world and might be graduating some residents that are not essentially prepared. It is a controversy, and I know it's something that we're continually looking at within a specialty, but more information coming from that. In 2020, and this is going to lead into what we're going to talk about today in rural emergency medicine, There's a national study of the EM workforce that was done by emergency medicine, by the ASAP, I'm sorry, in looking at, okay, what's really going on with our numbers? And I'm going to go over that study in detail here shortly. Essentially said that urban centers are well-staffed, rural hospitals are underserved, and it fits what I believe is an anecdotal student and resident model that we'll talk about further in regard to graduating resident options. Now, briefly about APPs. Nurse practitioners and PAs are an important part of the healthcare team. There is a lot of discussion back and forth as to what the role is of APPs within emergency medicine. I think that supervised nurse practitioners and PAs are an integral part in taking care of patients in the ED. It allows us to take care of sicker patients. It allows us to take care of more patients in an expeditious manner. Now, I'm not going to address the controversies back and forth between physicians, nurse practitioner organizations, and PA organizations, but suffice it to say, those are things that we can discuss offline. But bottom line, I think that we can all essentially work together and without the feeling of, well, someone took my job type of deal. And I mean, I don't think that's the case. I think that healthcare entities and institution will make the best decision they want from an economic standpoint. And, unfortunately, we may be cut out from those, we are being cut out from those decisions. Telemedicine has made it easier to support APPs. But at the same time, we know our worth, and hospitals do as well. So rather than infighting and rather than the discussions, we should just have more of a collaborative discussion as to how can we better take care of our communities. So with that being said, just before I segue into rural emergency medicine, I just want to give you guys a heads up why I'm doing it. So as I said before, and thanks, Alexia, I graduated from ASU, went to U of A, graduated from Penn State in emergency medicine. I've been practicing for a decade in both rural and urban settings, large hospitals, rural facilities, standalone EDs, and I'm a site lead in rural ED here in Arizona. And what got me into it was when I was an undergrad at ASU, in founding FACES and AMSA, we started a migrant health, what's called MHEP, the Migrant Health and Education Program in 2001. Basically, a couple of us looked at different places around the state saying, hey, why don't we go do something? Very naive, if you will. I mean, taking a little medical bag and going out there. One of the people that founded it with us was an ex-Special Forces medic. And his experiences actually kind of built that fire under us in going out to different rural settings to provide Head Start physicals. And we obtained a grant from Susan G. Komen to do mobile mammography in some of these locations. Interestingly enough, as I started practicing emergency medicine a decade ago, I actually went and practiced in some of these sites again as a physician. That was very rewarding. But yeah, that's what kind of led some of the interest in going out to more underserved and rural communities. Now, what is the definition of rural? Census Bureau, White House Office of Management and Budget, Centers for Medicare and Medicaid, all have different definitions on what is rural based on population, geography, demographics, urban versus suburban populations. Nobody really has anything official in regards to what the definition is. For our purposes today, we're going to talk about urban, which is a city, and not urban, which is a small town in the middle of nowhere. That's kind of the best way that I can describe this. Now, the American College of Emergency Physicians has a rural emergency medicine section that you guys can take a look at if you're interested in rural emergency medicine. But their definition of what rural EM is urgent or emergent medicine practiced in geographic areas with low population densities and resource constraints. Basically saying in the middle of nowhere without much stuff, including ready access to more specialized care facilities. Rural EDs, we provide critical services for the communities and especially facilitating entry into the healthcare system, stabilization and transfer/transport to a tertiary care facility. A tertiary care facility is a facility, it's a major hospital, a major medical center. For example, Banner University in Phoenix, UMC in Tucson, Banner Desert in Mesa, UPMC in Pittsburgh. Sorry, I'm kind of a little more Pennsylvania centered, but you get the drift. Tertiary care facility is a hospital that has every specialty available with numerous avenues of support. And I'm sorry, that comes from the ASAP Rural EM section. So I'm going to delve into this because it really deals with the crux of why go into emergency medicine in a rural setting. The study of the EM workforce came out in 2020. There were approximately 50,000 active EM physicians in 2020. Median age was 50 years. I'm not there yet. I don't care what Sarah says. Median age was 50 years, 28% were women. And the overall density of emergency physicians per 100,000 population was 14.9. Most of the doctors, and this is what I want you guys to key on, were in urban areas. Only 6% were in large rural and 2% in smaller rural areas. So essentially, this kind of tells you that's a huge disparity, and I'll explain why. So the national study of the EM workforce continued to say that in urban settings, there were younger physicians than those in large rural areas, and most likely to be women. Most physicians in rural areas completed the medical training more than 20 years ago. So it's an aging population of clinicians that have been practicing for quite a while. And even though the total number of physicians increased between 2008 and 2020 by almost 10,000, the density actually decreased quite a bit in rural areas compared to urban populations or urban centers, sorry. So I am going to have these slides available through the conference. So if there's something, if I'm going a little bit too fast, please let me know. I'm actually clicking on the comments and on the chat and a little bit of the QA as we're going. So moving forward, rural emergency departments. Now, 42% of EDs in the US are classified in rural counties, all based on geographic isolation and acuity. Geographic isolation and acuity are a hallmark of rural EDs. You tend not to see the critically ill patient until they come in. And I'm sorry, it sounds kind of weird saying that, but for the most part, it's lower acuity, the sprained ankles, the belly pains, occasional chest pain, some orthopedic things. But then when you see something crazy come in, as I occasionally do, you really have to think on your feet. You are essentially all alone and nobody is coming. So that's why when you graduate from an EM specialty or you graduate from emergency medicine residency and you start working in these places by yourself, this is essentially you. It's that horrifying moment that you're the only attending. You're the only doctor in the hospital and you have somebody critically ill. So you have to go back on your training, trust your staff, trust the people that you work with to stabilize that patient, take care of them, and to get them to a place that they'll get that definitive care. But you're it. You're essentially the tip of the spear, not to borrow the SF community, but you really are. That's my favorite meme. One of my favorite memes of being an attending, by the way. So there's no trauma, no stroke, no sepsis team. You really got to think on your feet and solve some of these complex issues on your own. Telemedicine is helpful. I have often relied on critical care specialty support via telemedicine with some of these critical patients, especially because there's a prolonged transport time. You're talking about hours to get some of these folks from X location where you are to that tertiary care center. So you have to continue the care. Not only do you practice emergency medicine to stabilize the patient, but you also are practicing critical care on that patient. You are the critical care doctor. You're the intensivist. You're the pediatric critical care doctor. You're the surgeon. Obviously, you're not doing surgery in the ED, but you're continuing to stabilize that patient to get him out. Excuse me. Now, in rural departments, there's a camaraderie that develops among medical staff. And you do see a whole diverse amount of pathology. anything from the heart attack in one room to the other room, somebody who had a crush injury, just somebody who went skydiving and sustained an ankle fracture, to somebody who got stung by a scorpion or got stepped on by a cow, or weird infectious disease things. And so you're constantly thinking on your toes, which really adds diversity, and why I chose emergency medicine as a specialty compared to others, where you're not really specialized in one particular aspect of medicine. You see everything. And then another part that's dear and near to my heart is that you really get involved with your community. There's a lot of excellent patient care that you can provide to these folks, and you get to know them. You really get to know their families. You get to know them as individuals, as human beings. And that's one of the reasons why I've loved working in rural settings. I see these folks over several years, and I get to know them and their issues, a lot like a family practice medicine doctor does. But at the same time, you get to take care of them in their hour of greatest need. So let's talk about the negative sides. And a big portion of what I'd like to talk about and maybe criticize a little bit. I have some time here, and I want to focus on this slide in particular. So there are perceptions to emergency medicine physicians out in the community. I'm sorry, in rural settings. There's a competence factor. When you're talking to an urban physician or a tertiary care center, they perceive that you're not as smart. Why are you working out there? Are you a less competent doctor? Do you have malpractice on board? Have you done something wrong to work there? And that's one of my favorite things, to dispel the rumors. I love taking care of a critically ill patient, sending them out and receiving the phone call a couple hours later by a physician or a trauma surgeon or a specialist at the tertiary care, the main hospital setting, going, oh, wow, they're really sick. Wow, great job, thank you. And obviously I'm not trying to, pound on my chest or anything like that, but I'm just saying that there is that perception, and that's my job as a rural emergency medicine physician, to dispel those rumors, saying, hey, I'm a board certified doctor, I am competent, I'm here to take care of that patient and to send it to you because they're sick and they need that care. Otherwise, I just keep them with me. I'm not calling you at 2 a.m. because I want to talk about the weather. I'm calling you at 2 a.m. because I got someone sick that needs to come your way. Now, and that's kind of leads into a little bit more, that we're a little bit devalued, if you will. Don't you have the hepatologist? Don't you have that pediatric liver specialist or that X specialist? No, we don't. We are sending them to you to get that definitive care. So there's a little bit of a myopic view from urban centers. And you do feel a little bit professionally isolated at times. That's why I'm constantly reading and studying and going through the professional organizations, keeping my CME up, and to make sure that I have that important bit of knowledge when I'm taking care of my patients. Now, this is the part related to you guys, especially to you guys, the ones that are attending this conference. And once again, thanks for listening a little bit to my diatribe in emergency medicine. But part of the reason that rural centers aren't really well staffed is because, as a medical student, and a resident, you have mortgaged your 20s. You have spent all this time training and going through this difficult process, and you want to graduate and you want to go somewhere fun. You want to be in a place that has culture, a place that is not where you did your residency. You want to be somewhere exciting. You want to be somewhere fun. You want to be in New York. You want to be in Chicago, LA, Pacific Northwest, Miami, somewhere that's a big urban center. You don't really want to go to an urban setting and just, for lack of tense purposes, just not have fun, if we will. And so that's one of the issues that you deal with. And one of the things to think about as you're going through residency. A lifestyle. Maybe you want to be in a more exciting place. Or maybe, I just want to work, do my shift, see my people, and just get out. I just want to go home. Forget this. So those are all things to think about. And those are all valid points. That's what I call basically a little bit of an anecdotal student resident model, where, people, and I'm going to be quite honest and frank, people say, hey, I want to go to med school. I want to be a rural doctor. I want to do this and that. I want to be underserved. I'm in serve in underserved areas and all this verbiage, if you will, and all this rhetoric. But at the end of the day, when you're done with your training, you might lose a little bit of your sight. You might lose some of that passion. And that's where you have to keep that going as a resident. And you have to really look into yourself and say, okay, do I really want to practice in that setting? Or do I just, and by all means, I'm not saying selling out. Please don't get me wrong. Please don't get me wrong. But, or, do you want to, go to a city, go to a location, a suburban center where you really, you practice the medicine that you want to practice at the end of the day. You practice in a place where you feel comfortable, where you feel that you can get your best growth as a clinician, and you can take care of your family. Those are things that I looked for. And although I live more in the outskirts of the Phoenix metropolitan area, I enjoy the drive to some of these rural settings. And, I've enjoyed my practice for the last decade. I love what I do. And it's something where it is truly a lifestyle option. I had an option after residency to go to a very rural setting. And my wife said, you know what? I'm not really wanting to live out there. And I said, okay, fair enough. I'll still be able to practice my medicine, but I'll have to, kind of live in a place where my family wants to be. And so those are things that you have to think about as you go through medical school and residency. You're going to experience the most growth you've ever had in your life these next few years as you go into med school and then onwards and upwards. You have to, pardon the adage, learn and know of thyself. Know what you can handle, know of your capabilities, and then at times you have to exceed them. So to that end, just want to briefly go over a couple last things before we go into some Q&A. There's some rural emergency medicine resources out there that you can look at from ASAP. Ed Leap is an ER doctor, has been practicing for many years, and he has a great article on why he likes practicing rural emergency medicine. There's a journal that was published for a couple of years on rural EM resources that I encourage you to take a look at. But these are some of the official EM resources as well, ASAP, SAME, AEM, and EMRA. And, thanks so much for your time, guys. The first picture on the lower left is the lights in the background of the Phoenix area. That's a sunrise at about 5 a.m. when I left, as I was leaving one of my rural sites a few years ago. And I love that drive. I love being out there and the middle of nowhere. I love camping. I love being out with my family out in the woods. The other picture is my wife and kids with the San Francisco peaks in the background. I love being outdoors. I love the capability of going to the urban center. My wife and I do enjoy going to the symphony. We do enjoy a lot of the trappings of the city that the city has to offer. But at the same time, we do, and I do enjoy practicing in that type of rural setting. So let me go a little bit more into the chat. And then I'll work with the host and panelists on putting a link to the presentation. But a couple of questions that have come up. So, how do you build leadership and problem-solving abilities over time? So that is a great, great question. That's something that you develop as you get a little bit older. If I can ask the hosts if they can kind of re-enable the video, more than happy to.
Yes, first, hello, Dr. Cortez.
Yeah.
And everybody in the audience. My name is Rani and I'm the host director, and I'll actually be doing the Q&A with you today.
Oh, you will? Okay.
Yes.
So one thing, as you do the Q&A, there's just a couple questions that came up on the Q&A section. If that's okay,
Yeah.
if I can just address those for a sec.
Yes. And
All right, cool.
if you could stop sharing your slideshow, that would be great.
Cool.
Awesome.
Sorry with the, all right, cool.
All right.
So with the,
For the first question, it says, how did you build
Yeah.
your leadership and problem-solving abilities over time?
Okay, so how do I develop those leadership and problem-solving abilities? Those are things that, as I was talking about earlier, you develop on your own. You are going to look at different models of people that you work around. And as you continue the learning process, as you continue your education, you will develop those leadership skills, if you will. And those are things that you develop over time. It's not one thing that you develop within 24 hours or a couple of weeks or a couple of months. It's something that you develop over the course of years and whatnot of practice and experience. So hold on, there's another question here. So I'm sorry, go ahead, Raniel.
Yes. So for the next question, they're asking, do you think there's a select personality type for emergency medicine? How did you know it was for you?
So how did I know that EM was for me? So it's interesting. When I did a mock interview for the U of A, when I was an undergrad in the early 2000s, the person that did a mock interview for me was an EM physician practicing over in county. And he said, hey, I'll do the mock interview. Hey, no problem meeting you. I'm going to meet you at Starbucks over by ASU at 5 p.m. after I pick up my kids. And I said, that's a specialty for me. So the ability to have, that openness, that ability to have the freedom of schedule, not tied to a pager. I was tied to a pager when I was an undergrad working in organ and tissue transplant, where I would be on call from like a Friday to a Monday, and I would have to leave class. I would be working all weekend. Luckily, we didn't have any kids at the time. We had just gotten married. And it was, it was challenging. It was one of those things like, man, I don't really have one on pager again. I had one during residency, and then afterwards, I was happy to just drop it off. Now, I still have a phone as a director. I'm constantly, answering texts and things like that. But one of the things that I really enjoy about my specialty was, that ability to be a little bit free, a little bit more free within the House of Medicine. Now, I'm going to dovetail into one of the other questions that was asked. The care of the patient in the acute setting, being able to practice critical care not only in adults and kids, and being able to provide that service to not only the community, but my neighbors, and also in practicing wilderness medicine, are some of the biggest things that led me into emergency medicine. The ability to know what's going on in that patient, or be able to figure out or have a list of things that could be going on with that patient at that point in time, is what led me into EM as a specialty. Also the fact that, I'm being quite honest with the panelists and everybody attending. I like the fact that I can just go, I can work, I can provide the best care that I can for a period of time, and then I can go home. And then I repeat again the next couple of days. So I know you're going to be asking, kind of going along with another question. So some of the pros and cons and skills you need to work in emergency medicine: definitely time management, organizational skills, the ability to think on your feet, and the ability to quickly think about what is going on with that person, what's going to kill them within the next 15, 20 minutes. Now, it can seem overwhelming, a little daunting at first, but that's what you do training for. That's why you go into residency. Without being too controversial, that is why you go through a residency process. 3 to 4 years to develop those critical care skills. 3 to 4 years to develop that know-how, that differential diagnosis development capability, to be able to look at that patient and say, okay, you don't have this, but you probably have this. We're going to go down that pathway and make sure you're not going to die. Make sure that what your complaint is not one of those critical complaints that could kill you. So that's where some of the skill sets that you develop during residency. You can start developing them during medical school, but you are going to be continuing to develop them during residency as well. And hopefully by the time you graduate, you'll have that skill set behind you. Now, you're going to continue developing those skills as you go on in your practice, but those are some of the skill sets that you develop during a residency process.
Awesome. Thank you, Dr. Cortez.
No problem.
And then for the next question, we have, apart from being in a less populated area, what are the differences between working in emergency medicine in rural versus urban areas?
Oh, and as I mentioned a little bit in the presentation, in the rural setting, you have less resources, less specialty support, less backup. In urban areas or major urban hospitals, you have full specialty backup. You're not that little cat on your own, looking for the attending. You have the trauma team next to you, you have the other specialty support next to you or available to you to come down to the emergency department and see that patient, that you can just hand the patient off to them. And that's one of the biggest differences between rural and urban areas. Rural areas, you really have to think on your feet. You are on your own. And you have to develop those skills to take care of that patient quickly and transition them or transfer them expeditiously to the tertiary care center.
Thank you. And then I'm also wondering, Dr. Cortez, how many patients do you typically see in a day?
Oh, it depends. It really depends. In a rural setting, I was talking about 12 hours earlier.
Mm-hmm.
That was an interesting exception in an urban center where the group that staffed it, the company that staffed it, really wanted to get the most out of you. It wasn't very conducive to a good lifestyle, by the way. But usually I see anywhere in a rural hospital, limited resource setting, I might see 1, maybe 2 patients per hour in a 12-hour shift. When it gets busy, like it's been busy the last couple of days in our facility, I was seeing upwards of, closer to, more than 2 patients per hour. But it's a little bit of a misnomer because I was really seeing 5 patients per hour the last couple of hours of my shift. The first half of the shift was relatively empty, and that's typical for a rural setting where during certain parts of the day, you're not going to see very many patients, and then everybody comes in during a certain time. It happens in urban centers as well, where everything just kind of ramps up at a certain time, a certain hour, and then you have the backup for it. In a rural setting, you don't. So you're stuck there. And that's where you depend a lot of the nurses and the techs to kind of help get these patients back, see the sickest patients first, and then triage to the lower acuity patients like the ankle sprains or an earache, things like that, kind of like a little bit lower down the list.
Great. And I think this is a good transition to the next question,
Mm-hmm.
which is, do you encounter frustration from the limited access to resources? How do you tackle this? Also, how do you make patients feel at ease or in good hands?
So that is I experience that every single day. I mean, that's what I do every single day in a rural setting where, I do get frustrated with essentially apathy that you get from the large institutions, the tertiary care centers, where you've invested so much time into your patient. You put them at ease and you let them know, hey, you have a pretty serious condition and we need to send you to a major center to get taken care of or to get the care that you need from those specialty services. And so I routinely come across, whether it's a admitting physician at these centers, like a hospital physician or a specialty physician that says, well, why are you sending them to me? Why this? Why that? Essentially, it's just it's just another person I got to take care of from this far-flung place out in the middle of nowhere. Why me? There's a lot of stabbing yourself in the chest in medicine from doctors. And, it's been there for eons. And it's quite frankly, that has to stop. But regardless, it's something where I just kind of take a step back. And to answer Leslie's question, I take a deep breath and I don't yell on the phone or say, blah, 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 you, or, you're a bad doctor or XYZ. I just take care of my patient the best I can and reassure them that they're going to get the care that they need. And then that provides me with the emotional support, if you will, to deal with some of these issues. I've had specialists berate me on the phone saying, you're stupid. Why are you sending this? I don't need to see this. Or, why are you sending this patient to me? And, why aren't you sending him to this other place? So I deal with a lot of those frustrations every day. more often than not, it's interesting. I've actually, in a small number of cases, I've had those specialists actually call me back and apologize. We all have a bad day. We sometimes blow up on the phone.
Thank you.
Mhm.
And for the next question by Joshua, since you have more responsibility over a patient's life in the rural setting, does that make death harder to deal with?
Well, it's a great question. I've been practicing long enough where it doesn't really get me as much as it used to when I started practice. Pediatric codes, when a child dies under a tragic circumstance, that's difficult. And so you almost have to develop kind of like this moral core where, interesting, I'm actually dealing with this right now in my rural site where you do have that child that's dead or that person that's dead coming in. And so in that instance, when that person comes in and there's a possibility to resuscitate them or bring them back, you have to work closely as a healthcare team to really get the medicine in front of you, get that patient kind of separated a little bit, the patient from what's going on, take care of them in an expeditious manner, see if there's a way to reverse what's going on. With the understanding that, if they're going to come in dead, they're probably already dead and there's not much you can do for them. But you have to be a competent clinician with all your skills ready at your disposal to take care of them. And then when you're done, they're dead. It's okay to cry. It's okay to come together as a team and say, hey, we did our best. And we can debrief, we can decompress. I did that 2 weeks ago with our team where we just sat in a room and we just cried for a half hour. We had to. You have to. I pronounced a dad from, he had 2 boys with him, and it was a pretty tragic circumstance. And, afterwards, it was one of those where, I told those boys, they were my boys' age, hey, your dad's dead. And, it was difficult. It was very, very difficult. But it's okay to cry. It's okay to take those emotions and just let them, come out at a later moment. But at that point in time, you got to take care of that patient. You can't let that emotion block your way saying, oh crap, there's a dead person, there's a dead kid. And you got to take care of them. And these skills you develop as you go on. As you develop your practice during residency, and then you go on your own practice. So it's okay to have emotions.
Thank you for sharing that, Dr. Cortez.
Yeah,
I think that's such an important point, actually. And even especially as undergraduates, we may also be stressed, but also that you have to acknowledge it as well. And it just shows that, we're human, and just realizing you're not alone. You're not alone in this situation, especially when you're doing it with your team. I think that's such a great point. So thank you for sharing that with us.
Yeah, no problem.
So the next question is, Dr. Cortez, what was your personal motivation to pursue emergency medicine in rural areas for particular?
So, it started working as an undergrad with migrant health, excuse me, and also working with organ and tissue recovery. We used to fly out to rural hospitals and rural settings. And I find myself a little bit more at ease in a rural hospital. I don't want to say that, big fish in a small pond or whatever like that, but more of, I think there's a little bit more collegiality with the medical staff at rural settings. There's a little bit more of an interpersonal relationship with the patients that you have at a rural hospital. And so those are some of the big motivations that keep me working there. You get to know some of these folks over the course of several years, and there's a little bit more intimacy among the staff rather than a gigantic institution.
All right. And then for our next question is, what habits or mindsets have empowered you in your medical journey?
Do
you have like a motto in life?
A what?
Like a motto in life?
So we have 2 minutes. Okay, good. We have more than 2 minutes, but this is. So, a long time ago, it was a dark and stormy night. And I had an elderly patient come in, and he was sick, had a heart rhythm disturbance that was threatening his life. And I was the lowly intern. I just graduated medical school. And so I was like this. I was like the picture of that cat. I was looking around for the attending, and I was just an intern. I was a resident. I wasn't the attending or anything like that. And so I called the senior person who was my backup. Excuse me. And he said, I don't care. You do it. Like, well, I was going to do this, this, and this. I don't care. Click, hangs up the phone. So I give the patient medication. He does okay, but he's still a little bit sick, needs more medicine, needs to get that heart rate under control. I call this doctor again. Hey, can you help me out? No. Click. So the family could see the sweat beating on my forehead, the anxiety. I'm like, oh man, I'm going to kill this guy. So I gave another medication. It starts working a little bit, but not yet. The patient's blood pressure starts dropping a little bit. So I give him some fluids, and I call this person in bed, and he just on the phone just yells at me. Don't call me again for this issue. You should know what to do. Click. So I'm like, all right. I guess I'm on my own. And so over the next couple of hours, I was working with some of the nursing staff, and I, gave a couple of the medications. Heart rate stabilized a little bit more. The patient did fine. He survived. He did great. Family was happy and everything else. And so the next day, the chief of the service, eventually this doctor got fired for other reason. The chief of the service came up to me and he said, hey, what happened last night? I heard you had some problems. The nurses told me. I go, well, I had this, this, and this. I called XYZ. He blah, blah, blah. And so I told him the substance of what happened. And he goes, next time do this. But before that, did you take care of your patient? Well, yeah. Did you take care of your patient, Dr. Cortez? Yeah. So you did your job. So that's my motto. That's my mantra is take care of your patient. And I've had that with me for, 14 years now since I started residency. That's my mantra, and I live by it every single time I go to the ED. Did you take care of your patient?
Thank you so much, Dr. Cortez.
No problem.
And thank you to everyone who listened to his presentation today. So we'll be wrapping up this session with the transitioning to our lunch break. But before that, for all the attendees, we do have a quick poll. And once again, we want to thank you, Dr. Cortez, for your time and all your insights.
Yeah, no problem. Anytime.
All right, everyone. And I just want to remind you of the Kaplan and BMO resources that we have. So feel free to fill out the forms to enter to win a Kaplan course and free BMO resources. So we'll be back, and we hope to see you soon for the game session.
Hi, everyone, and welcome to the MPHC Kahoot with Jacinta and Ruhi. Today we're going to be playing a Kahoot, and we're super excited to have this with all of you. For those of you who aren't familiar with Kahoot, Kahoot is a fun and completely virtual trivia platform. Today's Kahoot will have 100 questions with various topics and different backgrounds, such as pathophysiology, various medical knowledge questions, and different healthcare career questions. To play, open up a browser on your device or through a separate device and type in kahoot.it/join. We will also be putting the link in the chat in a second. Once you click enter, a screen will come up for you to enter the game pin, which is shown on the screen right now. So the game pin is 224766. After typing in a nickname, you'll be officially in the game. So once the game starts, some questions will pop up with answer choices on the screen, and that will be shared on Zoom. And to select an answer, go to the tab that you were on where you put your nickname on it, and then click the corresponding shape for the answer that you want to select. You will only have 10 seconds to answer the question. Don't be discouraged if you don't know the answer to some or a lot of these questions. The goal of this Kahoot is to allow you all to learn together and to have fun. I encourage you to also take any notes on anything that comes up that you want to research some more later on. So just feel free to add your nickname to the Kahoot, and we'll give you a few moments to do that. I also just added the link to the Kahoot, so you can join using that.
We'll go ahead and wait about 2 more minutes for anyone else that needs to get joined. Okay, we'll go ahead and get started. So the first question is, what are NPHC's values? knowledge, unity, and empowerment, knowledge, kindness, and unity, encouragement, unity, and knowledge, and empowerment, unity, and health. That was fast. Okay, so the correct answer is knowledge, unity, and empowerment.
Nice. So the next question is, what is the theme for this year's conference? That's fast, lot of answers. Yeah, so the theme for this year's conference is unity in healthcare.
Great job, Krishna. Okay, our next question is, what does NPHC stand for? Yes, so NPHC stands for the National Pre-Health Conference.
So who is hosting this session?
Hopefully everyone gets this one.
Yes. Ah, okay, so Ruhi and I, Jacinta, are hosting this session. Oh, we have a new leader. SR.
So the next question is, who are the founders of NPHC? Pictures are up here too. Yep, everyone got this. Alexia and Alejandra. Okay.
How does NPHC continue to outreach throughout the year? Nice. So we actually do all of these things. We do Instagram live interviews, we host smaller conferences and events, and we also send newsletters with updates in the healthcare community. So stay tuned for that throughout the year.
Okay, so what type of doctor treats diabetes? Yep, an endocrinologist.
True or false? To become a pharmacist, you must attend medical school. Correct. So false is the right answer. You do not have to go to medical school to become a pharmacist.
What's the difference between a nurse practitioner and a doctor? Yes, so doctors get an MD, but in general, nurse practitioners and doctors all administer emergency care, take medical histories, and administer diagnostic tests.
A collection of signs and symptoms that usually occur together in response to a certain condition is referred to as a, what is this term? So yeah, this is the definition of a syndrome. Don't feel discouraged if you did not get that one. I probably wouldn't as well. SR is still on top.
Okay, so this is the definition of how well a person can get health information and services that they need and how well they understand them. Yes, so this is the definition of health literacy.
Next question. What type of doctor treats Hodgkin's disease? Yes, so a lymphologist treats Hodgkin's disease because it's a disease that has to do with the lymph nodes.
So these are public health workers who investigate patterns and causes of disease and injury. Yes, almost everyone got this. This is an epidemiologist.
Which of the following is not a function of the respiratory system? Nice job. Yeah, so the answer was decreased temperature of air.
What percent of nurses are Hispanic or Latino? Yes, so only about 10% of nurses are Hispanic or Latino.
What is the name of the standardized test needed to get into med school? Yes, almost everyone got that. It's called the MCAT, something that I will need to be studying for in the future. Oh, our LW is doing amazing, still #1 for a long time.
True or false, pharmacists are part of the medical team? Yes, this is true. Pharmacists do play an integral role in medical care.
What is the most popular specialty in medicine? Yes, so primary care is the most popular specialty, which is something I didn't know before working on some of these questions.
How many years is dentistry school? Yep, dentistry school is 4 years.
Given the symptoms, diagnose the illness: sneezing, running or stuffy nose, sorry, I cannot read, sore throat, and a cough. Yes, so given these symptoms, this is a rhinovirus, also known as a cold. Some new leaders on the board. LW still in first place.
True or false, you should get a tetanus or diphtheria shot, a booster shot every 15 years. Yes, this is false.
Severe gum infection that can lead to tooth loss and other serious health complications. What is this? Yeah, so the correct answer was periodontitis. Congrats to those who got it, and don't feel bad if you didn't. Oh no, LW went to third, but now we have SR back on top.
help identify the possible risk of genetic condition by gathering and analyzing family history and inheritance patterns. Who is this? Yes, this is a genetic counselor.
True or false? Research experience is required to be admitted to medical school. Correct, it is false. You do not need a research experience. However, a lot of applicants do. And it can give you a better idea if you want to potentially go to medical school in the future.
What is a sign of someone with Broca's aphasia? Yes, the correct answer is broken speech.
True or false? The terms psychologist, psychiatrist, therapist, and counselor are interchangeable. Correct. The answer is false. Although they may seem interchangeable at first, they all have different qualifications and some differences in the things they can do in their role.
What is a health provider who specializes in the evaluation and treatment of eye movement problems and binocular vision? Yes, so the correct answer is an orthopist. Only one person got it. That's hard, though. I definitely wouldn't have gotten that one.
True or false? Veterinarians can specialize. Correct. Yes, everyone got that right.
What is a podiatrist? Yes, so podiatrists treat disorders of the feet.
About what percent of nurses are male in the healthcare industry? Yeah, so only about 10% of nurses are male in the healthcare industry. SR is still in the lead.
True or false, PAs may be dependent on physician oversight. Yes, the answer is true.
How long does it take to become a doctor? Yeah, so it depends on the person, really. You could go to medical school right after undergrad, or you could take a gap year, or you might do something else, some other career before you decide that you want to become a doctor. It's completely up to you.
True or false, you must be a science major to be pre-med and apply to medical school. Yep, the answer is false. You can really major in anything you want as long as you take the prerequisites.
True or false? Gap years are frowned upon before attending medical school. Yeah, so the correct answer was false. It is not frowned upon if you want to take a gap year. And in fact, many applicants take at least 1 to 2 years off before applying to med school.
When is the best time to submit your medical school application once the application window opens? Yes, so as early as possible. Okay, so we are running out of time, so we're going to go ahead and stop here, but I'll keep the scoreboard up. So SR is in the lead, followed by Krishna and then LW. So thank you so much, everyone, for playing, and stay tuned for our next speaker.
Thank you so much, Ruhi and Jacinta. I will go ahead and send out the poll, and we will have Dr. Dorfman join us very soon. So please wait a few minutes and we'll wait for them to join. So I'll send out the poll. Please let us know what you thought about the game session. And we'll be back very soon.
Are you able to see me or no?
Hi, let me ask to start your video. I think you should be able.
Video. Let's just see if that works. Yeah, okay, it's not connecting with video. All right, so we'll have to just do it on your phone. But let me share the screen.
Perfect.
Okay, I'm sharing my screen. Are you able to see it?
Yes, we can see it.
So you can see the presentation?
Yes.
Okay, fantastic. All right, so what we're gonna do is then join through with the phone and use video that way.
Okay. Yes, feel free to join and let me know whenever you join so that I can make sure you're a panelist.
Okay, so let's try. Okay, so let's go to your email. Dr. Bildy.
Yeah.
That's it. Oh, here.
I need to change.
Okay. Okay, let's see. Oh, okay, perfect. So that works. Okay, this is weird. All right. Okay, thank you so much. And then he's just finishing getting ready, and then we will do this. When do you, yeah, how do we start? Like, when do you want to start?
Recording in progress.
Okay.
Sorry about that, everyone. Please give us a few minutes while we join. Hang tight.
Can you guys hear me?
Yes, we hear you.
Okay. I don't see me anymore.
You're right here. Do you want me to pull it closer to you?
No.
Okay, so hello everyone. My name is Rani and I am NPHE's host director. I have the pleasure of hosting today's session with Dr. Bill Dorfman, who is America's dentist and has been the featured dentist on ABC's hit show Extreme Makeover, and as a recurring host on the CBS Emmy awarded show The Doctors. He is also the inventor of Zoom Teeth Whitening, where he helped grow his company, Discus Dental, from 0 to over 1.3 billion in sales. In addition, Dr. Dorfman has more than 20 Lifetime Achievement Awards, 2 Guinness World Records, is a New York Times bestselling author, and has raised over 45 million for children's charities. Today, he will be sharing with us how Instagram can help build your dental practice. Please give a big welcome to Dr. Dorfman.
Hey, thank you so much. So for some reason, that was not the correct introduction. We sent it over this morning. I'm not just going to talk about Instagram. I'm going to talk about social media and Instagram as well. For those of you who don't know me, I've been practicing cosmetic dentistry in the Los Angeles area, right around Beverly Hills for the last almost 40 years. I graduated from University of the Pacific Dental School. I did a 2-year residency program in Lausanne, Switzerland, immediately after dental school. And then I started practicing. And before I even start, I want to share something with you. When I came to Beverly Hills, the last thing they needed was another cosmetic dentist. Like, they were all over the place. So what I do? Well, there's something we say at my LEAP program, and I'll talk a little bit about LEAP in a little bit. It's a motivational leadership program for high school and college students. I copy genius. And what I mean by that is I found the 5 most successful dental practices in the area. And I called all of them and I said, can I come in and shadow you? And, a lot of students come and shadow me. I probably have had thousands and thousands of students shadow me over the years, but none of them did what I did, even back then. And this was like 1986. I didn't just come in and watch the dentist drill teeth. What I did is I came in 10 minutes before the first patient. I wanted to see the intake forms. I wanted to see, what the patient was given when they came in, how they spoke to the patient, then how they brought the patient back to the treatment room. And then once in the treatment room, how they presented treatment, how they presented payment options, then how they delivered the dental care. And then finally, how they dismissed the patient, collected money, and set the patient up for the next visit. So it was kind of the whole ball of wax, and, most dental students, none of the dental students, thousands of dental students that have come to my practice have ever done that. So if you have any questions, please put them in the chat. Is my sound okay, you guys? Because I can't tell from my end. Am I okay?
We hear you clearly.
Okay, awesome. All right. So, when I started practicing, obviously, the first thing you need are patience. And that's a real challenge. Things were different back then, but I'm going to show you some things that you can use for social media so that when you do, get out of dental school and you open your practices, these are some things that will help you out. Brandon, my thing's not advancing. I'm going to need you to do it. Can you push the advance button? Just sit in the chair right there. You see on the bottom? Nope. Yes. Yeah. Oh, it's not responding. Let me see. Hold on 1 second. We're having a little technical difficulty. Why is it not moving?
Because we got to get. I'm going to click on slideshow.
Well, what are you on? Okay, so hold on. Click on that.
This one.
Okay, so I already mentioned this, copy genius, and I think that, once you set up your practice or you know where you want to practice, the smartest thing you could ever do is look for other successful practices in that area, see what they're doing, and then do it better, right? So I'm going to talk a little bit about my LEAP program, but basically, LEAP is a motivational leadership program. We do this for high school and college students every year. This was last year's LEAP program. And I basically teach students the skills that they need to be successful in life. And if you want information on LEAP, go to www.leapfoundation.com. And I bring in amazing speakers. I've had Anthony Hopkins, Paula Abdul, Kathy Bates, Jason Alexander, Michael Strahan, Apollo Ono, the most decorated Winter Olympian in history, and on and on and on and on. But if there's only two ideas that I want students from LEAP to walk away with, it's this. One, don't wait for opportunities in life, make them. And number two, when you do get an opportunity, don't take it, master it. And I'll give you the best example I can for that. When ABC gave me the opportunity to be on its hit show, Extreme Makeover, this was kind of the inception of, reality TV. They had never had a TV show like this before. And I watched the first few episodes, and I'll be 100% honest with you, I stunk. I mean, like bad. I was not good at all. Not the dentistry. The dentistry was easy, but I wasn't used to being on TV. I wasn't used to doing dentistry with lights and camera and this and that. So what did I do? Well, instead of just sitting there and feeling bad for myself or waiting for them to fire me, I was proactive. I took acting classes, hosting classes, teleprompting classes. I went and learned how to be the best version of me that I could be. As a net result, our business exploded. Discus Dental was a company I used to own. We sold it to Philips, and we invented Zoom tooth whitening, night white, day white, Zoom, all these other products. And our company had a really steady trajectory in growth. We went 2 million, 4 million, 8 million, and we kind of plateaued at like 67 million. We just couldn't break that barrier. My first year on ABC's Extreme Makeover, we jumped to 101 million in sales. The next year, 134 million in sales. And the third year I was on the show, we did almost $200 million in sales as a result of me not just taking an opportunity, but mastering it. So when you start to, and I don't care if you decide not to go into dentistry or any business you do, don't go halfway, go all the way. This is a cool example. You all know Katy Perry. She's a good patient and a friend of mine. Katy did a video called the Dark Horse video. And her makeup artist, Johnny, came in and said, Doc, we need a grill for Katy. So on the left of your screen, you'll see the grill he showed me. And he said, can you make something like this for this video? Well, I said, what's my budget? He said, $1,500. I'm like, are you kidding? You can't make a grill for $1,500. I said, I'll just do it for free. I called my friend who owns the largest jewelry store. It's called 14 Carats in Beverly Hills. They gave me $1 million in jewels on consignment, and I made $1 million grill by Dr. Bill for Katy Perry. This grill has over something like 17 billion views on YouTube. I'm crazy. And I got all kinds of media and exposure and everything. So this was an example of not just taking an opportunity, but mastering it and then maximizing the exposure. I mean, it was just crazy, the kind of press we got. And it was my second Guinness World Book record, the $1 million grill by Dr. Bill. So what's the history of marketing? Well, we went from the printing press and radio and TV to magazines and yellow pages, social media. I mean, today it's all about social media, and what you need to do is focus on turning your patients into ambassadors to help build your practice. And if you do it right, you can. And we've done all different kinds of things over the years. This is a billboard that we put up, which was, I would say, minimally effective. We tried a different format. Again, it was okay. But for me, the thing that's really been probably the biggest contributor to new patients in my practice is my website, my mobile site. Sorry, I put my phone on Do Not Disturb, but it doesn't listen to me. Instagram, and then Google reviews. If you notice, I don't have Twitter on here. For me, Twitter doesn't really move the needle. It just doesn't. I don't get patients from Twitter. I get tons from Instagram. And I'll talk to you about Google reviews and how important those are. I do nothing on Facebook. Actually, I've never even opened my Facebook. I mean, I know I have a page. I don't even know what's on there. I couldn't tell you. But I'm really, really active on Instagram. And in fact, if any of you ever want to contact me directly, I'm probably the only person with over 1 million followers on Instagram who actually answers all of their own DMs. So just DM me. It's Dr. Dr. Bill Dorfman. And I promise you that the person responding is me. When you do build a website, just take a picture of this slide. It's really important. Make sure you put up your social media icons. Make sure the copyright year is current. Incorporate blogs into your site. Make sure you use high quality images. That's so important. Check your spelling and grammar. It's important. Believe it or not, it hurts your SEO when these are bad. And use Google Translator. Not everybody speaks English. So it's good to have that. So when you go to my website, Dr. Bill Dorfman, you can't not know I'm a dentist. Like, bam, I'm a dentist. You know, you see it right up front. And then I highlight like the most important things, I'm on the doctors, I'm on Oprah, I'm a, Larry King Live. I mean, these are important things that, that I want patients to see. So all that comes up right away. And then, I gradually put down, some of the celebrities. I've got Katy Perry, Travis Stork from the Doctors, Anne Hathaway, Jason Alexander, Deborah Messing, Hugh Jackman, Mark Wahlberg. I mean, all of these patients of mine are totally cool with me having them on my website. And, for the area that I'm in and all that, it helps. Also, before I designed my website, I looked at tons and tons of websites. I wanted mine very clean, very modern, easy to follow. I mean, these are all important things, and people, even if they find you on Instagram or, they find you on TikTok or another social media outlet, a lot of times they go to your website because they want to see, more. The camera that I use is this Nikon. It's a D850. It's the best one I know of. It's specifically made for dentistry with these 2 flash hoods on the side, and you'll get beautiful, beautiful, beautiful images. So here's a before and after. So this was taken with my old camera, and you can see the color isn't really great on the gums there. It's a little too red and whatever. And if you look at her teeth, 99.9% of the people in America would say, well, those are great teeth. Why does she want cosmetic dentistry? Well, this is my patient Joy. She just landed the new Guest campaign. She's the new Guest girl. And she didn't need a lot, but what we did is we bleached her teeth. I did 4 porcelain veneers on 7 through 10. And we did just a teeny bit of bonding just in the corner of her 2 upper canines. And we transformed her smile from this to this. Now look at the difference in quality in photographs. This is with my new camera. And look how beautiful and natural that looks. And again, for most people, the first smile would be fine, but for Joy, it wasn't. And if you want to follow her, it's Joy Corrigan. She's a lovely lady. When you post before and after pictures on your website, they must be impeccable. I mean, like I always say, don't put them up if you wouldn't show them to a room full of 100 dentists. So this is a nice before picture of a patient where we just only did her anterior 4 teeth. One's an implant, she's got a crown. And I mean, this is a hard case, but when you look at the after result, it's really kind of spot on and very natural and beautiful. Again, another really difficult full mouth case, and that's his after. Testimonials are great. I think I currently have close to 2,000 5-star Google reviews now. Why are those important? I'll tell you why. If somebody's looking for a cosmetic dentist and you have 2,000 5-star Google reviews, it pushes you to the top of all the search engines. So it's really great to optimize your SEO. In fact, pretty much if you're looking for the best cosmetic dentist anywhere, like I would say west of the Mississippi, I'm going to come up, right? And that's because we have so many Google reviews. How do you get Google reviews? You ask for them. You know, when patients leave, my front desk always says, you know, how was your visit today? And if anybody says anything positive, she'll say, hey, would you mind doing a quick review for us? And most patients are pretty nice about that. They get the importance of social media. I also have my Instagram on my website. The top 7 things that you need for your mobile website. Most people will find you on a mobile device. So it must load quickly, right? You have to have a click to call button, has to be easy to navigate. Find us is mandatory, clean, minimalistic, very current, less is more. Who creates it? Well, I mean, I always hire specialists because I want to make sure everything is done properly. And I know I do teeth well. That's all I know. I don't do all the other stuff that well. So I always hire people. But, you know, you can do it. You can do the research and all that. But I prefer to use a specialist who knows what they're talking about. Here are some important mobile site facts. My vision's not that good, so I'm going to have to move up close to read these. 2019. Google drives 96% of mobile search traffic, Yahoo 2%, Bing 1%. 80% of social media time is spent on a mobile device. Over 50% of smartphone users grab their phone the first thing in the morning when they wake up. Fact, 61% of users are unlikely to return to a site if they've had a hard time navigating through it. And today, mobile advertising is 72% of all US digital spending. So it's very, very powerful. If your website is responsive, user-friendly, efficient, visually appealing, but has poor or little content, it's all for nothing. So make sure that your content is rich, it's interesting, it's easy, it creates a great experience, and having that is the best way to get higher SEO rankings, okay? Remember, your website is available 24/7, right? The best way to maximize its use is to keep its structure and overall layout of the website simple and user-centric. Irrelevant information should be omitted. More isn't better. Better is better when it comes to websites. The colors that you use should be constant. They should be permanent. They should be part of everything you do in your practice, in your websites, in your, everything you do should have the same colors. And remember that colors create an emotion. They cause you to emote. So if you want to know what colors cause different emotions, take a picture of this slide because it's pretty good. Most dental websites, you're going to see a lot of blue. Why? Blue, peace, serenity, confidence, integrity, tranquility. That's great. You don't typically see red on a dental website. Yes, it's great for love and passion. It's also the color of blood and danger and energy. So, that's not an ideal color for a dental space. Most dentists will use colors like blue, they'll use grays, they'll use greens, purples, things like that. SEO friendly code, make sure, and this is something that I know nothing about, but apparently there are these things called tags and structure that are important. So when you build your website, make sure that somebody who builds it has the wherewithal to determine that, that you're following the guidelines and that you're optimizing everything you can possibly optimize. Users look for social media to engage with and turn to in order to establish credibility on a website. So again, you want to make sure that you're listing your Facebook and your Instagram, your YouTube. I am pretty active on YouTube. I have a really big channel, and we put a lot of stuff up there. It has to be a reliable and secure host. Don't mess around with that, because if you have an unreliable one, you can lose everything. So, make sure that that's not going to be a problem. The guy that I use to do my website is excellent. He's very slow and very expensive, but you're welcome to call him if you'd like to, and he can help you. Again, copying genius, I think, is one of the smartest things you could do. Look at dentists in the area where you want to practice and find the sites that you really like the most and kind of fashion yours after those. I'm not going to spend a lot of time talking about these things because you guys know more than I do. Facebook, you have, in the old days, we would say, word of mouth. Well, Facebook is scalable word of mouth. I would always say when a patient comes into my practice, I don't want to meet their expectations. I want to exceed their expectations, because in general, if you exceed expectations, on average, they'll tell 10 people. Well, with social media, with Facebook, with all these things, you can tell 110, 10,000. I mean, there's really no limit. You definitely want to make sure you have a fan page. If you want to also keep a personal page, you can. I could care less about my personal stuff, so I don't put that on there, but I do have a fan page. And again, I'm not very active on Facebook. These are things that, are good with all social media: asking questions, be funny, use images, and then obviously you want to put a lot of dental stuff on there. These are just some pictures I've used in the past. Twitter, for me, I just don't do it. I started off on Twitter, and I literally don't think I've posted a single thing on Twitter in 5 years. Instagram. Increasingly a more powerful marketing tool owned by Facebook. Capture and share moments, thoughts, photos, videos, stories, and live content. I used to do something live every Wednesday at 11:30. Engage and interact with potential patients. Show before and after cases. Office news, upcoming events, personal events, travel, family, whatever you want to put up there. Throwback Thursdays, Fitness Friday. I mean, you can do pretty much whatever you want. Albert Einstein in 1921 got his first Nobel Prize. And as he was being lauded for his brilliance, he said, "It's not my brilliance that made me successful. It's my creativity." It's not your brilliance that will get you exposure on social media. It's creativity. If you come up with a really cool idea or whatever, I mean, things blow up. And I think a lot of it blows up more on things like TikTok and all that. And again, for some people, TikTok is a great, way of engaging. For me, I feel like it's pretty young, and people that come into my office and spend $50,000, $60,000, $70,000 on a case, yeah, they're on Instagram. No, they're not on TikTok. 3 tips for Instagram. Niche focus. You need to decide, who are you targeting? Who are you talking to? Who do you provide for? My Instagram is mainly dental, fitness, and leap. That's it. Those are the main 3 things that I focus on. You could say, well, why fitness? I'll get into that in a bit. But, Every third post I post is dental. Again, I say copy genius. I probably am copying like 10 very, very successful dental influencers. So if you copy me, you're already copying, now you're copying 11. But look and see what I do on my Instagram. It works. Every third post is a dental. And then I put the TV shows I'm on. I put, a lot of fitness stuff. And then occasionally when I'm on trips and stuff, I'll put some pictures from that. Consistency. Success demands on follower retention. So give them what they want. If you want to have people keep following you and they're following you because they like dental, keep giving them dental. If all of a sudden, you start showing them, swimsuits, they might not be interested anymore, right? Engagement. Comment and respond. I think that's really important to do, and I try to do that as much as I can. I will promise you this: if you ever DM me, I will answer. Okay. Instagram bio tips. So when you build your Instagram page, your name and your niche, this should be bold and searchable. Okay, you're allowed to have 30 characters. So at the top of my Instagram, it says Dr. Bill Cosmetic Dentist. Okay, now the reason I did that is doctor is searchable, Bill is a throwaway because there could be a bunch of those, but cosmetic and dentist are also searchable. So if people are looking for anybody who's a doctor or who's in cosmetics or who's a dentist, those are three really important things that I wanted on there. So that's how I came with Dr. Bill Cosmetic Dentist. Your username is consistent on all my social. It's all Dr. Bill Dorfman on Instagram, on Facebook, on Twitter, on YouTube, on anything I do with social. It's Dr. Bill Dorfman. Your Instagram bio tips. Write your bio. You can use emojis, make it interesting, but you need to write it in notes on your phone and then copy and paste. Maximum is 150 characters. So if you want to have a different kind of layout and add different kinds of emojis, you can. You just can't do that on Instagram. You need to do it on your phone and then copy and paste. Also have a call to action, have links to a website or, have phone numbers and things like that. And that way people can contact you right away if they want to. Bio tips, your contact, I already said. If you can, try to get verified. Okay, it means that Instagram has confirmed that an account is authentic. Presence of a celebrity or global brand is usually what it takes, but there are other ways to get verified. If you publish in a few different dental journals, you can get verified. So, check and see, because these things change all the time, but having that little blue verification up there gives you a lot of credibility, and it also opens the door to a lot of different things. It makes you more trustworthy. It increases your brand awareness. And again, there are some special features that you get on Instagram. Google reviews. The quality and quantity of reviews on Google is one of the most powerful ranking factors for local SEO. I mean, honestly, when you open your dental practice, I would invite everybody in the universe that you know to come as a new patient, and also when they come in, have them write a review, especially if they write it right there. If there's any kind of location tracking device and the review comes from your office, that they stick. But, the second people come in and that they've had a good experience, write a review. Here's a sample of, I think this is from Google. That shows. So at that time, I had 1,700 Google reviews. I think I have close to 2,000 now. The best way to get reviews is by using the one most powerful word in the English language with 3 letters, and it is ask. Ask, 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 ask. Or incentivize your patients, and this works. Dear Mrs. Smith, we're trying to build our social media presence. If you'll write a review for us, we'll give you a Starbucks card for $5. Is that legal? Yes. Do some people frown on it? Yes, but who cares? Do what you got to do. Another way to make it easier is with a QR code. So you can create a QR code. You guys all know how this works. If you point your phone at that QR code while it's in the photo mode, it will take you to a place where you can write a review for me. And if you like the presentation that I'm giving today, please go ahead and do write a review for me. All of my reviews are in one place, from my presentations to my practice to everything I do. It's all under Dr. Bill Dorfman. So if you guys would like to do that, I would really, really appreciate it. I talked about my LEAP program. This was from 2020, 2021. So 2020 ended up being virtual. 2021 was a hybrid. It was virtual and live. 2022 will be live. So if you or you have brothers or sisters or friends are 15 to 25 and want to go to the best motivational leadership program in the country, please join us. The phone number is 877-855-5327, or you can go to @Leap Foundation and on Instagram and reach out that way. But it is an amazing program, and I hope to meet you there one day. So 99% of alumni say that LEAP helped prepare them for success. 98% are more motivated after attending LEAP. 91% are more confident after attending LEAP. 100% leave with defined vocational goals. Past speakers, Eric Garcetti, he was our mayor. He will be our president one day. Chris Paul, basketball player, Paula Abdul, Scott Hoying from Pentatonics. Here's Anthony Hopkins and Mark Wahlberg. And if you need to reach me, my personal email address is above. On Facebook, it's Dr. Bill Dorfman. On Instagram and Twitter, it's @Dr. Bill Dorfman. On YouTube, my YouTube channel is right there. And that's it.
Thank you so much, Dr. Dorfman, for that amazing presentation. That was very, very helpful, including all the tips and tricks that you provided. And we do have questions coming in the Q&A, but we will hold on for that. We will go ahead and have Garrett come in. So if Dr. Dorfman, if you could stop sharing the screen, please.
Start on this one.
Sure. No, we're only sharing screen on that. This is my video. Just turn that on. Hey, Garrett.
Dr. Dorfman, how are you?
I'm good. How are you?
I am fantastic.
Awesome. So today we have Garrett Halley, who is an aspiring third-year dental student in Florida. He is a well-known TikTok icon with over 800,000 followers and more than 10 million likes. Through this platform, he shares his everyday experience in the field, as well as oral hygiene tips. Today, he will be presenting on channeling passions and health advocacy through social media. So let's give it up for Garrett Halley.
Hello, everybody. So I'm going to just be talking to you guys normally because I'm a student just like you guys. And I'm going to have the Q&A link up too on the side of the screen here. So just as you guys have questions about anything, you can go ahead and throw them in. I'm reading them and maybe I'm answering them as I go along. I don't know if you guys want me to hold off on questions until the very end for like Alexia and
Yes.
you want me to hold off on questions for the very end?
Yes.
Okay, yeah, no problem then. But I'll go ahead and type your questions in so I can go ahead and see. And yeah, I just wanted to talk with you guys and talk to you about social media because as you heard from Dr. Dorfman's speech a little bit ago, it's really important and it's an awesome, awesome platform and a way for you to connect with your patients and really build a name for yourself and kind of make a brand for you. So starting out with a little bit about me, I am from North Carolina originally, and I am moved to Florida 3 years ago to start dental school. I go to Lecon School of Dental Medicine. They also have a pharmacy and a medical school here, as well as a dental school, and it's in Bradenton, Florida. So if you don't know where that is, it's like an hour south outside of Tampa. And it's awesome down here. The weather's great. And I kind of just started out with my social media career really randomly, actually. So my platform that I choose to use is TikTok. I'm sure you guys are pretty familiar with it. Was randomly posting videos one day, just like the rest of you guys probably have, just silly nonsense stuff. And all of a sudden I woke up one day and I realized that my video had went viral. And I was like, that's kind of cool. And so I started posting again, and my video then went viral again and again and again. And it was funny because on all of the comments that I was getting on my TikTok videos, they all kind of had the same sort of theme around them. Like, oh my gosh, I'm afraid of the dentist. I hate the dentist. The dentist is the worst place ever. And so I thought to myself, like there's a way that I can kind of bridge this gap in between people's fear of dentistry and me being the dentist. I can kind of connect these two. And if I can connect my future patients and people for them to not be so afraid of dentistry and going to the dentist, we might have a positive outlook on dentistry because sometimes dentists don't have the best rep. People have horror stories of the dentist. So that was kind of my outlook on TikTok. And why I started posting videos is because I realized that there was a niche for me inside of TikTok where I could talk about dentistry and kind of try to eliminate the fear or the stigma that the dentist is a scary place. And like Dr. Bill mentioned earlier, it's a great platform for you to build into your other social networks. So I'm sure if you guys have a TikTok account, you know that there's a little button on your profile screen that you can hit and it connects you to your Instagram account, your YouTube account, your Twitter, whatever social media platforms that you guys use. It's a great avenue for you to go in and start and just channel people through the rest of your social accounts so you can see. So going back to TikTok, I had this thought, just like I said, to bridge this gap between the fear and the dentist. And so that's what I started talking. I created this posting philosophy or things that I was thinking about myself, what I could do to post and what I can do to make an impact. And that's something that I would encourage all of you guys to do when thinking about starting a social media account for your specific discipline is think about, the why behind what you're posting about. Are you posting about advocacy? Is there a certain topic that you're really passionate about within your discipline? Are you trying to educate? Do you just like making helpful, fun, educational videos for people to watch? Or do you just do it for enjoyment or for accountability, for some way to just keep you accountable with your daily routine? And so once you find the reason behind why you're posting, it kind of lets your creative flow go better, and you can make certain videos and channel different creative aspects while you're posting on your TikTok account or Instagram or whatever social media platform that you decide to use. So for me, I sat down and thought about, my why behind social media. Like I said, it's to eliminate the fear of the dentist, but in my short time of posting, I see that there's really two sides to social media. There's an advocacy and an education side to it. And there's also a fun, interactive portion to it. Now, I've already hit a little bit on the advocacy and education side, but I want to dive into that a little bit more because I think it's a really important aspect that you have for posting. Because like I said, my experience was that a lot of people were afraid of the dentist. And I quickly found out that a lot of people's fear was from the unknown, for them not knowing exactly what we're saying in our everyday dentist language when you're sitting in the chair, or just from horror stories from friends, family, or the internet. And so advocacy and education is such a powerful tool whenever you are creating content on social media for your specific medical discipline, because the greatest fear is the unknown. And so if you can make the unknown more known to patients, it makes the dentist, it makes whatever a little less scarier. So advocacy and education is super important whenever you're posting, because it leads into a trusting relationship. You guys are all going into the healthcare field, and the most important thing, obviously, is your patient. And if your patient doesn't trust you, you're not going to have a very good foundation for medicine, and the relationship is not going to go smoothly. And so it's really important that you can advocate and educate these things, because it creates a crucial component of your profession, and that is your relationship with your patients. And the second part of social media that I found out for my why was the fun aspect of it. I love creating content for people, and I love going out and making videos because it's fun. It's a way for me to step away from school and the seriousness and really let loose and enjoy myself and find things that I like doing, because that's also super important for yourself and for your mental health. So you have to figure out why you're posting for social media. Like I said, this is my reasons why. And so I want you to think about your own reasons when you're posting, because this is a super helpful and a really potential benefit for you as a healthcare professional, because there are countless opportunities for you inside of social media. So what can you do now to start collaborating with those around you? You guys are applying to your healthcare field and your healthcare profession soon. So you can talk about volunteering. You can talk about your studies leading up to your application process. You can talk about just literally anything that you think that can make you a well-rounded person. Going into the application process as a future med student or a dental student or a pharmacy student, it would be really awesome for you to show your social media on your application, so you know how well-rounded you are. You can advocate, you educate. You also are a normal person too, and you have hobbies outside of school and medicine that you enjoy doing, that you're passionate about. Social media is a great way for you to channel all of that into one portfolio for you. So, and you can start building your brand image now. Don't wait and say, I can start my medical Instagram or my dentist Instagram whenever I get into dental school. Don't wait until that, because you can go ahead and start posting about things that other people have questions about, or collaborating with other people in social media before you're even in your graduate profession to start, building a brand for yourself, really reaching out there and connecting. One of the biggest things on social media too is the opportunity to connect with people from all across the world. I have had an amazing opportunities because I have reached out to dentists, and dentists have reached out to me when posting on TikTok and Instagram about just dentistry in general and cool hobbies and interests that I have. So it's really such a cool, unique tool for you to really go out and collaborate and connect with people from all different specialties and disciplines. I had this opportunity to talk to all of you guys right now, and it's something that social media wouldn't have given me. It's something that social media gave me. I wouldn't have had this opportunity if I didn't start my social media. So don't wait until you're at this point in your medical career to start your social media. Go ahead and start now, because you can talk with other pre-dental students, pre-professional students, and learn, different study habits, talk about different schools. You might even discover something else within medicine that you like just because of social media. So don't stop. So don't wait, and keep posting. Start posting now and find things that you're passionate about. So that way, when you do get into your medical specialty, you can elaborate on those more and still, I'm sorry, I saw this thing pop up in the chat. Okay, never mind. that way, whenever you do get into your medical specialty, you can start building off of what you've already had before. So there's endless opportunity. Like Dr. Bill said earlier, it's not good to wait. You should go ahead and start now. Don't be afraid. The scariest part of all this is the unknown and, like the what ifs. So just go ahead, take a step out and just start posting. People enjoy seeing what medical professionals do because they really don't know much about it. So I for instance, like I'm sure I like to post about like my oral hygiene and just dentistry in general, because most people don't know much about teeth. And so I feel like it's an awesome way for me to connect with people and for me to really educate everybody else, like the previous points that I've already mentioned. So a short spiel, but nonetheless, if you have any questions, make sure to reach out to me. I respond to all of my DMs on Instagram as well. I'm not very good at TikTok because I really don't know how to work that well either, other than just posting videos, but don't hesitate to reach out, and don't be afraid to reach out to other medical professionals as well. Most people who post like myself and like Dr. Bill, they enjoy talking to other people and they enjoy speaking about their profession. So don't hesitate to reach out, because you never know what kind of opportunities are going to present itself when you send that message. So that's all the advice that I have for you guys today. I'm ready to answer questions if you guys are. So
Awesome. Thank you so much, Garrett. I think the quote that I could take from that last thing that you said is, you miss 100% of the chances you don't take.
100%.
I agree. Awesome. Okay, so we'll head into the Q&A section. And we have our first question today from Sarah. How do you balance the line between entertaining and informative social media and HIPAA? And Dr. Dorfman, you are muted.
First of all, regarding HIPAA, if you're going to use a patient on social media, have them sign a release, okay? That's very, very important. We have a standard one. If you'd like, I can email that to you and you can make it available to your contingency. Please don't just use mine blindly. Every state has its own laws, so make sure that mine is in compliance with yours, but at least it's a guideline that you can use. As far as balancing entertainment and education, I like to call it edutainment. I kind of combine them both, even on all my fitness videos, I like to combine them both. So, people will engage and watch you if you're funnier and you're lively. I mean, if you're talking about something in a low voice and have no energy, they're out. That's the reason that I get to do so much TV. Who else makes dentistry fun? Me. How do you make a root canal sound fun? Me. I mean, that's what you got to practice. When I first started doing social media, I drew on my experience as an actor. When ABC first put me on Extreme Makeover, I stunk. I was horrible. So I took acting classes, hosting classes, teleprompting classes. So if this is something that you really want to do and you don't feel like you're a natural at it, go take classes and learn how to do it. Look, I didn't know how to do an endo. I learned.
Go ahead, Garrett.
Yeah, no, sorry. And going off of that too, I really think it's just like, whenever you're filming videos, especially if you're going to like try to work with people in them, you really kind of talk to them before you start posting videos. Like, hey, like this is my thought process for this video. We're going to do this, 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 and this. Are you okay with me filming this? And then after you film the video, go ahead and show them the video to make sure that they are okay with this image that you've created of them as well too. And as for HIPAA's its own power. Like Dr. Bill said, it's really nice to get a form and really just have them sign that way. That way you're on a mutual agreement. That way you don't make any sort of violations or cause any problems for yourself.
One thing I will say, if you look on my Instagram, every third post is a dental. I rarely show the patient's faces. So if they're not identifiable, if I'm just showing Garrett's teeth, I actually don't need him to sign off on anything because nobody could identify him by his teeth. Now, as soon as you show the whole face, it's a whole different thing. So.
Thank you so much for answering that question. For the next question we have, would you say that quality of content is more important than quantity? For example, would you post more often on your social media with mediocre posts or less often with higher quality or effort posts?
You want to go, Garrett?
Yeah, sure. So that's a really good question. Whenever you start getting into like the algorithms of all the different social media entities, it can be challenging because all of the platforms are all different in terms of what makes a post go viral or the engagement that's encountered on that post. In my experience with TikTok, a lot of it is about the quality. The quantity of content that you're producing. So for TikTok, like I wouldn't call it mediocre posts. You should always put, best effort into everything that you're posting. But the fact that you're posting all the time is what is going to get you on that algorithm to get you on your For You page on TikTok. Now for Instagram, there are certain ways that you can grow your social media presence. For instance, like I was doing some research the other day about just how to keep on growing. And it was static Instagram posts and the Instagram Reels are what are most shown on the Instagram Explore page that you guys are familiar with. Whereas Instagram Stories and IGTV videos are more catered towards your followers that you already have. So if you're really trying to grow on Instagram, then you should really be producing a lot of static IG posts. So posting on Instagram pretty frequently. And you should also be throwing up Instagram Reels pretty frequently as well. That way you can get your content out on the Explore page so people can interact with it.
Yeah, and I have a little bit different take. Again, I'm not on TikTok. I'm 62 years old, and I just don't feel like I'm going to have the audience that a guy like Garrett would have. So, and plus I'm already, getting a great response from Instagram. But my feeling on Instagram isn't, more is better, better is better. So I only produce high quality stuff. I have an Instagram team, and just, because I'm not an expert in everything, when I went to do Instagram, I thought, the best way for me to do this is to hire a team. So my team knows what they're doing. And basically the way it works for me is I send all of my content to Antonio. He curates it. So all the videos, everything I post on there, he puts together. He then sends it to Dan. Dan is in the UK. And what Dan does is he pushes it on to the Explorer page. So I'm picking up 2,000-3,000 followers every day because my content's hitting an Explorer page that I would have literally zero idea how to do, And so, I keep growing organically that way. And, and I really just focus on, basically dentistry, fitness, and LEAP. And then when I take a vacation here or there, I throw in a few, pictures to show I'm like a real guy with a family and all that kind of stuff.
Yeah. As for like students, like all of us, eventually we would all like to have teams to post for social media. But my goal, like with posting for me, just to stay on top of things too, is just to try to post one thing once a week and then supplement in between those timeframes of my posts. For instance, I don't know if you guys follow me on Instagram, I do a Tooth Tuesday segment every Tuesday where I let people ask me questions related to dentistry. I make a video answering the questions and then I post it. So I made some way where every Tuesday I post a video to create engagement around my followers looking out for my video on Tuesday. And then in between every Tuesday, we'll post things about dentistry, my life, fitness, etc., just to keep the engagement up, because you need engagement in order to grow. And how do you get engagement? You post. So that's kind of like the formula for someone who's kind of trying to navigate on their own and are by themselves editing and filming and stuff like that.
And I think that's a great, great, great word of wise. And I also think that whenever you engage in anything, you need to have an end game in sight. For instance, when I was doing ABC's Extreme Makeover, I was approached by a big publishing company to do a book on cosmetic dentistry. And I said, no, I don't want to write a book. If I'm going to write a book, it's going to be a New York Times bestseller. I am the only dentist on the New York Times bestseller list, and my book, $1 Billion Smile, is the only dental book that is a New York Times bestseller. But I had a clear goal. Why? Why was it important for me to be a New York Times bestseller? Because as a book, as an author, big deal. When you're a New York Times bestseller, I got to do, Oprah and the Tonight Show. And I mean, all these different things. And that was a door I wanted to open. And, the same thing with social media. When I started doing social media, my goal was not just to do it. Like, I could care less about Facebook and I don't care if you know that I went to the beach. You know what I mean? My goal was I want more patients. I want more kids to learn about my nonprofit LEAP and to go to LEAP. I want people to stay fit so they have longer, more productive. So I have goals, like I have an objective to do this. What's the net result? I mean, I will tell you confidentially, and last year I earned over $250,000 endorsing dental products on Instagram because I had a goal. I wanted to grow it. I hired a team to do it the right way. And I realize you guys are students and this is like not something that you're going to do right now, but because Garrett's been so successful on TikTok, he's starting to get paid to promote different things. And so, if you play your cards right, this can also pay off monetarily very, very well.
Thank you, Dr. Dorfman. Yeah, that's such a great point. And I think it also, brings us to the question of how are you going to reach those goals? And I think we have a good question right now. And how important is it to do networking, to building your network?
It's the most important thing in the world. Listen, when I opened my dental practice in 1986, the first thing I did was I sent a written, real mail, you guys, written announcement to every single person I ever touched or ever saw or ever knew in my life. And I invited them to become patients. And when I opened my practice in Century City, and I wasn't that busy, at that time, 9/11 hadn't happened yet, I paid high school kids like $3 an hour to go and pass out flyers in all of Century City. I sent out 20,000 flyers inviting people to come to my practice. And right off the bat, I have about 90 new patients a month, every month, starting from the day I opened my practice. And that cost me nothing back in those days. So you need to be creative. You need to be smart. And again, copy genius. Look at what people that are successful are doing and do it better.
I love that. Somebody make a quote of that. Copy genius and make it better. Awesome. So we have our next question. In terms of advertising, how do you market your services to people who are afraid of dental work? Do you use keywords, or maybe do you have words that you would avoid using?
Well, I think the most important thing is to offer sedation dentistry, and so we do. I mean, this is the funny thing about, you have these patients who come in, their mouth is basically a train wreck. I mean, it's horrible. And it's not for lack of money, it's for fear. And the first thing you need to do is assure them, number one, you're in the right place. Number two, don't be ashamed. You're taking a very, very bold step by coming into my office, and we know that. And number three, I promise you, nothing will hurt. Because as soon as you come in next time, we're going to put you to sleep. We'll work on you for X amount of hours, and then you're going to wake up, and that's it. And, that's the biggest thing. You need to really understand your patients. If a patient isn't having treatment, is it fear? Is it money? What's the holdup? And, my office manager is literally a genius. If you come into my office for cosmetic dentistry, and let's say I treatment plan you and you have a $50,000 case, and the patient's like, what? She will figure out how to fund the most she can, and we can do it in stages. It doesn't have to all happen at once. I'm going to tell you something. We're coming out of a pandemic now. I know what the average dental office does in this country. I'm going to be very honest with you. I'm doing $850,000 a month in my practice. I'm doing 80% of that, and I'm working 25 hours a week as a dentist. I have 2 other dentists in my office that work with me, and I have 2 hygienists. So this is a very, very lucrative time in dentistry now. And if you're not in a situation where you're doing that kind of work, come and shadow me. We didn't let people shadow us for months and months and months because of COVID. If you're vaccinated and you're in the LA area and you want to come in and observe, I literally have had thousands of dentists come in. Garrett's been in my office, he's shadowed. Come in my office and look and see what it's like.
Yeah, I think a really big thing, just like I've only been treating patients for like 5 months now in clinic. And one of the big things that has helped me, I feel like, be successful as a student is sit down with the patient and talk to them and really get to know them and kind of understand, is there any triggers at the dentist that makes him afraid or will make them kind of wane away from treatment? Because it's important that, they come in to get treatment, and it's important that I understand what triggers them so that I can try to avoid it. Most people are afraid of the anesthesia, the local anesthesia that we give them. And so by sitting down and talking to them and explaining it to them that, unfortunately, there's no way that we can avoid this. And this is going to prevent you from feeling more pain than it would. So it's a little pinch compared to something that would cause you excruciating, drastic pain. And patients are really receptive to that. And they really appreciate the explanation and you sitting down and talking to them just so they can get a better understanding of you and just of the treatment, because that helps get rid of their fear.
Thank you so much. And for the next question we have, how do you be genuine when you're on social media?
Be thoughtful.
How do you be genuine?
Yeah.
Yes, that was the question that we have here.
I don't really understand it, but I try to be genuine in everything I do in my life. I know a lot of people are concerned about this poser syndrome thing. I'm not. I'm as real can be. I don't claim to be something I'm not. People may think you're arrogant if you say, "Oh, I'm a great cosmetic dentist." Well, I am. Okay, I am not a great chef. If you want a good meal, don't come to my house because you'll get sick. Okay, I'm not a great driver. I stink at golf. I was the last kid picked for every baseball team. Okay, but if you want to go to the gym and lift weights or work out, I could be your man. So I think you just have to be real with yourself. Here's the thing. At the end of the day, you need to look in the mirror and like what you see, period. You need to really put on blinders and not care what look, I'll get 10,000 amazing, sweet, supportive, great comments. Once in a while, I get something that says, "Hey, you're a jerk." Do I care? Heck no. They don't know me. Maybe they're miserable. I don't know what their issue is. I think that I tell my students that lead this all the time. The hardest thing in our lives is that we compare our deepest, darkest insides to everybody else's bright, sunny outside. We all have dark, deep things inside us, and you have to realize that. And I think the strongest thing that you guys can do, and this has given me more strength than anything I've ever done professionally, is join a mastermind group. If you don't know what it is, I'll explain quickly. There's an organization called YPO. It's the Young Presidents Organization. It's a global organization of presidents' companies. And I joined this when I was 40. And it's very hard to get into. And so you may not qualify for this. I was the only dentist in this group, but there are other groups that are comparable. But basically, you know, in order to join this group, you had to have a company with 60 employees or more. Your company had to do over 20 million a year in revenue, and you need to be under the age of 44. And it puts you in a group with other presidents. Why is that important? Well, when you have a company like I did with 650 employees, and an employee has a problem, who do they go to? You. When you have a problem, where do you go? Well, what YPO does is it takes you, and it then takes that group of 50 or 60 individuals and puts you in small forums of 8 to 10 people. And your forum is a mastermind that meets once a month where you just talk about business, life, challenges, and all these things. Every single one of you that are listening to this can join the Crown Council. There are two organizations I tell every dentist they should be part of: Crown Council and the AACD. AACD teaches me cosmetic dentistry. Crown Council teaches me how to be a great person. That's what they teach. They teach you how to be a leader. They teach you how to run a practice. And they also put you in mastermind groups. I've been in the same mastermind group for 20 years with the same group. It's 10 men. And we met just last week. We meet every month for an hour by phone. Since we're in all different parts of the country, we meet twice a year in person, where we do, you know, a retreat. And these men know me better than my family, better than my brothers, better than anybody, where we're very transparent and we share our deepest, darkest insides about our practices, our marriages, our divorces, our kids, our everything. And, you know, it's crazy. If I get 15 messages on Instagram telling me I'm a jerk, I never look at them. I just delete them. If somebody in my mastermind group said, "Hey, doc, you're being a jerk," what? Like, I want to know. Look, we all have blind spots, you know, but it really depends on who's telling you and how well they really know you. And, you know, that's really important. So you need to make choices in life, but you have to realize that not everybody is going to think you're genuine. Not everybody is going to love you. That's okay. But the people who matter to you, that's a whole different story.
Garrett, would you like to add on to that?
No, Dr. Bill hit it pretty spot on. Yeah, you should just be, I feel like there's no like difference between me on social media and me without a camera. And so just be yourself, basically. So that's pretty much it. Yeah.
Thank you. And for the next question we have, what advice do you have for healthcare providers who are starting out with a limited budget?
Well, I can talk to you about that because I am right there with you. So your iPhone camera can shoot amazing quality videos. Android phones too, doesn't really matter. So start out with that. I mean, I still shoot on my iPhone sometimes, and it still gives that really clear picture that you need for posting on social media. And in terms of editing software, I use Splice, and I use an app on my computer. I don't know what it's actually called, but the initials are VN on the little dock thing. And that's all free. And that gives you a really easy way to edit your videos, add text to it, add effects. So if you have a low budget, I completely understand. I feel for you too, because I'm there with you. And your iPhone is more than enough for you to make content and be successful with that.
Yeah, one of the things I learned about filming on iPhone, for the best quality, hit the HD button. You want to go to HD 60. You don't want to go to the 4K. It's too high and it gets degraded. So you want to do HD and keep it on 60. Look, when I first opened my practice, I was broke. I didn't have a penny. and that's why I came up with this idea for flyers. So, I went to Beverly Hills High School. I got a few kids. I paid them $3 an hour. I printed up these flyers for about maybe $450, and we passed them out to everybody in Century City. And 80% of the people that work in Century City have dental insurance, so they didn't even have to pay. They just came in and we billed their insurance. So, do what you can do, but it depends on where you're practicing. One of the most successful dentists I know is my friend named Sam Zarabi. He has 40 clinics now in the Texas area, and they only treat kids from low-income families. And the state pays 100% of their dental care. And he set up 40 clinics called Rodeo Dental. And he is crushing it and providing such a great service to people. And, so you just have to look at the area where you want to go. And again, copy genius, but do it better.
Thank you, Dr. Dorfman and Garrett. Dr. Dorfman, there's one question towards you. It's, Dr. Dorfman, do you have book recommendations or videos that taught you how to effectively use social media and websites to promote your business?
Okay, do you understand? I didn't have a computer when I started. When I went to dental school, there weren't even cell phones. When I went to dental school, there were dinosaurs walking around. I mean, you guys, I'm old. I didn't have any of this stuff. Like, I literally learned it on the fly. And when I decided to do Instagram, it was because my kids were sitting there on the couch and I'm sitting there trying to talk to them. And all I see is Instagram. I'm like, okay, what is this? So they showed me their Instagram and I said, do you guys think I should do it? They're like, no, Dad, you're too old. I'm like, well, are there any other dentists on there? They're like, well, no. I'm like, come on. So then we did a search. I'm like, no, he's a dentist and he's a dentist. So then when I saw that there were dentists on there, I told my kids, no, you're crazy. And I went and I started searching and I hired a team of people to help me. And my initial team was not great. I've had 4 teams. My new team is the best team I've ever had. So I learned really kind of on the fly just by hiring people. And I get it. When you're a poor dental student, that's not an option. So I would say, I don't know any books, but I would be shocked if there isn't a plethora of information on the internet that you can't learn just by Googling it.
Yeah, absolutely. Googling, it really helps in terms of social media, and also trial and error too. Don't be afraid to try new things and post different things, because you never know what's the algorithm will pick up on your post. And that can also guide you on what type of content to post. So trial and error is also something that I use from time to time, just because I think it's a good way for me to explore kind of the questions that probably you have that you're looking to get out of a book. So
thank you so much. And Garrett, there's one question for you. What are your plans for the future and which dental TikTokers inspire you?
My plans for the future, obviously I want to graduate dental school. I don't really have a set place and where I want to practice. So I'm just letting that take me. I'm just kind of going with the flow with that. I really do enjoy posting, and I plan to continue to post throughout my whole entire career, just because I love doing it. And I think it's such a good opportunity for me to connect with people. And what was the last part of that question? Oh, the dental TikTokers. So I talk to a lot of the dental TikTokers pretty much on a monthly basis. Keishan Gadia, David Cohen, Dental Digest. So we all kind of talk and we all kind of bounce different ideas off of each other and congratulate each other for our successes and whatnot. So those are probably my top 3 that I talk to. So those are my favorite. I keep up with all of those guys a lot, and it's fun talking to them.
Thank you. And there's one question that asks, what do you recommend for introverts who want to get involved in social media or TV?
Sorry, for who?
For introverts who want to get involved in social media.
Introverts who want to get involved in well, stop being an introvert. It's easy. I mean, look, when I first started doing TV, I really stunk. It was not like, I grew up a swimmer. That's the least social sport in the world. You literally can't talk to people at all. So I was used to listening and not really talking much. I learned how to do it, and I did it out of necessity because I knew that, if I wanted to have a voice, I needed to learn how to communicate. So, it's a choice. Learn how to be an extrovert.
Yeah, and something to add on to that too is obviously like everyone doesn't feel comfortable being in front of a camera, and you can definitely take steps to be more comfortable on camera. It's still something that I am getting more comfortable with, and that's something that social media has helped me do a lot, is be more comfortable talking to people and in front of a screen where I'm listening to myself and watching my mannerisms on camera. But just to start out, just to connect with people, you don't have to make videos of you speaking. You can post a picture and you can type up a caption and say everything that you need to say with words to start out. And that's how you can start to connect and talk more and just get more extroverted, kind of dip your feet in the water. And then once you feel more comfortable talking with people, then you can start making videos where you're speaking and interacting more. So baby steps. But yes, for social media, unfortunately, it's called social for a reason, and it's all about interacting with everybody else. And so you can be an extroverted introvert for social media.
Thank you so much. And now we have our one last question. What way can you recommend to grow and reach more people on social media?
We kind of,
Garrett, you go first.
Yeah, I mean, we kind of talked about this a little bit before. Really just find things that you're passionate about, like I'm also passionate about like fitness and dentistry, or some people can be passionate about, fishing, sports, like knitting. Post stuff about that. And then, like I said, trial and error stuff. Post about your passions, your interests, and see what people really engage in whenever you post those things. And then kind of let that guide you. If you're posting videos about your study habits and people are interacting with that, start posting more about how you study and the materials that you use to study and what you do to study for certain things. So just kind of trial and error, post things out, see what you engage with, and then go from there.
Yeah, I agree totally. I need to go back to the last question. So I just thought of two things that I think could be really helpful. Number one, and this is an exercise somebody told me, and I really love it. Every day, just read 5 minutes out loud. Just 5 minutes. I mean, read an article from the internet, read the news, read whatever, but actually practice reading out loud. That's a really, really great skill to be able to read and enunciate well. The second thing is, anytime you do anything, just take a cell phone and video yourself and watch yourself. You will be your biggest critic. You will see things that nobody else sees. And I think it's one of the best ways to really teach you how to be better is just video yourself and watch yourself. When I first started watching myself on Extreme Makeover and the doctors, it was painful. The phrase, a deer in headlights? I mean, that's what it felt like. But you learn what works and what doesn't work. And even when I go out and I would lecture, and it's funny, you do an 8-hour lecture, you're speaking all day long. Like after a few weeks of giving a lecture, like I knew where people would laugh. I knew where people would cry. I knew where people would cheer. I knew it. Like it becomes a routine, and you get pretty much the same emotions every time. And when you see that people are fading out and not responding, I get people to stand up and take a stretch. I mean, that's a cool thing about doing audience stuff, is that you actually get immediate feedback. Whereas a lot of stuff that you do virtually, you can't see your audience. Like if any of you are sleeping right now, wake up. Like, I don't know what you're doing.
Okay, thank you so much, Dr. Dorfman and Garrett, for all those amazing answers and for your time today and the presentations, of course. So we will be moving on to our lunch break sessions or rather break session. And again, we want to thank you for your time and have a good rest of your day.
Absolutely. Don't hesitate to reach out either.
Yeah, you're welcome. Thank you for the nice little note. Bye.
See ya.
Hello, everyone, and welcome. Today, I have the pleasure of introducing Dr. Alexis Archinsky. Dr. Archinsky received their doctorate in counseling psychology from the University of Utah and is currently serving as a staff psychologist at the university's Counseling Center. They also serve as a coordinator for the Mindfulness Center and the Change Coalition undergraduate internship program. Their research and teaching focuses on 3 themes: examining how practitioners engage in multicultural practices, employing empowerment-based approaches, and promoting social justice. Let's give a warm welcome to Dr. Archinsky in leading our session on mindful wellness.
Hey everybody, it's lovely to be here today, and I'll go ahead and get started by sharing my screen, and we're going to be using some stuff that I've never used before, so we'll see the fun times that we have with that. But first things first, if you could go ahead and go to this website, joinpd.com, and use the code that's provided, IWGQQM, to link to it. Later in this presentation, I'll have some questions and you can give your live responses if desired. No pressure. And I'll give folks a couple of seconds to get connected to that. Since I don't know about you all, but I can't necessarily focus on 2 things at once on Friday afternoon. So do your thing. We've got about 7 people connected, and let's try. I know that there's quite a number of people here, so let's try and get at least about 15 or 20 people in there. So again, the link has been, or the website has been shared in the chat, and the website is joinpd.com, joinpd.com. And the code is IWGQQM. You can totally use your phone. Part of mindfulness-based stress management is noticing when we make mistakes and laughing at ourselves for having a moment of being human. So Angela, thank you. Welcome. You're human. I'm glad you're here. All right. Other folks are welcome to join as we go. And the website is in the chat as well as the code. So I hope more folks join as we go. Again, you can log in with your phone or any other device that you're on right now, because presumably everybody is here on some sort of a device. All right, so today we're going to be talking about mindfulness and stress management. And part of that process will be the following learning objectives that just give us a sense of where we're going in space. So we're going to identify the basic components of mindfulness. Those include the micro skills that come with mindfulness in the particular approach that I'm going to share with you today, as well as the basic philosophical components of mindfulness, which are very important, which I'll be illustrating throughout the presentation. We'll apply mindfulness towards stress management in the moment with each other, and we'll demonstrate those mindfulness skills through application. And the invitation is to think, feel through moments of stress that you might have in your day-to-day life, which could be happening right this very moment. So there you go. And before we take a moment of pause, actually, I'd like everybody to join me in a couple of norms that we can build in this space. Now, I recognize we're not talking with each other like we might in a class or in our workspaces or practicum or internships. but let's create an environment of confidentiality and non-judgmental acceptance. And what I mean by that is that let's leave whatever people share out when I ask for people to respond to questions. Let's leave that information here, leave their stories, leave their names, leave everything else here in this space so that people can share whatever they want to share without fear of judgment. And let's take up a non-judgmental space with each other. And what I mean by that is holding our judgments loosely that we might have of others, and in particular of ourselves. So offering ourselves the same kind of grace that we might offer other people when they slip up, get distracted, or make mistakes. And so it is my hope that everybody will take me up on these principles as we go. Okay? Just apply them. When you notice a judgment, notice it, give it a name, and let it pass. So let's take a moment of pause with each other, because I'm guessing you're at a conference. I'm guessing you had one thing before this and you have another thing after this, and you probably have homework to do and a semester coming and some jobs or something. And so let's take a moment to just be with each other. So if you can, close your eyes. If you can remain present and engaged, close those eyes. If you can't, let them stay open. And fix your attention on a spot about 12 to 18 inches in front of you. And just begin to pause in this moment in your day. You're simply going to stop whatever it was you were doing before this moment and let go of anything that might happen after this moment and take a few breaths. Breathing in to a count of 4, breathe in, 1, 2, 3, 4, pause, and breathe out, 1, 2, 3, 4, pause. One more time, breathe in, 1, 2, 3, 4, pause, and breathe out, 1, 2, 3, 4. Last time, breathe in, 1, 2, 3, 4. And with your exhale, breathe out through your mouth with a sigh. You've arrived and you're here today. And hopefully you'll get a moment of relief in your time and space with us today, with each other today. So I'm going to invite folks to respond to this question in the application that you've associated yourself with on your device. So please write your response to this question. What does mindfulness mean to you? We've got a good number of responses, so I'll start putting them up on the screen so we can see. Mindfulness means being present in the moment, being present. I'll come back to the first one, don't worry. Peaceful mind, connecting with myself and feeling comfortable with. I'm going to pause for a second. I might be getting ahead of myself with this application. So we'll give people time to finish their responses. Connecting with myself and feeling comfortable with my emotions, to be mentally healthy and to not be always so stressed out and to be calm. Being present. I'm hearing some themes happening in this so far. Being aware of my thoughts as they come up. Awareness, being aware of others' feelings. Indeed, part of mindfulness is social awareness. Peace and understanding. A clear mind, no worries, and peace with oneself. Being aware of oneself and one's presence. Take time to just exist. Heck yeah, we're going to do that again later too. Being calm and collected, and being calm with us ourselves being uncollected and messy at times as well. So holding two things at once. Taking consideration of our surrounding environment, peace and mental relaxation, quiet mind, communicate with yourself. These are lovely responses, everybody. Thank you for adding these for us. And this first one, mindfulness is being present in the moment and being in tune with yourself. Beautiful responses, everybody. So thank you for that. And I'll go ahead and add to these a couple of layers to an understanding of what mindfulness might mean. And mindfulness means many different things, actually. And before I go into any further depth, I'll name some of the ground that we're standing on. So as you may or may not be aware, Mindfulness is a practice that's existed for a long, long time, thousands of years, emerging from Eastern and indigenous practices. And these practices have been culturally appropriated by mostly white men in the West and have been used for the purposes of personal well-being. And the background, the cultural background that we've pulled these practices from has larger feelers than that, larger implications. So as some of you talked about, it also means being in tune with our surrounding environment and the people we're in relationship with or cohabiting on this earth with. And so it's very much about personal and community liberation through the act of being present in the moment. So just naming that for a moment in our space together. So in terms of what mindfulness is, so it's paying attention to the present moment. Some of you, ding, 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 you got that totally right. There's not a lot of ways to get mindfulness wrong, FYI. It's ungluing our experiences from culturally born self-judging and self-limiting thoughts. All of us have agreements with the broader worlds from which we've been socialized. And those agreements sometimes tell us that we have inborn limitations and also take up critiques of us and how we move in the world. And mindfulness can help us let go of that a bit and formulate new cultural agreements for which we agree instead. Mindfulness is also, as some of you rightly stated, being with emotional states and using that those emotions as information. Our broader worlds teach us to actually discount our bodies and our emotions as sources of important and wise information, and instead locate intelligence in the mind and in the rational mind. And so what mindfulness can do is can help us to have a broader space of understanding of the kind of information that we can use in our day-to-day lives. So ding, ding, ding for those of you who noticed that. No one in here is more right than the other. Just, hey, somebody mentioned that. Mindfulness also allows us to forego automatic ways of being. So instead of being like being an autopilot and being on the way home from work and suddenly being at home and having no idea how we got there, mindfulness can give us the opportunity or the choice to be present on that whole drive home and to use it as a moment of peace in the space in between things that we're leaving and going towards. Mindfulness is also a practice of letting go of future fears and past problems. So we don't have to live in the future or the past, but can instead live right here, right now. And the right here, right now might be dang uncomfortable, but we can still be here anyway and contend with what is in the moment and give ourselves space to be with it. And mindfulness also teaches us that when we need a break from the present moment and we need to distract or self-soothe, we can also do that too, and that's okay. And lastly, mindfulness is being in the present with a calm, curious mind, a playful beginner's mind. So if you think about a kid who's never run around in the park before and is kicking a soccer ball, they might laugh and be playful when they miss the ball or they fall down, and they might cry too. But us adults, we have a tendency to get really hard on ourselves when we make mistakes or don't meet our expectations. And so mindfulness allows us to be curious with our reactions to ourselves and to be playful at the same time. So what is mindfulness? These are some helpful micro skills that we can use to take care of ourselves when we're in a stressful moment, and to also take care of ourselves when we're in a moment of relief. And these practices, as are stated on the screen, are observe, describe, and participate. What I mean by this is observation is turning towards the present moment without attachment to our experience or our reaction to our experience. So let's say that right here, right now, you notice yourself getting distracted by stressors that are happening in your day-to-day life. Like it's pulling on you and pulling your attention away. What the mindfulness micro skill of observe can tell us to do is when we have a mindful moment that we've gotten distracted by a stressor and that's taken us out of the present moment, we can notice where we've gone and just notice, oh, I'm thinking about that assignment that I have, or oh, that job task that I have, and noticing that. Okay, that's the first step. to helping ourselves change our stress reactivity and instead respond to stress. Describe is the act of when a feeling or a thought arises or a distraction happens, putting it into words to acknowledge it without judgment or criticism. So for example, if you're distracted by something that's stressful in this present moment here with me, you might notice where you've gone and then you might name it. I'm thinking, I'm worrying, I'm planning, or whatever it might be. Okay. And then lastly, after you've had that mindful moment, you have a choice. You have a choice to continue down the rabbit hole of that thought, and there's no judgment there because sometimes we just got to do it. And you also have a choice to return to your experience in the moment by getting immersed in it, getting lost in it for a little while. So again, the micro skills of mindfulness are to observe what's happening for us in the present moment, to describe it, put it to words, and therefore hold space for it for a moment, and then to participate actively in our present moment, or to at least give ourselves the choice to do that. These can be used when we get distracted by stressful things, or when we have strong emotions or difficult thoughts or whatever it might be. We can observe it, name it, and then come back to whatever it is that we're doing. Next are some really important philosophical tenets of mindfulness. These are just three, there's many, and they've kind of been inserted throughout the presentation so far. But the how to do mindfulness, if you forgive the syntax of that statement, involves non-judgment, one mindfulness, and effectiveness. So we've talked about non-judgment here a little bit, but we humans, part of the way that we've survived for so long in our vulnerable little bodies is that we have developed the ability to judge our circumstances. And presently, that judgment can take many different forms. It can take pleasant directions, it can take most unpleasant and critical directions, and it can be rather neutral. It can be leaning in or being averse to an experience. And what mindfulness asks us to do is to hold our judgments really, really loosely, because our judgments are not facts. Our judgments likely have far larger socio-political implications of their origin, meaning that we likely learned it from somewhere, from our broader worlds and from our relationships with people, and they don't necessarily mean truth. Like as an example, we live in a world where we're taught to be hyper productive all the time and to always do things well, perfectionism. And that perspective can lead us to believe that when we're taking a moment of pause or enjoying time with friends or just laying on the floor in a puddle, that we're not doing a good job with our lives in that moment. And so mindfulness can help us to pull away from that, from those culturally born judgments, and instead lean towards being with ourselves in a present moment with an affectionate gaze. Okay, so non-judgment. And so non-judgment in and of itself is holding our experiences and our judgments of our experiences quite loosely, and noticing without evaluation and with a playful attitude. So another way to look at it is if we notice a judgment of ourselves or a critique of ourselves that we're having in a moment. I'm not being very articulate is one that I'm having right at this particular moment. When we notice that, we can also be playful with ourselves. Oh, I know where that's coming from, because I believe that the only way to love myself is to be perfect all the time. And that's no way to live, right? Next is one mindfulness. So I didn't create a prompt for this, so forgive me, but I'd like everybody to take a moment and to acknowledge from themselves if you believe that you might be good at multitasking. Usually it's about 90% of the room, people think that they're pretty good at multitasking. And what research suggests is that as humans, we're actually really bad at it. We're really good at sequential processing. So we can do, what happens when we do multiple things at once is that we're actually doing one thing at a time and doing those one things at a time really badly. So for example, let's say that in this moment, you're eating a meal, you're checking your email inbox, you're responding to text messages, and you're watching this presentation. Generally speaking, that means when you're, and there's no judgment here, folks, we all do it. But if we're checking a text message, we're likely missing pieces of the presentation. If we are if we're watching a presentation and eating at the same time, we're likely getting less delight out of the food that we're eating, and et cetera, and so forth. And so what mindfulness suggests is that we instead do one thing at a time. So in this moment, you may decide that you need to take a couple minutes to eat and tune out the presentation. More power to you. Or you may decide that you're full in this moment and you can turn your attention to the presentation. Or you may decide that you have to take a 30-second brain break, because we all need those moments to respond to a text message to a friend that you care about. So again, one thing at a time. And lastly is effectiveness. And what this particular philosophical tenet means is do what works or needs to be done versus what we think we should, quote unquote, be doing. And an example of this that I use in my day-to-day life is that I have a tendency to write, funnily enough, we're at my workspace. So I like to write lots of to-do lists. Oh, you probably can't see it, but lots of to-do lists with really little tiny written words that are way too long and have lots of things to do. And I tend to target the things on my list that I find to be the most difficult first, because I like to end on a pleasant note or an easy note. However, on days when I'm feeling stressed or I'm struggling with some emotionally laden thing in my life, like pandemic and not being able to see my family, for example, fairly easy one to reach, it may not be possible for me to attack the difficult things first, the ones that take the most attention first. So instead, I might do what works and switch the order and do some easy tasks first to help me feel a sense of mastery over my situation and to distract myself a little bit if I need to get some stuff done, even though I have emotional stuff happening, which likely happens for all of us all the time. And once I've been able to tick off the small things, then I can move towards the larger order things. And maybe the next day I'll feel differently and I can start with those difficult things. So let's practice an activity together that helps to coalesce these ideas together. This is a stop meditation. You can search it on your web, on your search engine right this minute. Generally speaking, this meditation is very, very short, a couple of minutes long. I'm going to draw it out for you all because part of what I was asked to do was to do a little bit of meditation practice with you all to give you a moment of pause in your day versus filling your minds with more things. So let's take a minute to practice this stop meditation. And this meditation gives us an opportunity to practice the micro skills that we just learned together and the philosophical tenets. This meditation can be a helpful way to slow down and check in with ourselves. A couple of reminders as we go into it. Mindfulness, no offense to the person who said it in the comments, but mindfulness is not a blank mind. Mindfulness is allowing ourselves to be whatever we are in a given moment and to be curious and kind to ourselves in those moments when we're maybe feeling a little bit more all over the place. Okay. It teaches us to respond to ourselves in times of stress versus to react harshly or quickly in those times of stress. So we'll practice that together by entertaining different sources of information in the moment and checking in. Okay. So again, get settled in your seat. If you're not in a seat or you're sitting on the floor, more power to you. You could even lay down if you want to. Nobody's going to know. If you prefer to stand because you might get too sleepy and fall asleep, go for it. Whatever you want to do is your thing. But get comfortable in your seat and take in your surroundings for a moment. Begin to look around your surroundings and notice where your entrances and exits are. And begin to take in anything that has the color purple. And then begin to close your eyes if you can feel present and engaged with your eyes closed, or allow your gaze to drift to a spot 12 to 18 inches in front of you. Notice the sounds that are in your space, pointing your attention to the sounds furthest away from you first, and then tracing those sounds closer and closer to you, ending on the sounds within you, perhaps the sound of your breath or your heartbeat. And now, once again, take a moment to stop and take a pause from your day. In this moment, you don't have to be anywhere or do anything or learn anything. You just get to be. And now take a few intentional breaths. You may decide to observe the sensations of your breath as the breath enters and exits your nostrils, or the sensations of your ribs expanding and contracting. Or you may decide to count out your breath, like we learned a little while ago. But take a moment to breathe intentionally. And if it feels good, let out a sigh of relief with each exhale. And now, without any judgment or any analysis of what's wrong, begin to observe your thoughts. You may notice multiple thoughts happening all at once, messily moving through your mind. You may notice one thought happening one after another. You may have a broken record in your head, or by turning your attention to your mind, you may notice nothing. All of these things are okay and all right in this moment, but just observe your thoughts. Just noticing what's present. If you notice that you start to go down some rabbit holes with your thoughts, or you start telling stories in this moment, notice that tendency. Give it a name, whatever's happening, planning, worrying, and redirect your attention back to just noticing whatever pops into your mind in a given moment as they come and go, stick around, and repeat. Now, I invite you to shift your awareness to observe any and all physical sensations that are occurring in and on your body. These sensations may be on the surface, so like the feeling of your clothes on your skin, the feeling of air brushing up against the little furs on your arms and legs. These sensations may be deep within, sensations of muscle tension or relaxation, sensations of hunger or digestion, sensations of breathing, heartbeat, pain, relief, whatever it is, just notice in this moment. And when you notice the urge to critique any sensations you have on your body, notice that tendency, give it a name, and kindly move away from that thought and back to just observing with a gentle, affectionate gaze. Now, begin to shift your awareness to observe any and all emotions you might be having in this particular moment. Again, you may notice nothing. That's fine. You may notice emotional purity or one present emotion at this time: frustration, sadness, tiredness. Or you may notice many emotions happening at once or one after another. All are just fine. Notice and be with whatever's present, giving it a little space to just be here. Now, I invite you to shift your awareness to observe your spirit or energy. This may be a very physical sensation of how much energy you got in this particular moment. It also may be quite ethereal. Just notice whatever it is that you notice in this moment. And as we close this activity together today, begin to suspend all effort. Don't have to attend to anything right now. Begin to open your eyes with a soft gaze. And begin to proceed into the next moment with me, with awareness and presence. Thank you, Alexia. Now, part of mindfulness-based stress reduction is taking some moments of pause to reflect. So I invite you all to begin to submit some responses to this question using the Pear Deck app, website that you've already associated yourself with. But begin to just kind of quickly describe whatever it is that you noticed. Folks may notice things that are pleasant and unpleasant, things that are neutral, whatever it might be. But feel free to share that. Just to be transparent and giving a little bit of time so folks can put those responses in there. And I'm going to take a little drink of water because notice that I might need it. Lots of different thoughts. I couldn't relax. This is actually quite common, especially when if you haven't been exposed to mindfulness or meditation much before. Many folks will notice that their minds are all over the place and it's hard to just be in the present moment. And a reminder, mindfulness-based meditation is not necessarily relaxing, although it can be, as Alexia highlighted, so peaceful. It can also be a moment to notice. Yes, we're going to be moving to the Q&A in just a moment. many folks will notice that over time and with practice on a regular, if not daily practice, we can start to relax more into it. And we can start to learn things to help us relax when we notice or learn when we sit down to practice that we're overwhelmed. Many folks tend to fall asleep. If we tend to be in a space of pretty consistent and chronic stress, our bodies are on high alert all the time. And when we start to do a mindfulness or meditation practice, our bodies are like, oh, it's time to go to sleep then. And so we might get sleepy. Noticing our breath, noticing fatigue, a really important thing to notice. Maybe a nap is needed after this, some calm. Sometimes folks get that right off the bat, and that's really lovely. We might notice more acutely our senses. And again, difficult to find concentration, difficulty quieting the mind. Noticing discomfort in different areas of our lives. And noticing sadness around a lost pet or a pet, not a lost pet, just a pet that is sick. So thank you everybody for sharing your responses. These are all quite typical in my experience, and so you're not alone. And sometimes with practice, we can get better skilled at being concentrated with ourselves and also kind of letting it go if we have an off day, because we're all allowed to have those. All right, so let's talk about questions and answers. I've got 3 that we pre-approved, but we'll kind of let that go for right now. Are there any questions in the Q&A? I don't even know how to get to that.
I can read them for you. Why don't we stop sharing the screen and go into dialogue mode?
Yeah.
Perfect. All right, well, as we're waiting maybe for some of those to come in, I had a question. Where can we find other places to get resources for more exercises, more mindfulness exercises?
That is a really great question. And what I will do, I probably should have had that prepared, but I didn't do that today. So what I will do is, where is that window? There it is. So Tara Brach is a mindfulness-based practitioner, Tarabrach, and she has a lot of practices on her website. There's also a website. And a practitioner called Chris Germer that has a lot of self-compassion based practices. And there's selfcompassion.org that has some wonderful practices as well. And there's about 70,000 different apps that are even free that have mindfulness-based practices that can help lead us through practices in the moment, like the Calm app and other ones like it. Those are some places to get us started. And it looks like Angela might be doing some research to get those added to the website, to the chat box.
I think I found 2. I'm missing that 3rd one though.
I'll get it for you.
Perfect.
If people don't mind watching this middle-aged queer try and figure out a website for a second. Here's, oh, you already got that one. Whoopsie. Here we go. I found it. Oh, well, dang it. I sent it to you, Angela. You can share to the group.
There you go, everyone.
Well, thank you. I love my haircut too. We can all thank my partner for it. I have an in-home hairstylist.
Moving on, I have a question from Alexia really quickly. How many meditation sessions would you recommend as a pre-health student per week? I know she also asked about apps or platforms, but yeah, 3 in the chat for everyone.
Yeah. And again, apps. I don't know that I necessarily recommend these ones, but these are commonly used ones that I hear about for folks. These include the Liberate Act if you're a BIPOC individual, if you're identify as Black, Indigenous, person of color. Headspace is a great application, has lots of different things. Insight Timer is another. And they offer free and subscription-based ones. And then in terms of how many practices a week, I think I'll kind of add some layers to the answer to that question. So mindfulness can be practiced in formal practices, like the one we did today, the stop meditation. And there's lots of other formal ones that you can find on the websites that can be anywhere from 5 to 45 minutes in length, which I know sounds crazy, but just think about it. 45 minutes of a moment of pause for you to get a daily vacation. It's a really good idea. But generally speaking, the recommendation that I have for folks is to work towards a daily practice in some form. Mixing together formal practices where you're kind of taking a pause from your day and going to your mindful place or mindful practice. But there's also in the moment ones we can do. Like when we have a mindful moment that we are stressed or overwhelmed or judging or critical, we can take a moment to notice it, observe it, give it a name, and turn back to our lives with more of a gentle awareness. So that's a mindfulness-based practice of redirection that can help us in any given moment to be kinder to ourselves when we're in stress. And there's also ways to practice mindfulness with just our everyday things that we do. So if you are an avid exerciser, try it. You could try being mindful when you're exercising. And what I mean by that is instead of having your headphones in, take them out and do your run or your bike ride or your walk or your yoga sesh, really noticing what's coming up for you. And what we can often learn when we're in exercise is we notice our instantaneous reactions to stress. Do you tend to get angry when things get hard? Do you tend to get sad when things get hard? Do you tend to get really anxious when things get hard? Noticing that in your inner dialogue, and again, practicing mindful redirection to help ourselves just come back to that movement in the moment. And some other ways to do it are to insert mindfulness into one component of our morning ritual. So could be with your cup of coffee or your shower or whatever it might be, but kind of turning off all the things and just redirecting ourselves back to the activity over and over again. So those are just some examples, but generally doing what works for you versus what I am telling you should do right now, because it's not what I'm saying. Working towards a daily, regular practice of mindfulness and making it fit into your life.
I like that answer. Moving on, I saw a really good question. What would you recommend? How would you recommend using mindfulness to combat insecurities or imposter syndrome?
Perfect. And I'm going to sound like a broken record, by the way, folks. So as a human that has lots of insecurities, and as a human that also struggles with imposter syndrome, depending on our identity statuses and the ways we've been socialized into those identities, we may be more or less on the margins of society. And that means we often inherit a lot of internalized shame and baggage from those bigger, broader cultures. Now, that doesn't mean that folks that are quite privileged don't have insecurities. In fact, they do, because it's built into the system. But part of using mindfulness is when we notice, again, part of mindfulness is when we notice something happening for ourselves, being curious about it instead of seeing it as truth. And so when we notice when we notice a moment where we're feeling like we shouldn't be in this role, or we don't have enough education, or we're not competent enough, or somebody soon is going to find out that we don't belong here. These may be messages that folks have in their head. When we have that moment of noticing that thought is there, that's when we can notice it and be curious about it. Where did I learn that from? Because I'm guessing you didn't make it up. You learned it from somewhere else. And also being curious of how much do you buy into that belief system? So instead of buying into it, being like, what's my truth in this matter? Am I still a trainee? Am I on the journey? And therefore I don't have to be perfect. And even when we're licensed and way far along in the journey, we're never going to be perfect or know everything anyway. Are there ways that I can counter this belief that might be more self-compassionate and honest, for example? So questioning as well as being curious about. And another practice is, again, mindful redirection. When we have a critiquing thought in our minds that seems to be based more in socialization or how we've internalized our broader worlds, in that moment, we can decide to intentionally redirect away from it. I don't have to choose to listen to you right now. I'm going to go ahead and do this other thing that I find way more enjoyable. Thank you very much, mind. So we don't have to let it take rent in our minds, but we can notice it and acknowledge it and give ourselves space to contend with the feelings that come with it without buying into it. I hope that helps. That's a start anyway.
That's a great response, definitely. Audience members, please also remember that if you have any questions that come up, you can also raise your hand and ask yourself. But we have another really great question that kind of went with what you just said. How has mindfulness helped you personally? Can you share any experiences with it?
Absolutely. Kind of a broad general thing I can say about it, which is not meant to be like a promotion for mindfulness, but hey, I'm here talking to you about mindfulness, so I must believe in it in some way, right? But one thing that I have noticed in my life, in my journey with mindfulness, which is extended off and on for more than a decade, that doesn't mean that I'm perfect at it, nor does that mean that I always am in a daily practice. So I'm still a human being. But what I have learned is when the practice is regular, when it is a part of my day-to-day life, in formal and informal ways, I feel calmer. I feel like I give myself more latitude to F up, excuse my not quite swearing, although I wanted to. It also gives me a better ability to be compassionate towards myself and to others. So I notice notable differences when I'm in that regular practice. Another thing that I've learned about mindfulness, I think I'm straying from the question a bit here, but another thing I've noticed about mindfulness is that the way it plays out in my life, in my regular practice, depends at different points in my life. There's been points where it's been more associated with my physical activities. Like right now I have a really regular practice of yoga, and I practice mindfulness while I'm practicing, and I practice mindfulness in the shavasana, or the meditation afterwards. And then I work to build in little moments of pause throughout my day. So lots of informal practices. There have been other points in my life where I've had a thriving sitting meditation practice where I block out 15, 20, 45 minutes a day to meditate. And I have learned to be in acceptance of and to be grateful for whatever form mindfulness takes, because it gives me relief. Our culture tends to teach us that there's a very rigid way of doing things, and it's the more productive way. And I choose instead to let myself be where I'm at and be in flex with that practice as it takes different forms in day-to-day life. That's me anyway. Did I answer the question at all, Angela, or did I miss it?
No, I think you got it. I think the most important thing is how you've incorporated it into your life reasonably in a way that other people can go ahead and do it too. And I think that's what's important.
Yeah.
We love string answers because I feel like they answer more things that no one thought to ask.
Yeah. I think we might be at time.
We still have another 5 minutes if you'd like to go ahead.
Sure,
to
yeah,
fill the
I'm fine with that.
time. I think we could maybe have another question or two. Someone asked, would you recommend journaling or any sort of writing for mindfulness?
Absolutely. On the, I believe it's on the selfcompassion.org website. She has prompts for journaling for self-compassion, and quite, in my opinion, and I'm not an expert necessarily, I would never entertain myself to be that, but my belief is that anything can be mindfulness as long as we are present and intentionally coming back to that moment to moment experience over and over again. And part of what journaling can do, at least in my experience, because I go in and out of having a thriving journaling practice as part of my self-care. Somebody, Jacinta, did you have something to say?
No.
Okay. Hopefully I pronounced your name right. What journaling can allow us to do is it can allow us to just have a freebie moment where we just kind of write down all the stuff that's in our brains. And it can also be a moment where we do that mindful curiosity and questioning process that I talked about earlier when we try to challenge our own negative belief systems. And so journaling can very much help to augment or be its own mindfulness-based practice. Totally support that.
I love journaling. It's a great calming, it has a great calming effect on me personally, so would recommend. A little bit more of a specific question. Rana asks, I apologize if I mispronounced that, but how can I use mindfulness if it is so hard for me to calm myself? And when I try to be more chill for once, I become lazy and might stop working out or even showering and all of that.
So I'm hearing, I could be wrong. I'm not here to suggest anything about your lived experiences, Rana, but sometimes when we start to do things that are relaxing, we might notice that we back way the heck off. And what I mean by that is we might be a pendulum person. So we're either all in pushing full tilt or we're all off doing nothing. And that might suggest to us that our regular way of being, where we're going hard all the time, might be pushing us past our limits. So part of what mindfulness can do is can help us to move from a pendular kind of way of being or an all or nothing kind of way of being, and noticing where our limits are over time. So noticing when our safety signals are being thrown out by our bodies, minds, hearts, and spirits earlier in the process, so we don't have to get to full tilt overwhelmed before we back off and then we start to completely pull away from our lives. There's a book out there. I'm gonna name it wrong, but I think even if I name it wrong, you'll still find it. But Laziness Does Not Exist. It's not the right name, but it's something like that. Has a yellow and orange and pink cover.
Right on the dot.
Yeah, and the things that you're talking about that you experience when you start to give yourself a break of completely backing off and having trouble with hygiene, having trouble with taking care of your day-to-day life, sleeping all the time, those can actually be symptoms of being overworked. And so my invitation is to maybe do a little mindful study and read that book, or to take a step back from yourself and notice the ways that you might be pushing yourself into overwork instead. And mindfulness might actually help you to get there. So that's kind of gets around the question that you asked, Rana, but I hope it kind of gives you some direction.
Well, thank you, Dr. Chinsky. It looks like our time is up, but thank you so much for joining us and giving us so much information and so many good tips and exercises to end our Friday evening. Audience members, stay tuned for our last session of Volunteering Abroad, the Africa Mercy. Thank you so much.
And just a quick reminder to everyone to please fill out the poll that I just sent, and we'll be back very quickly.
Hi, everyone. Thank you so much for joining our final session of the conference, volunteering aboard the Africa Mercy. My name is Jacinta, and I'll be hosting the session. I'm excited to introduce Ruth Waln, who is joining us all the way from the UK. Graduating from the hospital in Oxford, Nurse Wong went on to specialize in orthopedics and work in the orthopedic aftercare department. Since semi-retirement, she has been using her skills to help those in countries where healthcare is limited. Today, she will be sharing more about her work on a floating hospital ship called the Africa Mercy and giving hope and healing to so many people in West Africa. Please welcome Nurse Wong.
Hello. I take it you can hear me, Jacinta. Is everything running fine? Okay, I'm going to thank you for inviting me. It's 11 o'clock at night here, so I hope I can keep you all entertained and enthusiastic about the work that we do in West Africa. So I'm going to share my screen. There will be lots of opportunities for asking questions at the end, if that's okay. So you should be able to see a picture of the Africa Mercy. Jacinta, can you put your thumb up if that's correct? Okay, that's fantastic. So this is our flagship at the moment, and it's a Christian organization, actually based in America, and it's we follow the 2,000-year-old model of Jesus, bringing hope and healing to the poor. Now, it was actually started by a couple of Americans who had a child who was severely disabled. And he realized that the care that he had in the States was really fantastic. And it came to his conclusion was that actually there were so many places all over the world that didn't have this care. So he was working with an organization called YWAM, which is Youth with a Mission. And he had this vision of seeing a white hospital ship actually being able to go to those places. And this was the first ship they had, the Anastasis, the first hospital ship. The other two were just little coastal ones that took crew to do dental work or eye work in local villages that they had access to a port. But soon the Anastasis wasn't suitable or big enough, and it was becoming quite old. So with a lot of help from donations, they bought this ship called the Dronning Ingrid from Sweden and Denmark, and it was a roll-on, roll-off railway ferry. So you can imagine this is not really suitable for a hospital ship. So they brought it over to the UK, and after many years of planning and work done on this, it was converted into what it is now, a fantastic white hospital ship. Now, this is after it's been in Gran Canaria undergoing some renovation work. Every year it has to go to Gran Canaria for either dry dock or ordinary dock. And then it goes off to a country for 10 months. And I know that because you can see on the top of the ship, on the top deck, lots of vehicles that they use to get people out to the local clinics. Now, people say to me, oh, you're going on your cruise again. Well, if you compare the Africa Mercy on the left to a cruise liner on the right, and that's not a big one, you can see the comparison in size. But the Africa Mercy is by far the more important ship there. So we go into a country, they invite us to go, and they give us dock space. And in Benin, we had a fairly big dock space, which allowed us to park the vehicles on site in the port and also have some activity areas. You can see there's some tents on the dock, which is the outpatients, the physiotherapy, the admissions, and the waiting area. And that's at the pointy end of the ship, and at the stern, it's where the maintenance is done and they load containers onto the ship and fill up with fuel. And as I say, it stays in the port for 10 months. And why do we go? We go because 2 out of 3 people lack access to surgical care. And that isn't just any old surgical care. It's the safe, affordable and timely surgery. These statistics were put up before we were hit with COVID, but it is just under 33% die from a year lack of access to safe, affordable and timely surgery, which is more than quite a few other causes as well. That equates to between 16 and 17 million people every year. And we go to West Africa. 93% of sub-Saharan Africa can't access this healthcare that they need. So we reach the people who have little or no healthcare in the poorest parts of the world. This is the area that we go to. Now, remember, I said it was a ferry, and so it's got a bit of a flat bottom, so it doesn't travel very well. It did go to Madagascar for the years when Ebola hit Guinea, but we tend to keep the work into the west coast of Africa. Now, I've been really fortunate to be able to serve in Benin, and Cameroon, which is just on the armpit of Africa. And I've also done Guinea and Senegal. When I went out to Africa, I hadn't got a clue what it was really like. And flying in over Mauritania, this is what you see. This is the Sahara Desert, and for 40 minutes, beautiful views out of the aircraft, but that is the view you see. So of course, when you land in Senegal, this is the part of Senegal which is very much still the desert. I was able to spend a weekend in the desert in a tent. I didn't go on one of these camels. I didn't feel the need to experience that. But we do experience a lot of things in the country, and we try and get to know the country and learn about it. Now compare Senegal to Cameroon, which has 6 months of rain every year. Consequently, the trees grow beautifully, the fruit grow beautifully. There's a lot of harvesting of the wood, and obviously that has some ethical problems with taking too much of the wood out of the Congo Basin. But here we've got a cocoa plantation, and you can see it's really lush. And that is so different to Senegal. So we try and find out while we're there as much as we can about the country, because this helps us to treat the patients with an understanding. Now I've put these pictures up, which is an area in Benin called Ouida. Now they collected 14 million people up from Africa to get them on the slave trade ships. And they all came to Ouida. Only 11 million went from Ouida. And this is what was called the gate of no return, i.e. the people were walked through that area and they did never return. Now, the significance of going from Benin is that it's the main country which has voodoo, and I will talk a bit about that later. But knowing what happens in that country helps you to understand what's going on with the patients. So also, this was on a small safari I went to, but they have a lot of traditions. And in this area, they had some skulls in the bottom of a baobab tree. And these are storytellers, and they don't have written language, or they didn't have written language. So the history of the country was passed down by storytellers, and they were held in great esteem, and the skulls are still visible in this tree. I think they were about 400 years old. It's a very vibrant country, and you can see really colourful motorbikes in Benin and Cameroon were very colourful and looked to me to be quite dangerous. But you can see there the roads not bad in the cities and the towns, but actually go into the rural areas, and you can see why we need the all-terrain vehicles for getting the training and the clinicians out to hospitals in those areas. Very resourceful population, where the builders have to be able to make their own bricks first before they can do it. Their skills in carving and basket weaving is phenomenal. So the Mercy Ships has a 5-year engagement plan. And the first year, we don't just go in and say, this is what we're going to do. They invite us. And so that first year, it's signing off on protocol and planning what they're going to do. So they have to agree to give us port space and a certain services. The phase 2, or the second year, we advertise within the country. They go to clinics, radio stations, and say that we are coming. And the country will know at this stage what we can do to help them. The phase 3 is when we are actually in the country. So all the work that has been done in the previous year culminates in us getting the right patients in at the right time for the right doctors to treat them. A lot of training is done during that time with the local clinicians. And phase 4 is that we carry on with that training and support, and people will go out to clinics to check that things that have been put into that area are still being used correctly and they've got the support they need. And then the last year, it's a report to the World Health Organization and the Lancet, so that what we've actually achieved for that country is published. We partner with the nations. We want to transform the lives of the individuals, but really importantly, we want to leave a legacy of improved healthcare. On the ship, we have visitors coming from the Parliament. We have the President comes, usually the Minister of Health. Everything stops, and we all hide because it's only people in really posh uniforms, and we just get on with our work. But it's fun to see them arriving in their state cars. But these people, they don't pay anything. Everything for these people is free. And I will show a 2-minute video at the end, and you can see queues of people waiting to be seen. And in Guinea, we had 6,000 people all turn up on one day to be seen, to see whether we could actually help them. So during that time, we had the teams of people go out and actually look at patients and work out which ones we can actually help. It's really quite a tight criteria. And out of those 6,000, we had quite a lot that were not going to need any care from us. But a lot of them were. And for something like this child with bow legs, definitely a case that we could deal with. So I work as a plaster technician and a nurse. So I'm split between the physiotherapy department and the operating room. Now here you can see, this is our huge team of physiotherapists, occupational therapists, all specialized in, most of these were orthopedic, but some of them were on plastic. So they were hand physios as well. And we have day crew that work with us. So we can actually give them employment. We pay just above the basic rate, but they learn, and they are very important for us because they learn, they teach us how to care for their people. They learn skills and they translate for us. And although a lot of these countries are French speakers, in the case of Senegal, it was Wolof, and although we have a go at learning that, it's really good to have Senegalese people actually talking to their own people, and they get a skill from that as well. And this is the operating room team, and I put this one up because actually we are all from different countries all over the world, with the tall chap in the middle who is from Senegal, and he worked with us for 8 weeks, learning the skills of doing surgery on the children. And it was a German doctor who was teaching him at this on this day. So in Senegal, this is the ship. It was very dusty. Obviously, we had the dust coming in from the Sahara, but also we always seemed to be moored fairly near a cement works as well. So it did get a bit dusty. If you are able to see at the bow end of the ship, there is a container ship, and I will show you a close-up picture of that. In the inside of our ship, we have 5 operating theatres. One of them is eyes, one is, when I'm there, it's orthopedics. It switches between orthopedics and plastics. One is general surgery, and the others are maxillary facial, which is what our ship is renowned for. Total of 82 ward beds. Now, if you're building a new hospital in the UK, recommended 11 foot between the beds. Obviously, we can't do that. And the beds are really close together. And for me, plastering these children or doing anything with their plasters between the beds is quite difficult. But not only are they in the beds, their carer is under the bed or sleeping on a mattress. So the wards get very hot and very chaotic, very untidy, but great fun. We have a radiology department with a CT scanner, obviously not an MRI because that's we're on a metal ship, so that wouldn't work. We have a laboratory, and Darlene here is from the States, and she's been running it, and her specialty is doing the blood transfusion, because a lot of these patients come in and they need blood at the time or subsequently, and where are you going to get blood from in Africa? Well, it's the first thing we do when we get to the ship is actually agree that they can take our blood. So it's a real honor to give blood and actually then see the patient that has received it. So a little bit of me is still in Senegal. But they do all the other things that are normally happen in a hospital, which is blood tests, swabs, specimens, or lots of complicated stuff. Pharmacy, brilliant. They seem to have the right drugs for the whole time that we're in the country. Obviously, we know a good idea of what we're going to use, but they are superb at providing us with the right drugs. So these are the things that we will do on the ship: maxillary facial, plastic surgery, orthopedics, yeah, that's mine, obstetric fistula, so women who have given birth to a baby who has been stuck for some time results in having a hole develop between the vagina, uterus, rectum. And some of these have had incontinence, total incontinence, for up to 20 years. So to be able to treat them is an absolute honor. And I was able to discharge very many of them when I was working as a nurse. And that was absolutely wonderful. A bit of general surgery, depending on what the country wants, eyes, dental, and palliative care. We don't do any surgery on known cancers. It is on, if we find somebody who has got an inoperable tumor or something, and they are nearing the end, some people will go out and give them the drugs that they need. I'm going to put up a few graphic images of some of the patients. So I told you about Guinea when 6,000 people all turned up. We were expecting about 200 of those to be cleft lip and palate children, babies' children, but there were only 6. And the reason was the previous time that the ship had been in Guinea, they had taught some local doctors how to do the surgery. These doctors had gone on to open a clinic and were then able to do the children as and when they needed it. In Guinea, we saw some that came from a long distance away, but we didn't see the amount that we would normally see. Unfortunately, this little boy turned up in Cameroon The ship arrived and the mother brought this child, and you can see he's 3 months old. He weighed less than he did at birth, and he was not surviving. He had his mother was only able to give him some rusk in some water. Not fit for surgery because he was very, very poor state. So the infant feeding team got to work on him and made him put on large quantities of weight. So after 3 months, this is what he looked like, and he was fit enough then to have surgery. We developed a relationship with the mother, and she was so delighted with her baby. She was able to take him back to her village and present him as, look at my beautiful boy. We do see a lot of burns, and people in Africa don't know how to treat burns. In a child who falls into a fire or gets severely burnt, they would just wrap them up in a blanket. Consequently, the skin will contract. So this little girl got burnt at a year, and she had no movement in her elbows, her wrists, or her fingers. A lot of these patients will hide. They can't go to school. They are laughed at. But she had surgery. Now, we can't get rid of scars, but we can release the tendons and the ligaments and put skin grafts on to give them movement. And this then means that they are able to go to school and be able to have employment and get married, which the schooling for them is really important. She was delighted. Now, orthopedics. This is the sort of operations that we do. You can see on the left that the bones look particularly bent. We only have one opportunity to go in and break one bone and plaster it. And then we leave it up to the body to straighten up the other bits. So we have a little child here called Djimbi, who had come just over 100 miles with her grandmother to the ship. She was in constant pain, had cried a lot because she was unable to walk or walk particularly well. She came with such great expectations, and this is me. This is the only one you've got of me. Well, no, I think there's another one, but ready to take her plasters off. And she was a lovely little girl. And for the time that she was with us, she was an absolute delight. You can see there her grandmother looking on and so happy to be able to go home walking with straight legs and not in any pain. We do an awful lot of eyes, and it's usually, well, mostly it's cataracts. And for this girl, she became pregnant and she lost her sight. And she thought that when she had her baby, that she would be able to see again. But she had twins and she certainly wasn't able to see again. But the ship came to the country soon after she had the children, and she had surgery and she was able to see her children for the first time. So not only did this give her life, it gave life to her children who would not be burdened with actually taking her around and looking after her. We do also do the children as well, cataracts, and these three children, actually their mother had surgery when the ship was in Madagascar for the same condition. She then went on to have these three children who all developed or had pediatric cataracts, and they had surgery and were able to then be able to see and delight in being able to see and go to school as well. Now, this little child was in Benin, and you can imagine if you have a child that looks like this in a country where voodoo is the religion, you can imagine what they think about this lump on his head. This child was shunned. You can see the fear and horror in his eyes. You can see that his mother didn't really want anything to do with him. And of course, the parents and the family were ostracized within their village. All he had was, when you start as a tiny 2-3 week old fetus, you sort of start flat and then you develop into a round, and that's where the problem comes with cleft lip and palate. And for this is an encephalocele. The bones just don't meet up in the middle. He had surgery, and you can see there that the delight in his mother's face as he is restored to a normal looking child who was then going to be accepted into the village. Give a man a fish and he'll eat for a day, and teach him to fish and he'll eat for a lifetime. Very much our thinking. Outside the orthopedic ward, I saw the day crew, and they were giving the children breakfast, and we give them, the orthopedic children, we feed them up really well, because it is basically very poor nutrition that has developed these conditions. And they were drinking black coffee because that is what they were weaned on. So as soon as they came off the breast, as babies, they would have black coffee. I said to a mother one day, what do you give your child for breakfast? Oh, they had rice. And for lunch, yes, rice. And in the evening, oh, they'd had rice again. So these children were not hungry, but they were so malnourished. Now that's the ship that was moored very close to us. And every 14 days, we got another one in. And this ship unloaded 32,000 tons of rice to Senegal. Every 14 days, a new one would come. I was able to go on the ship. Not that you would see it on TripAdvisor, but really interesting to be able to go on a ship and see just how it worked, and have some fun with each other. Now, diet and food is really important, but how do you get a country to improve the way they farm? And we have a lovely man called Eliphas, comes from Benin, and he started a agricultural program where he takes about 50 students for 32 weeks, teaches them how to farm. The middle one at the bottom is they built a hydroponics unit for growing tomatoes and also keeping fish, and consequently they were able to, this is just made up with things that they can get in their normal in the village. It's fairly simple to set up. Now these students then go on to teach others how, and other farmers, how to improve their things they grow, from the mushrooms to the cows. Sometimes they have rabbits, and you can see there at the top, that one is in Senegal. Trying to grow anything in Senegal was really difficult, and they did manage with companion planting. That was their first crop of pumpkin or some something that they grew. But that is really important if we can improve the vegetation. So along with that, and what we are known for, is the training and mentoring local professionals, and providing medical tools and resources, and building better medical facilities. And you can see there, this is an area that we need somewhere for the people to come to the ship, for them to stay. And we will convert a building and houses about 200 people, and then it is given back to the country afterwards, where they will use it as an A&E department or maternity or something on the health side. We want to make things better for them. I did go to a local hospital after a lot of work. This is a couple of plaster technicians, and I said I would go and help them and do a day's training. That was the equipment that they had on the left, which actually was the only equipment for the A&E department, the outpatients, and theatre. And they did have an electric saw, but just one hand saw. And I planned to do a day's training for these two, plus I had a translator with me. And I ended up with 12 people, which was really good. In Madagascar, to have a surgery or theatre like this, 50% chance of dying. So they renovated 5 to look like that, putting in the equipment and the training for those, the equipment. In Guinea, We discovered that the local dentists were coming out of their training university without having any practical skills. So one of the floors was taken over by Mercy Ships, and the clinics, rather than being in the villages and the city, we had it at the university, and the patients were seen there, and students and the professors and the teachers were taught how to do things. And this equipment on the right is an X-ray machine that picks up problems in the mouth before it becomes acute. And the things that they're looking for that causes most of the problems is a tumor that starts from the tooth enamel, they think, called ameloblastoma. So these are two photos off the internet, or two X-rays, and you can see there's a gap in the person's jaw at the top. And what we do is we will take that out, put in a metal plate, and then 3 months later go back in and put a bone graft. Consequently, this is the sort of thing that is very common on the ship. And this girl was operated on, and she went on to become a nurse in the Republic of Congo. So she had a life. And you can see that the tumor, it's sticking out a long way, but also it goes in. So they're not cancerous, but they will kill because you are neither able to breathe or to eat. So to have a face which doesn't make you turn and look and be stared at gives her hope and just a life. You can see there we have volunteers from all over the world. We do have quite a lot from the United States, I must say. It is our biggest source of volunteers. And we have a lot of volunteers annually, and from 40 different countries. We pay our own crew fees and we pay our travel, but only half of them are medical. So we are a team. There are so many people that we need on the ship. We couldn't do it without the housekeepers or the dining room staff or the caterers. It is so important. And obviously being on a ship, we have the maritime as well. So you can see there a lot of things that go on the ship, from the maintenance of the Land Rovers to scuba diving to change the filters under the ship, and teaching as well. Our Gurkhas are our security, and they are lovely. In Senegal, we did have an impact. Unfortunately, we had to pull out early due to COVID. And unfortunately, we've not been able to go back, and we are waiting to go back to Senegal to finish the work that was started. But we have a new ship called the Global Mercy. It's bigger, it's better, it's got a lot more teaching and conference space. These are the sort of tumours we see. We can't change the whole world, but we can change the whole world for the individuals, one life at a time. You can go onto the Mercy Ships website. You can look on Vimeo Mercy Ships. You can see a lot of videos all about the patients that we see. And it is amazing to actually follow a patient through and to be able to see the hope and the joy in their eyes as they actually are restored to full health. So together we work for these people in Africa that don't have anything. We need volunteers. We've now got 2 ships. Could you do it after you've been trained? Do you know somebody who can? Can you get involved? I'm going to now share let's stop share for a minute. I'm going to now put a video on, and which is only 2 minutes, which I think you'll find interesting. Sorry. Bother. I forgot to screen share. And now I have come out of there. I'm sorry. I've just closed it down. How awkward. That's it. Open. Ah. I want to screen share. Screen share. Right. Let's minimize that. I don't know now whether I'm on screen share. Oh gosh, I'm sorry.
Hi Ruth, it's okay. Are you able to click that button at the bottom that says share screen?
I'm just gonna put that on full. I've now lost me.
If you want to
hang on, I should no, because I've lost myself. Have I come out of Zoom?
We can see you.
But you can't see the video, can you?
No, but it's okay. Would you like to email me the video and I can share it from my end?
But I've only got you tiny. All I've got is your pre-health care one now. How do I get back out of that? I've sort of lost Zoom. Have I lost Zoom?
If you'd like to, well, we can see you. So as long as you can hear us, we can still do the Q&A.
Yeah, okay, let's do the Q&A.
Okay, perfect. And if after this session today, feel free to send us your video. We would be happy to email it to all of our attendees and include it on our website as well.
Okay.
Okay, Angela, or Jacinta, sorry, go ahead.
Thank you so much for that presentation. I'm sure I really enjoyed that presentation and many of our audience members have as well. One question we have is, would you be able to volunteer for a short period of time, for example, as a college student during the summer?
Yes, now the Africa Mercy tends to break during the summer. The Global Mercy will be on, which is the new one, which will be on a different time schedule. They like loads of people to volunteer. You can volunteer from 2 weeks up to 3 months or full time. It does cost quite a bit the first time you go. For me, it became fairly addictive. Once you've been once, you can't, it's very much then you want to go back. You see such a change in people. It's a real delight to see countries that you wouldn't see normally. And it's just so delightful to be able to treat these patients, play with them, get to know them, and also the day crew that you work with. So yes, you know, we need people like housekeeping. They don't take any trainees. Actually, if you're physio or occupational therapy or a doctor, you need to actually be qualified. But there are so many jobs on the ship. But certainly when people are qualified, yes, anything from 2 weeks up to 5 years or 10 years, whatever. Somebody's been on there 20 years. So, you know, it is addictive.
Great, thank you. Someone else was wondering, how do you sign up to volunteer and whether you take lab professionals?
If you go onto the Mercy Ship's website, all the jobs are there, whether you want to be the captain, first officer, electrician, right down to a nurse, all the jobs are there and when the vacancies are. Now, obviously with COVID, we don't know quite what is happening with the ships. Hopefully the Africa Mercy will go back to Senegal and the Global Mercy will join the Africa Mercy there because they need to move quite a lot of stuff across. Then the Africa Mercy will go down to South Africa for some refitting. And once that is done, then we will have the 2 ships in service. But COVID at the moment, I'm afraid Africa are not getting vaccines in, and so many people, they don't know the statistics, but I think only 5% of the population in West Africa has been vaccinated.
Well, thank you for that answer. Someone else was wondering, what are the costs of volunteering?
If you're coming from somewhere like the UK or France, Germany, the States, the first time you go, it does work out probably I can't compute it into dollars, but for me, I suppose it was about 500, maybe. I think it was something like £800 for my 6 weeks that I was there. That is your crew fees. Then, of course, you've got your flight out there. You need all your vaccinations from the yellow fever and all the ones that they require. So it is the first time you go, it is quite expensive, but each time you go, the crew fees go down. So I have been out for 6 weeks as a nurse, 8 weeks as a nurse, 3 months as a nurse and plaster technician, and as another 3 months as a nurse and plaster technician in Senegal. So it gets cheaper each time. And you'll find that people actually want to help with the crew fees. And they will donate to you or do crowdfunding, or people want to support the work, but if they have a personal attachment to you, you'll find that people will help towards the crew fees.
That's amazing. Thank you. Yes, someone in the chat mentioned that their cousin worked on the ship for a year and it was the best experience of her life there, working there.
Yeah, it's a fantastic experience. It's lovely to see the country. It's lovely. I've been and seen places that I never even dreamt that I would see. To go on a cocoa plantation and actually break the cocoa pods open, and actually brought some home and fermented my own cocoa beans. But to go on a ship, in the port, to go and see waterfalls that have and places that in history you've only ever read about, and the UNESCO sites as well. I haven't seen any elephants. I've seen giraffes and zebras and a few other things, and I've eaten rotting pine caterpillars. Yeah, it's great. It really is lovely, and for me, it did become addictive, and I can't wait to go back out. We'll have to just see.
I can see why. That sounds amazing. What do you think is your favorite experience working on the African Mercy?
Well, the first time I went, I worked a whole shift, a whole day, and if actually they work you quite hard. And then I had to file some patients' notes at the end. And I went, I think I was still doing it at 11 o'clock at night. And because I'd broken, there was something I had to do in the middle of the evening. And then I went back and somebody said, "Are you all right?" And I said, "I don't think I ever want to set foot on this ship again." For me, I think the experience of discharging ladies who had been incontinent for years and years, and being able to discharge them as people who could not dribble urine for whole, wherever they go, they have become social outcasts, and to be able to explain to them why it happened, and see them go with this huge smile on their face, that is an absolute delight. And it is wonderful to see children walking with straight legs, to see their faces change from absolute horror to realizing that they can run, they can play football, they're not going to be looked at. They've got a place in society. Sitting at a table, they can eat with other people and not go around with cloths over their faces, fearing that they're going to die, which is what would happen. And of course, with no health care and no social services, with no chance of employment, they were deemed to be unemployable and would spend their time begging. And that's sad when you see conditions of people on the streets. You see them with legs that are bowed or bent the wrong way or knock-kneed, and they can't walk, and they're just sat on the side, just waiting for somebody to give them some food or money or something, because they have nothing. So, yeah, I mean, every country has been totally different, and I have thoroughly enjoyed my time on the ship. Yes, it's got its stresses. We all work in different ways, and working with Americans and Dutch and Swiss and French. English, thankfully, is the language spoken. And we all have different ways of doing things. And it's actually being a team together to get the patient healed.
Thank you. That was an amazing answer. We actually have a question about teamwork. How would you consider the environment of teamwork on the ship? Do you think anyone from any background can assimilate and feel supported?
Yes. Some countries work better with each other than others. But it's really important that you see that everybody has something to offer. It's very easy to think that the housekeeper who's sweeping those stairs, and I can tell you there's an awful lot of stairs, and the swimming pool on the top deck on the Africa Mercy, from the cabin that I had the first year was down on deck 2, which is way below the waterline. It was 100 steps from my cabin up to the swimming pool. And if you forget your goggles, you're never going to go back down to get them. And but people are cleaning the stairs, cleaning the corridors, and it's very easy to walk past them and just think, oh, they're just a cleaner. But without that cleanliness on the ship, we're going to get infections. And actually, if you talk to these people, we had one lovely lady, and she was a barrister in the States, and she would come and clean the corridors because that's what she felt was something that she could do. We had lots of people. Everybody has something to offer and to give, and we couldn't do what we do without everybody working together. Yes, we have chaplains that support us and talk to the patients, and it's good time. Obviously, you don't get on with everybody, and you are sharing a cabin, so the chances of being in a cabin with somebody you don't get on with does happen occasionally, but you can move. It's most times it's really, really good. But we're all stressed, we all work hard, and we all have fun together. And we all go out for meals together and just enjoy each other's company and working together. The X-ray people, the physios, the OTs, the day crew. It's wonderful.
Great, thank you. It's wonderful to see everyone come together to do some meaningful work.
Yeah.
Another question that we have is, did you have to sacrifice anything to be able to do the work you do on the Africa Mercy?
The time I found more difficult was the first time I went to Guinea, and I was there for 3 months, and it was over Christmas. So I am married, I have a husband, I have to leave him at home, and I have children and I have grandchildren, and to go away for 3 months over Christmas and leave the family, that's hard. It's hard for my husband, and it was hard for the children as well. in Senegal, we did break over the week of Christmas, and actually somebody paid for my flight home, and I came home for the Christmas for 10 days. I actually wasn't very well, but that's different. I'd picked up some bug while I was out there. Yeah, it is, and it's tiring, and I come back and I'm absolutely exhausted. And you realize that you've lived in a cabin, you've had very little clothes to wear, and you realize you don't need all the clutter that you have at home. And you can see the back of my study, and I won't turn the screen around because it is all clutter. And I just, every time I come back, I think, no, I don't need that. I don't need that, you know, and I try and slim it all down, but it all builds up again. So do I miss something? Yes, the family, obviously. But with Zoom and the first time I went, my 3-year-old granddaughter, now children are very used to Zooms and FaceTime. But my daughter showed her, and I WhatsApped her, and I went, "Hello, Zoe." And there was this look of horror. How did grandma get in there? You know, she'd only seen me a few days earlier, and there I was in the phone. She was horrified, but you know, technology moves on, doesn't it? And she's quite used to it now.
Well, thank you for making all the sacrifices that you do. We have a question about some of the cataract cases that you mentioned. This is what they asked. They said they were curious about the cataract cases that you shared, especially because they were such young patients. Are they sporadic cases, or are cataracts really prevalent in the area that you served? What was the cause for the cataracts on those children?
Some of them are congenital, which you get you'd get them in the States and in this country as well. And some is just I think it's the sun that probably causes it. But you get older and people have cataracts. And I'm sure in the States they get operated on fairly quickly. When it first starts to become, your vision becomes a bit blurred. Whereas there, the vision becomes blurred and you become blind. With a child, they will operate on both eyes. With an adult, they will only do one eye, because you can get more people through by doing one eye, and most people can manage on just one eye. But for them to see, to take the patches off at 2 days, and for them to be able to see for the first time is truly amazing and joyful for them. Yeah. But ophthalmics is not my field. I can talk at length about orthopedics. Eyes, a little bit. I've watched a cataract operation and amazed at the instruments that they use, which are so tiny compared to the orthopedic ones, which are huge. Yeah.
Amazing, thank you. Someone was wondering, does anyone decide to work on the ship full time, and are there any paid positions?
The only paid positions are the Gurkhas, because they are our security, and they do 3 months on and 3 months off, and are paid for doing that. And there's 8 of them. Unfortunately, one went back to Nepal, and as you know, COVID swept through Nepal, and he has not survived. He went back because his family were ill, and unfortunately he's died. Those are the only paid people. We don't get off the ship or onto the ship without swiping a card. At all times, we need to know exactly who is on the ship in the event of fire safety. So every 2 weeks we have a fire drill, and we all have to go out onto the dock and be counted up. The people in theatre, also the OR, or on the wards stay, but they're counted. In the event of an actual fire, there are ways of getting them out, but we don't do that in a general fire drill. And in the when the ship is under sail, some countries, there's a lot of problems with pirates, and sometimes the Navy will escort the ship past, so Nigeria, for example. But the Gurkhas are very concerned with safety and pirates when the ship is underway. So they're the security there. They did have a stowaway from one country. Two chaps got on and actually hid in the lifeboat. But of course, that was a real problem because the ship then had to turn round, have to go back to, I think they were 2 days out of the country, and I can't remember where it was, but they had to turn round. I think they were fined because you can't have stowaways, so they had to return to the country, and you can imagine the amount of fuel it took for 4 or 5 days extra sailing. But these stowaways were the best fed stowaways probably in history and looked after once they found them.
Great, thank you for that response. Unfortunately, that's all the time we have today for this session, but thank you so much for that presentation. It was amazing to hear about your experiences and the different cases and the people you treated. So thank you so much for speaking at this conference.
Okay, well, I will send you the WeTransfer email that I got, which you should be able to send out as well, and people can download. And I'm sorry, and I've lost the screen.
No worries at all. Thank you so much. And thank you everyone for attending the session and attending the conference. Please stay tuned for the closing statement from our co-founders in a few minutes.
Thank you.
All right, thank you so much, Jacinta and Ruth. It was very great hearing your presentation. Now we have reached the end of the second annual National Pre-Health Conference. So thank you to everyone for attending our sessions, and we hope that you were able to learn a lot about healthcare careers, and hopefully you feel more confident on your journey towards becoming a healthcare professional, because that was the goal behind the whole event. So just wanted to say that we're very proud of you already, and we can't wait to see the awesome things that you do in the future. And hopefully you stay connected with MPHC so that we can keep being updated with what all of you guys are up to. So at this point, we have a few announcements to make before we conclude our conference. So MPHC's co-founder, Alexia, is gonna go ahead and share her screen.
Hi, everybody. If you haven't met me already, I'm Alexia, and I am the co-founder and co-president alongside Alejandra at the National Pre-Health Conference. Alejandra, I'm going to get started with the slides. Is that right? Okay, perfect. First of all, we would love to give a big, big thank you to all of our team members listed on this slide. There were quite a lot of members from all over the United States who came together to help us plan this National Pre-Health Conference this year. We'd actually reached out to them last fall after the first annual conference. We sent out an entire leadership application, and all of these students today, since January, have been helping us plan this 3-day event. And Alejandra, I just cannot believe that it is over, that we have already concluded our second annual conference. However, our leadership team will be back for next year, 2022, so stay tuned.
Yes, definitely. We could not have done this without the help of our team. So thank you so much. Maybe there are some of you watching, but we'll thank you in person whenever we meet. And secondly, we want to thank our sponsors for their support in helping us promote the conference and also providing some free resources. As we have been bringing up a lot of the times, we have some resources from BMO and from Kaplan that we will be sending out on the chat later. But all of these awesome organizations were supporting us throughout this whole semester that we planned MPHC in the summer. So we're very grateful that they helped us reach all of you, and that some of them were able to meet you during the Zoom tabling sessions. And we didn't have a slide for this, but I also wanted to thank all of our speakers who volunteered their time to come to our conference and who shared their words of wisdom with all of us. So it's very great that we had such an amazing turnout of students and that we were able to provide them with great speaker presentations. And also, it's also not included on the slides, but I also want to thank our advisory board and mentors that have been supporting us throughout the creation of MPHC. Some of them are watching this right now. So thank you so much for all your support and for really being there whenever we have questions and whenever we need to hear your advice. We appreciate it a lot.
Before we end the conference, I want to give one last announcement that our wonderful digital design team had created a t-shirt finally for this year's conference. And if you would like to purchase a t-shirt, go ahead and go to that link on our website under MPHC 2021 and then under merch. You'll be taken to the custom ink group order form. And just an announcement, this group order form will close on August 20th. So you should receive the delivery of these t-shirts about 2 to 3 weeks after August 20th. Thank you so much for your support.
Awesome. And as I mentioned before, we have this awesome scholarship that will be awarded to one lucky MPHC student. So if you're studying for the MCAT, or if you have any friends who are taking the MCAT soon, or really if you just want to have an MCAT course and start getting ready for this, wherever you are in your pre-med journey, we encourage you to fill out the link that we will send in the chat ASAP, because the form would close. Actually, I think it closes at 10 p.m. They just updated the form, but it closes tomorrow. So I wouldn't wait too long because you might forget. So I would really recommend filling it out ASAP, and it's valued at $2,499 US. So it's very expensive, and we're gonna be providing it for free to one of you guys. So we really recommend that you fill out the form.
We also have another free resource from BMO. And this form, correct me if I'm wrong, Alejandra, should be open for quite a long time. So you have some time to go on this form and fill it out to get your free access to incredible free resources from BMO. And go ahead and click that link in the chat. We will also send out an email after the conference today with links to both BMO and Kaplan free resources.
Awesome. And we also want to remind everyone to check out our program guide. We know that the conference is concluding right now, but if you want to look back at the awesome guest speakers that we had, if you want to learn more about MPHC or the team behind MPHC, feel free to check it out. And also just as a reminder that you attended the conference, as a nice souvenir, feel free to download it or keep it wherever you want. It'll be on our website anyway, so just remember you can access it at any point.
And another great announcement, if you have skills in event planning, or you also have experience on social media, marketing, anything related to conference planning, I would love to see your application this fall. Our applications usually go out every fall. It'll depend on the month. Alejandra and I still have to decide for next year. But we'd love for you to join us if you have these skills to plan the 2022 National Pre-Health Conference. So stay tuned in your email inbox for more details.
Next, we have the Research Expo Virtual Gallery. We encourage all of you to check it out. And we will also be announcing the Research Expo winners from the live event that we had. So stay tuned for that and check out their virtual gallery at our website, nationalprehealthconf.org. Go to the MPHC 2021 tab, and under that, you should see another tab that says Research Expo.
All right, so the most exciting part, I believe, of our closing statement is we are now announcing the winners of our Research Expo Awards. Yesterday on day 2, we had several students from all over the country present their phenomenal and innovative research. And now we have 3 awards to give out.
1, based on your favorite, and then 2, based on our team's reviews of best presentation, who spoke well and was able to convey their message the best. And then most innovative, which project was most interesting and most worthwhile to our society and community. So to get us started with our first award, audience's favorite goes to Animal Surper and Manu San. Thank you so much for participating. We can give a little round of applause. I know it's a little muted in the attendees, but feel free to say congratulations in the chat. Up next for best presentation, we have Alexander Yu. Thank you so much for presenting. Your research was phenomenal. And feel free, everybody, to check out their research projects on our website too. And then lastly, for most innovative, we have Amesh Sarecha. Thank you so much for joining. Your presentation was awesome. And these are our 3 groups of winners. After today, you will receive a certificate of the award listed. Thank you so much for participating.
Awesome, congrats everyone. And now we have a very big announcement to make. So as you guys know, so far, NPHC has been called National Pre-Health Conference. However, we have now been officially incorporated as an LLC, and we're on our way towards becoming an official nonprofit in the future. So for this reason, we have changed our name to National Pre-Health Community to make it more encompassing of the different events and things that we will have in the future. So we also encourage you to fill out the survey that we will send out at the end of this session, because we really want to hear your feedback and hear about any initiatives that you think we should incorporate in our organization as a future nonprofit. So we're very excited about this, and we will be changing our social media to this new name, and our website. Everything will be updated in the next couple of days and weeks, but we're very excited about this and can't wait to hear your feedback about future initiatives such as mentoring programs, blogs, even in-person events, if we're able to have some funding from different grants that we will be looking to apply to. So just thank you everyone for being part of our community. And as I emphasized in the opening statement, we really would like for all of us to stay connected as much as possible throughout the year. And so this is kind of the sign that we want to create a pre-health community that meets both virtually and hopefully in person in the future. So thank you so much to everyone. And as I mentioned before, don't hesitate to reach out if there's anything that we can help with. I know we have already received a lot of emails from students reaching out to speakers and asking questions to us. And we apologize if we haven't replied yet. It's been a long 3 days, I'm sure for everyone, but we will be checking those emails constantly and answering them very soon. But thank you to everyone for being part of our new community.
And the best way to stay connected is by following us on social media, especially connecting to our Discord. Feel free to connect on all 5 of these platforms. On Discord, type that URL in your browser and it should allow you to be invited to the Discord. I personally will be posting resources all throughout the next academic year until next year's conference to help you stay connected within the community.
Now, here we are at the end of the conference. And as we mentioned, we will be sending out the feedback survey. I think if someone, Lexi, would you be able to send it in the chat? I think I put it in slides. But as I mentioned before, it will take about 3 minutes. You will also receive it once you close out of the webinar, once you leave the webinar. But please take your time to fill it out and be as honest as possible so that we can really learn from you and what you want to see in the future and what you liked and didn't like from the conference so that we can fix it next year. And other than that, we also had Lexi surveys that she's using for her ASU honors thesis. So we're very grateful for all of you who are participating in the surveys. And you should have already filled out the pre-conference survey. So if you didn't, don't worry about this one. But if you filled out the pre-conference survey, you'll be hearing out more about the post-conference survey. in the next couple of days. So thank you to everyone. And I also appreciate everyone for filling out my annoying polls throughout the conference. Hopefully you listen to that, but we're getting a lot of great feedback that we hope to use to implement in future events.
I agree. Our goal is to help you thrive in your future career. And with that said, that concludes the 2021 National Pre-Health Conference. Thank you so much for participating, and please take the feedback survey after exiting the conference.
Awesome. Just give me 1 second. I'm gonna put it in the chat just so that everyone can start filling it out. But there it is, the long-awaited survey. And you also have access to it if you close out of the webinar. But for now, I put it there. Thank you so much to everyone. Thank you to our team. Thank you to the students who made this possible. And thank you to all of our MPHC community people.
Thank you. Bye. Have a great weekend.
Bye. See you, everyone.